the meeting today. We welcome you to the Cancer Management course Clinical Practice Guidelines. And without further ado, we would like to start today's meeting by a message by Mr. Bhomi Bhot, who's the CEO of Ruby Hall Clinic.
14 years ago, we conducted our first course on cancer management, and we were very, very enthusiastic with the kind of response that we got. Ruby Hall has got a completely integrated cancer center, having all the kind of technology, equipment, and doctors and consultants all under one roof. As you are aware, we have an integrated cancer center building, having the OPDs, IPDs, the operation theaters, the auditorium, linear accelerator. We are one of the only hospitals having 4 linear accelerators. We have a digital mammography machine called the Pristina, which was the first of its kind that came into this country. We have the digital SPEC CT, again, which was the first of its kind that came into the country supplied by GE. And we have the digital SPEC CT and the digital PET CT, both of them together in our new facility. Indeed, extremely glad to know that there are already over 750 participants who have enrolled for this course, and they expect 1,000 plus to enroll. I'm sure with the kind of people, knowledge, data that we have got, all of you are going to benefit a lot. There will be a lot of learning. There will be a lot of debating. There will be a lot of interaction with our consultants during this program. This is the first time that this program will be conducted online, and I'm sure all of you are going to benefit tremendously out of it. I wish the program the best, the very best, and I'm sure you will all come out winners at the end of the day. Thank you very much, and all the best for the conference.
Thank you so much, sir, for your kind words. We next have Dr. Manisha Karmarkar, who is the COO of Ruby Hall, to share a message with all the delegates over here.
Good morning, dear friends and colleagues. It gives me immense pleasure to welcome you all to this 14th Cancer Management course on behalf of a Ruby Hall Clinic Parivar. Ruby Hall Clinic was established way back in 1959. The Cancer Center at our institution was established in 2006. It is since 2006 that we have been successfully running the Cancer Management course till date. Since 2006, the Cancer Center here at Ruby Hall Clinic has grown by leaps and bounds under the able leadership of our 2 dynamic leaders, Mr. Bhomi Bhot, our Group CEO, and Dr. Ashok Bhange, the Chairman of the Center. The main concept behind having these cancer management course is to bridge the gap between the family physician and our hospital. According to me, and I think according to many others, the family physician is the most trusted person to the patient as well as the family. So if there is a good coordination between the physician and the institution, I think we can give the patient a better care. I welcome all of you as being a part of the Ruby Hall Clinic family, and I wish all the delegates and the faculty members all the very best. Thank you.
Thank you so much, ma'am, for your kind words, and we apologize for the slight technical difficulties. Next, we have Dr. Ashok Bhange, who's the chairman of the Cancer Center and the head of the Neurosurgery Department, to share a few words and to begin his talk on Introduction to Cancer Center and Management of Brain Tumors.
Hello, friends. When we started this project almost 15 years ago, we were really not expecting it to be so successful or to make it into one of the finest cancer treatment facilities in this country. When we started, our main mentor has always been in Ruby Hall Clinic was late Dr. K.B. Grant. He insisted each and every department in this hospital had the most modern equipment. In fact, there's an episode I can relate to is when we were negotiating with the Electa group for buying the new linear accelerator. The European chairman said, when Dr. Grant asked him, is this the latest? He said, no, this is not the latest. The latest is image-guided radiotherapy. But I don't think India is ready for that because it has still not been launched in even in Japan. It was nowhere in Asia was it existing, and he thought it was too early for India. And that really stimulated Dr. K.B. Grant, who turned around and told us, I want IGRT. And that's how we stepped into this, and that's how it went step by step. Dr. Parvez Grant now, with his enthusiasm and constant encouragement, has been a source of encouragement, a source of inspiration for us. That's Dr. Grant with the Cobalt machine. In fact, we started radiation treatment for cancer in the late 70s with this Cobalt unit, which was in fact the first one in this part of the country. And then, like I related the incidents to you, we went on with the first two Siemens Encore machines which were equipped with image-guided radiotherapy. At that time, image-guided radiotherapy, forget about in India, was not available in the entire Asia. So we were first in the country to have image-guided radiotherapy. And what's really image-guided radiotherapy? As you see from the diagram, you have the tumor, we have other normal organs. And then the tumor is encapsulating the normal organs, and the organs are in motion. Now with image-guided radiotherapy and add to it respiratory gating, we are able to deliver a very high dose of radiation very accurately to the tumor without affecting the surrounding tissues, even when the normal tissues are moving. And that is what is achieved in image-guided radiotherapy with respiratory gating. And then recently, after having two machines and having functioned with two machines for 15 years, we added two more machines, the TrueBeam STX from Varian, and followed it within 6 months with the Halcyon machine. And frankly, this TrueBeam STX machine is the finest of its kind in the world. It not only treats all treatments to the best, but also does it very fast. For example, now we are able to do trigeminal neuralgias with this machine equipped with cones. And so there are a lot of applications which can be done. And plus, for example, with the Halcyon, we are able to finish the treatment within 5 minutes, which is extremely comfortable for the patient, increases the turnover, it makes it very, very comfortable for the patient. And this is the new concept of stereotactic body radiotherapy. See, imagine somebody who has a cancer or a malignant growth and has to come to the hospital for almost 40 to 45 days to get fractionated radiotherapy. It's not only tiresome for the patient, it's also very inconvenient and tiring to the relatives to get the patient every day for almost 6 weeks. And imagine somebody who has, unfortunately, a very limited period of life. Almost 2 months of that you are spending in giving radiation therapy. What does stereotactic body radiotherapy mean? That means with the new machine that we have, the entire dose that is necessary is given at one go. So your radiation treatment is over within a single session or within 5 sessions. Extremely convenient for the patient, extremely convenient for the relatives, and as effective as a longer treatment. Now the world authority on stereotactic body radiotherapy is Dr. Carlo Greco from Lisbon, who came recently, joined us, he worked with us, he educated us, he guided us about stereotactic body radiotherapy. So now any tumor in the body, in fact at his Lisbon center, each and every malignant tumor, maybe head, neck, or maybe in the lung, or maybe in the uterus, are treated with a single session of radiation, and which is as effective as any other radiation. There he is giving a lecture and guiding us. And add to it the stereotactic radiosurgery and radiotherapy, which we have been doing with excellent results over the last 15 years. What does it mean? It again means the same thing. A large amount of radiation being given very accurately in one session is called stereotactic radiosurgery. Sometimes in 5 sessions is called stereotactic radiotherapy. And these are the results. You can see it on this screen where you have a tumor over there which over the next 3 years has gradually shrunken to a fraction of its size. This is an acoustic nerve tumor which arises from the nerve which gives you hearing, and at the end of the treatment the hearing too is saved. The same thing here, an acoustic nerve tumor, we start the treatment and within a few years it not only stops growing but also starts shrinking and gradually disappears. Here's a tumor which this in fact is an optic nerve meningioma. You can see the eyeballs and the optic nerves, and this small tumor is sitting on the optic nerve. But even with this small size, we are able to treat it with stereotactic radiosurgery. Here is the arteriovenous malformation. That's a large one that you see, which within 3 years has totally disappeared. And this previously used to be treated with very complicated surgery. Now without surgery, with stereotactic radiosurgery, you get excellent results and the AVMs disappear within 3 years. Excellent results we'll be having over the last 15 years. Over the last 15 years, we have almost treated 1,500 patients of various types, benign tumors, malignant tumors, arteriovenous malformations. We've had very good results. Here's a tumor, this is called a glioblastoma, which after the first radiation treatment and concurrent chemotherapy has recurred after 6 months, and these are small residual or recurrent tumors which can be treated with stereotactic radiosurgery. Over the last 15 years, it's not only the equipment, but we have been very, very fortunate to have excellent people working with us. Dr. Sanjay Deshmukh and Dr. Sujay Hegde, for example. Right from day one, we've been having very good oncosurgeons who have been specializing in certain parts of the body. For example, Dr. Sanjay Deshmukh with head and neck and with lung lesions, and Dr. Sujay Hegde over the last 15 years has been doing exceptional surgery in gastroenterological malignancies. Dr. Sadanand Karandikar, our senior most chemotherapist. In fact, he was the first one to start medical oncology as a specialty in Pune. He continues to do exemplary work in Ruby Hall Cancer Center. And Minish Jain, our backbone in medical oncology. He has been doing exceptional medical oncology treatment over the last 15 years. And our team radiation oncology with the TrueBeam STX machine, each and every one has been doing exceptional work in their own field. When we started radiation oncology department, it was a late president, Mr. Abdul Kalam, who came for the inauguration. Here he is being welcomed by Dr. Sumit Basu and by Mr. Bomi Bhot. And this was the first year that we started a cancer management course. This is, in fact, I was giving the certificate to one of the participants, and you can make out what difference 15 years have made to me also. And I give credit to Dr. Sujay Hegde and now Dr. Zhade for, apart from 1 year, we've been able to conduct this course for the last 15 years. That takes a lot of perseverance, that takes a lot of dedication, and I'm thankful to the doctors as well as the marketing team for making it a success. We have also been associated with our other activities. For example, we were associated with King's 11 Punjab, and one of the members who visited our center went around the wards, interacted with the patients and the relatives, was the recent star Akshar Patel, who was a part of King's 11 Punjab at that time. We have been doing good work academically also. For example, a couple of years ago, we had conducted a teaching course on behalf of the ISRO school, which is the European Radiation Oncology Society. And now in the month of June, we plan to have the Astro annual meeting, which again is an American radiation oncology learning meet. And it's going to be really a big thing academically for the Cancer Center to be conducting it. And over the last 15 years, yes, we have done a lot of good work, occasional criticisms, but as Sachin Tendulkar said, we use the brickbats thrown at us as milestones. Thank you.
Thank you so much, sir, for sharing us the updates about the Cancer Center. Now we would begin with the first session, which is on general oncology, and it is chaired by Dr. Sujay Hegde. Our first lecture is by Dr. Shailesh Nayak, who is a consultant surgical oncologist.
Good morning, everyone. The topic allotted to me is basic principle and biology of cancer. One of the first emotions of a patient undergoes is that of fear of impending pain, suffering, and untimely death. We all understand that it is a terrifying disease which takes a toll physically, emotionally, and financially. It is also a complex problem for healthcare workers because of lack of proper infrastructure across the entire nation. What does cancer mean to you? We all understand it is an uncontrolled growth of abnormal cells with poor prognosis. It is a disease where cells grow out of control, they invade, erode, and destroy normal tissue. It is like any other normal cell, however, it has its own characteristics and does not follow the principles which other normal cells follow. Coming to the problem, cancer is the second leading cause of death before the age of 70. There were approximately 18 million cases and 9 million deaths as per Globocon 2018, and more than half of these were in Asian countries. The main types of cancers, mainly I am talking of solid cancers, are lung, breast, stomach, liver, and colorectal. More than 50% of all cancer deaths occurred in middle and low income countries, which is expected. Deaths from cancer worldwide are projected to continue to rise to over 11 million by the year 2030. It can affect all people of all nationalities and age groups. So, cancer is universal and no one is spared. Coming to the worldwide incidence of cancer. Here is a global map which presents the national ranking of cancer as a cause of death below the age of 70 years in the year 2015. As we can make out, India has got a high mortality rate compared to the West and Australia. If we divide it between the males and females, we can make out that most of the Indians suffer from lip and oral cavity, which is the head and neck cancers, as compared to the prostate in America and other lung in China. However, when it comes to cancer in women, it is more or less breast cancer across the whole world. If you look at the estimated age standardized incidence and mortality rate, there is a huge discrepancy between patients in the high and very high HDI versus the low and medium HDI. We can make out the incidence is quite high of lung cancer, prostate, and colorectal among the high and very high HDI countries compared to that of low and medium HDI. However, the mortality is also very high among the low and medium HDI countries. Similarly, in estimated age standardized incidence and mortality rate, we can make out that in women, breast cancer is very common among the high and very high HDI countries compared to the other countries. However, the mortality because of breast cancer is similar in both the arms. Cervix is more common in the low and medium HDI as compared to the high and very high HDI. Also, the mortality is quite high. However, we have seen a recent trend of decrease in number of cancer cervix. This has been mostly attributed to better hygiene in the last few years. So, what is cancer? Is it a one single disease? No, it's a heterogeneous group of disease, and it spares no organs. We see that we have lung cancer, breast cancer in women and men, and colon, bladder, prostate. Some of the sarcomas which are seen from the mesenchymal cells are in fat, bone, and muscles. The leukemias and lymphomas are part of the hemopoietic system of the body. People often think of the word cancer as describing a single disease with a single cause. It is not the case. There are over 200 different types and subtypes of cancer that can occur anywhere in the body. Coming to the causes of cancer, we can broadly divide it into the external factors and the internal factors. Coming to external factors, they can be physical, chemical, and biological carcinogens. One of the most important carcinogen which we see commonly here is tobacco. Tobacco is grade 1 carcinogen, and it is the major leading cause of cancer in most nations, particularly in head and neck cancers and of lung cancers. The attributing factor is tobacco. Diet also plays a role. Infections, gender, some diseases, some cancers are more common in women and some are more common in men. Occupation also has a role to play. Sun and radiation also can cause cancer, particularly skin cancers. Then the others are like pollution, medicine, and food additives all contribute to cancer. 80 to 1 lakh people die because of tobacco-related death per day. Coming to infections, we know the Epstein-Barr virus, human papilloma virus, hepatitis B virus, Kaposi sarcoma is caused by hepatitis herpes virus, also CA stomach. One of the causative factors is Helicobacter pylori. Coming to internal factors, hereditary can affect many types of cancer. We see retinoblastoma and skin cancers like xeroderma pigmentosum, Wilms tumor of kidney, also colorectal are more common in patients with FAP. Coming to occupational carcinogens, we know that there are a lot of chemicals and which are used in various industries, and these can cause the various types of cancers. The commonest being arsenic, which is common in mining, pesticide workers, which can cause lung cancer, skin cancer, as well as liver cancer. Asbestos, we know, with the construction workers exposed to, can cause CA lung and mesotheliomas. So what exactly is cancer? All normal body cells, they grow, divide, and die in an orderly fashion, and cell death, programmed cell death, is known as apoptosis. However, cancer cells are different because they do not die. They just continue to grow and divide in a disorderly fashion. Cancers also develop because of a complicated interaction between the genes, the environment, and a chance factor. Breaking down to a cellular level, so we all know that this is a normal cell which does undergo various changes, and they can be DNA damaging agents like chemicals, radiation, viruses, and other environmental factors which can cause DNA changes. However, this damage is repaired by a pathway in our body. When this fails, then the mutations of the genome of somatic cells can result in activation of growth promoting oncogenes, alterations of genes that regulate apoptosis, and inactivation of cancer suppressor genes. Together or individually, they can cause expression of altered gene products and loss of regulatory gene products. Clonal expansion, additional mutations, and heterogeneity all then lead to a malignant neoplasm of that organ. So we have two types of genes. One is the protective genes, which are tumor suppressor genes, and the other one is oncogene, which is a proto-oncogene, which causes activation of certain changes which can lead to cancer. So whenever the tumor suppressor genes are absent or inactivated, that can cause differentiation leading to cancer, whereas in the proto-oncogene genes, the activation of these genes causes changes in proliferation and apoptosis leading to cancer. What are the hallmarks of a cancer cell? Sustaining proliferative signaling, evading growth suppressors, it resists cell death, it enables replicative immortality. Then angiogenesis. When a tumor cell or a group of tumor cells increase to a size of about 1 cubic centimeter, they require their own blood supply, and this is possible because of angiogenesis. Then there is reprogramming of energy metabolism. Then they evade the normal immune destruction by the host body. It also activates invasion and leading to metastasis. So this is a busy chart which actually shows us various factors which can lead to cancer at a cellular level. For example, evading growth suppressors, avoiding immune destruction, enabling replicative immortality, tumor promoting inflammation, activating invasion and metastasis, inducing angiogenesis, genome instability and mutation, resistance of cell death, deregulating cellular energetics, and sustaining proliferative signaling. Today, we have various drugs which target this specifically. Like we have cyclin-dependent kinase inhibitors which attack or which selectively block these growth suppressors. Similarly, we have inhibitors of VEGF signaling which stop angiogenesis, hence stop the blood supply to the tumor and then causing cell death or tumor death. Similarly, PARP inhibitors which block the genome instability and mutation and then help us in controlling malignancies. So we see there's a transformation and then there's angiogenesis wherein the cells, the tumor gets its own blood supply. Then there's motility and invasion wherein some of the tumor cells break away from the parent tumor and then they invade the capillaries, and through the capillaries they are carried, or through the lymphatics they are carried to different organs. They may then anchor themselves into a different host organ like the lung or the liver. They adhere to it by certain methods, by like an anchor, and then they develop their own blood supply over there and grow in size. These are nothing but metastasis. So if I have to make it very short, we have normal benign cell or tumor. Here we have cells which grow only locally and they cannot spread by invasion or metastasis. And then we have the malignant or cancer cells which not only invade the neighboring cells, they also enter blood vessels and metastasize to different sites. So how do you diagnose a malignancy? First and foremost, the gold standard of diagnosis of any cancer is a biopsy. So here the patient's tissue sample or the blood sample is taken, this is processed and examined under microscope using various techniques. And then there's also a genomic profile which is available today, which helps to establish the diagnosis of the malignancy. The crux of the whole talk is to make you aware that early and proper diagnosis of cancer helps in better survival. Hence, it's our prerogative to pick up disease at an early stage, which can actually, when they are in curative phase. So this is very important because as the disease advances, it becomes more and more challenging to control the disease. Thank you so much.
Thank you so much, sir, for your talk on basic principle and biology of cancer. Now we have the floor open to questions. If anyone has any questions, they can kindly ask it to Dr. Shailesh, who has joined us for the talk right now. If anyone has any questions for Shailesh sir, you can kindly ask it right now.
Hello, Dr. Rao, am I audible?
Yes, sir, you're audible.
Okay. If there are no more questions, I think we can progress or go on to the next presentation.
All right, sir. So next we have Dr. Vidya Chandra Gandhi, who is a consultant general surgeon and in GI surgery, and he would be talking on prevention and screening of cancer. Over to you, sir.
It's quite an important Hello and good morning everyone. I am Dr. Vidya Chandra Gandhi. I am a gastrointestinal surgeon. I practice at Ruby Hall Clinic here at Pune. So my topic is about prevention and screening of malignancies. It's quite an important topic because we can to a certain extent prevent a malignancy by proper screening methods and identifying certain high risk individuals who are at high risk of development for malignancy. So these are the different malignancies which I would be dealing with during my presentation. These are there are other malignancies as well where screening and prevention can be done, but since the presentation and I have to speak only for 12 to 15 minutes, the most important are breast, cervix, ovary and certain GI cancers. So if you look at certain carcinogens and risk factors which are associated for development of malignancies, these are the general ones, with the cigarette smoking almost associated with almost all malignancies as a high risk factor. Then there are certain infectious viruses which are associated with development of malignancies, like Epstein-Barr virus, which is associated with Burkitt's lymphoma. H. pylori is an infective microorganism which is associated with development of gastric malignancies. HPV for cervical malignancies, C. cervix. And then there are certain malignancies which are associated with radiation, with history of radiation in the past. Now, there have been a lot of literature and data to prevent the development of malignancy by using certain micronutrients like beta carotene and folic acid, vitamins, calciums, vitamin E, selenium, but there is no substantial evidence to say that use of these would help to prevent a particular malignancy. Smoking, as I said, is a most important and a high risk factor for development of almost all malignancies. So cessation of smoking, and WHO has given a guideline of a 5A questionnaire to a patient. Ask the patient about whether he is using a tobacco, advised every tobacco user to quit it, assess the willingness of the patient to quit, assess the patient's for quitting it through counseling and pharmacotherapy, and arrange a follow-up cessation support, preferably within the first week after the quit date. So these are the 5A for smoking cessation. And then there are treatment strategies which are been put across by the WHO for cessation of tobaccos. Now to start with, the most important malignancy is the breast cancer. It's important to know about the risk factors for the development of a breast cancer before going to its prevention and the screening programs. So for a patient, the risk factors are, one is gender, so there are certain modifiable in sense ki controllable risk factors, and there are certain uncontrollable risk factors. So controllable risk factors are nulliparous woman, giving birth at age primary after the age of 30 years, not breastfeeding, using of hormonal therapy, having bad eating habits, and using of hormonal therapy, birth control methods, obesity, lack of exercise. So all these are the factors which are controllable risk factors which can be modified, which can be modified, and thus can decrease the incidence of breast cancer. There are certain uncontrollable risk factors which are early menarche, genetic factors, late menopause, exposure to radiation. So these are uncontrollable risk factors. Age, elderly patients. So these are uncontrollable risk factors. So there are screening recommendations which have been put forward, especially for an average risk patients who average risk means who do not have previous history of malignancy, or who do not have a family history of malignancy, who do not have a previous history of benign breast disease. So these are the average routine patients. So the screening mammography is recommended, which should start at the age of 45 years, and is recommended every yearly. So women should undergo regular screening mammography, should start at the age of 45 years. Women aged between 45 to 55 should be screened annually. Women should have the opportunity to begin annual screening between the age of 40 and 44 years. When to stop the screening is also important. Women should continue the mammography as long as their overall health is good and they will have a life expectancy of 10 years. So it should continue almost after the year of I would say of around 75 years. So then there are certain high risk group of patients whom apart from screening, these are the patients who would actually benefit from some certain risk reducing procedures, which I will come through it. So who are these patients? Who have a strong family history of breast cancer, who have a genetic mutation, which is BRCA mutation, who have a history of radiation in the childhood, who have more than 20% lifetime risk of developing breast cancer defined by a risk assessment model. So there have been several studies which have been done to identify certain genes which would help to increase or to identify the patients who are at actually risk of developing particular malignancies. And this genetic studies or this particular genes, especially the BRCA1 and BRCA2 genes, are important because this genetic, if there is a genetic mutations which are seen in this in particular patients in these genes, these patients are at high risk of developing familial cancers, especially breast, ovary, cervix, endometrium, and also colorectal cancers. So it's important to know certain genes, not all of them, but at least certain genes, because this now genetic factors have come in a big way. A lot of studies have been done. There are genetic labs now across the city. So it's for a particular physician or a surgeon, it's important to identify this group of patients, especially those high risk patients who have a strong family history or a background of history of malignancy, so that a genetic panel can be done and a particular patients can be sent for genetic studies. So what are the options in these patients with high risk, who are this high risk? I mean, who are BRCA1 positive or BRCA2 positive. So in this you have 2-3 options. One is you can keep them on surveillance, where the MRI or mammography should be started at the age of 30 years. For an average risk, you start at the age of 45 years. In a high risk patients, you start at the age of 30 years. Or you can keep them on chemo prevention, where you start tamoxifen 20 milligram per day. Or the third option is you ask them for, you can opt them for risk reduction surgery. That means a prophylactic surgery is done, or a prophylactic mastectomy is done to avoid the risk of malignancy in the near future. It's an invasive option, a risk reduction surgery, but yes, definitely it would decrease the chance of developing or would avoid the chance of developing a malignancy. So for a breast cancer patient, if they are BRCA1 or BRCA2 positive, you can offer this option. It's either a simple mastectomy or skin sparing mastectomy or a nipple sparing mastectomy. When do you do it? So this the recommendation is it should be completed as close to the completion of a childbearing age as possible, in order to provide the greatest lifetime risk reduction. So usually typically it's recommended at the age of around 30 to 35 years. Next malignancy is ovary. So ovarian, again, it's one of the commonest malignancy which is seen in the females. Now we see a lot of young patients who come up with abdominal masses. Often typically they are ovarian pelvic masses. So again, there are, in these patients you have the most important risk factor is age, and the second and the second most important risk factor is the family history. If a particular female has a family history of ovarian cancer, then this particular female has a very high chance of developing an ovarian cancer in herself. So the moment you see a patient with with a strong family history of ovarian cancer, he or she should be put under screening or surveillance, or should be offered risk reduction surgery. So there are other possible risk factors like age, elderly patients, early age of menarche or late age of menopause, but these are again are not modifiable risk factors. Obesity, sedentary lifestyle, poor dietary habits, cigarette smoking, again these are all risk factors for developing ovarian cancer. So in asymptomatic patients, routine screening is not recommended, especially who asymptomatic means who are average risk, who are average patients who do not have family history, and do not have any symptoms, no routine screening is not recommended. But in high risk patients, then a screening with CA125 and transvaginal ultrasound is recommended. And this is the chart actually which helps us to guide the screening recommendations and the treatment offered to patients with carcinoma of ovary. So if there is a family history of hereditary cancer syndrome, the risk of development of ovarian cancer is around 15 to 50%. So this patients can be offered risk reduction surgery, especially when there is mutation which is seen in a BRCA1 gene and BRCA2 gene. This patient should be offered a prophylactic bilateral salpingo-oophorectomy. Bilateral salpingo-oophorectomy is recommended in women who carry BRCA1 or BRCA2 mutations because of the high mortality rate of ovarian or fallopian tube cancers and the lack of effective screening methods and preventive approaches. The next malignancy is CA cervix. Almost it is the most common malignancy which is seen in Indian females. There have been screening guidelines over a period of time. There are Indian screening guidelines have been also come, which have been put forward by the Foxy and other groups which have come out with guidelines for carcinoma of cervix. Now screening should typically start at the age of 30 to 35 years. Now there are several screening modalities which are there for carcinoma of the cervix, but since this malignancy is again seen commonly in a poor socioeconomic group, often in rural area or in rural India we don't have these facilities to screen these females. So visual inspection and assessment, so VIA, which is called, like visual inspection, inspect the cervix, and visual inspection, and with an acetic acid you see that area. So the chance of picking up these cervical cancers are high. So typically the screening starts at the age of at around 30-35 years, and the should be continued almost to the age of around 60 to 65 years. Commonest virus which has been identified is human papilloma virus, this is HPV, and there have been data which is coming up which to decrease the chance of development of CA cervix by giving vaccination. So HPV vaccination, human papilloma vaccination, HPV vaccine is available, and the vaccine should be given at the age of around 10 to 12 years before menarche. 3 doses should be given at 0, 2 and 6 months with a quadrivalent vaccine, and 3 doses of 0, 1 and 6 months with a bivalent vaccine. There is no need for booster doses. Colorectal cancer, there is a lot of data which has come from US and UK for to prevention and screening of colorectal malignancies, to identify the patients who are at risk of developing colorectal cancers. There are certain risk factors like dietary risk factors, again alcohol, high fat, low fiber, low selenium, low calcium, or less fruits, less vegetables. All these dietary factors can increase the risk of development of colorectal cancer. Presence of inflammatory bowel disease like ulcerative colitis, Crohn's disease, presence of polyps, all these are risk factors of development of colorectal cancers. Familial hereditary cancers, hereditary colorectal cancers are also seen in around the incidence are around 1 to 5%, and a particular and we as a physicians and surgeons should be aware about this adenomatous or familial syndromes. So how do we prevent colorectal cancer? Is having good diet, decrease the fat, particularly animal fat, increase the consumption of fruits and vegetables, do exercise regularly, avoid smoking. Regarding the low dose of aspirin, there is evidence for it. Aspirin would actually decrease the incidence of polyps and decrease the incidence of colorectal cancer, but the dose particularly for this is actually quite high, is around 600 milligram per day. So there is a data which has come that it is associated with 20 to 40% reduction in the risk of colorectal adenomas and colorectal cancer in individuals who are at average risk. So potential benefit of long-term therapy should be weighed against the potential adverse effects also. And the dose is around 600 milligram per day. So in making recommendations regarding aspirin, its benefit for the prevention of coronary artery disease in those at increased risk also need to be considered. So this it's important for us to know about familial colorectal syndromes. These are the adenomatous syndromes like familial adenomatous polyposis, HNPCC or Lynch syndrome, and there are several of these, Peutz-Jeghers and juvenile, and several of these. So the most important of these are the FAP, that is familial adenomatous polyposis, and hereditary non-polyposis colonic syndrome. So these two important polyposis syndrome should be known to the physicians and the surgeons, because there are around 2 to 3% of the patients who walk in to the OPD with a colonoscopy report of polyps all over the colon. The reason why we should know about this syndrome is especially familial FAP is associated with 100% development of malignancy at the age of 35 to 40 years. So prophylactic total proctocolectomy should be advised in patients with familial adenomatous polyposis. So it's important to pick up these patients to prevent the development of malignancy. So screening guidelines for colorectal cancer have been there, and there are several guidelines, but these are the commonest which are followed. So for average risk individuals and high risk individuals, it is different. For average risk individuals, so those are the individuals where who do not have history of colorectal cancer malignancy, do not have family history, who are naive patients, who do not have any previous history of colonic polyps and etc. So in these individuals, the screening should start at the age of 50 years. And these are the several methods you can do the screening. It is OR basically. So you can either do a fecal occult blood test every yearly, or you can do a flexible sigmoidoscopy every 5 years, or you can do a flexible colonoscopy every 10 years. So either of these can be followed, and by doing this you can, it is shown that by doing this in an average risk individual, the chances of picking up lesions are high, and actually decreases the incidence of colorectal cancer. It decreases the mortality as well. Now high risk individuals, these are the individuals who have previous history of excision of colorectal adenoma, which can be less than 1 centimeter, which can be more than 1 centimeter, who have a previous history of ulcerative colitis, who have a previous history of Crohn's disease. So these are the individuals where a colonoscopy should be started a little earlier, especially in patients with ulcerative colitis and or Crohn's disease. The colonoscopy should be the surveillance colonoscopy should be started at the age of around 8 to 10 years from the onset of the disease. So it's important because these are all risk factors of developing colorectal cancer. Patients with familial adenomatous polyps, the screening should start at the age of 21 years, and even the same is in hereditary HNPCC or Lynch syndrome, this hereditary non-polyposis colonic cancer. The screening should start at the age of 21 years, and it should be done yearly. Here the recommendation is yearly, where in average risk individuals the colonoscopy recommendation is at every 10 years. It's not only about doing it yearly, because these patients with FAP or HNPCC are at high risk of developing other malignancies like ovarian malignancies, cervical malignancies, endometrial, pancreatic, gastric malignancies. So screening for those malignancies is also recommended along with colonoscopy. So it's important to identify this high risk group of individuals. Esophageal cancer, pancreatic cancer, there are no evidence-based guidelines for screening for these malignancies. Gallbladder cancer, there is no rule for prophylactic cholecystectomy. So you don't remove the gallbladder laparoscopically, although it's an easy procedure, just to avoid or decrease the incidence of gallbladder cancer. So there is no recommendation as for now. Gastric cancer, there are recommendations for screening, but predominantly it's in Japanese and the Korean population, because there the incidence of gastric cancer is quite high. So there they routinely do an apogee endoscopy at a particular, which starts at a particular age. But for an Indian scenario, we do not recommend screening for gastric cancer. But of course, what you can do to prevent them, because most of this malignancy, these gastric cancers we see often are at advanced age. Either they have disease which has spread, they come with ascites or parental deposits or etc. So how do we prevent them? H. pylori has a great association. H. pylori is found to have a great association between for the development of gastric cancer. So diet. So how do you prevent development of gastric cancer? You can either eradicate by doing an anti-H. pylori therapy. You can have good diet, which is rich in fruits and vegetables, decrease intake of salts, decrease intake of smoked food, decrease intake of red meat, decrease alcohol intake. So all this can be done to prevent the development of gastric cancer. Screening endoscopy can be done, but it's not in the guideline, especially in high risk individuals who have pernicious anemia or atrophic gastritis, or who have previous history of partial gastrectomy. So those or patients with familial adenomatous polyposis or HNPCs, which I said, for when you do a colonoscopy in this group of patients, apogee endoscopy is also recommended, because this group of patients are at risk of developing malignancies, other malignancies also. There is entity called as hereditary gastric cancer, which is seen in around 10% of the patients, and this is a criteria to identify this group of patients with hereditary gastric cancer, and there the endoscopy should be started at early age. These group of patients can be recommended prophylactic gastrectomy, but again we don't see this group of patients that commonly. So plus these are the group of patients which are typically younger patients, where we see the malignancy, gastric malignancy at the age of 25 to 30 years. So you can pick up these patients if there is a strong family history of gastric cancer, then yes, or you have a strong family history of other colon or rectal cancers, then yes, this group of patients can be sent for genetic screening, and they can be kept under screening. They can be kept under apogee endoscopy screening, and which would help to pick up the malignancies earlier. Prophylactic, yes, gastrectomy can be recommended in this group of patients, especially where the mutations are seen in CDH1 gene. HCC, it's another malignancy which has where the screening has been recommended, because this malignancy is associated with cirrhosis, hepatitis B virus and hepatitis C virus, and alcohol. So to cut short, if we have in cirrhotic patients which is related to hep B or hep C or alcohol, you should recommend an ultrasound and alpha fetoprotein AFP level every 6 monthly. If an ultrasound or AFP is raised more than 400, if an ultrasound shows any lesion, you can either do a good contrast enhanced CT scan at the same time, or an MR, or MR would be better. MRI, contrast MRI would help to pick up those lesions, so that these patients can be subjected to particular treatment. So cirrhotic patients, screening is recommended. In non-cirrhotic patients, especially patients with non-alcoholic fatty liver disease, non-alcoholic steatohepatitis, patients with obesity, patients with previous history of alcohol, but they are non-cirrhotic. So these patients also ultrasound and AFP is recommended at an interval of 6 months. How do we prevent HBV related HCC? As a primary prophylaxis for HCC, HBV vaccination is available in infants and should be implemented in all the countries, especially in HBV endemic areas. As secondary prophylaxis for HCC development, effective and potential long-term antiviral therapy should be started in all patients with chronic HBV infection and acute liver disease. How do you prevent HCV related HCC? In chronic HCV infections, patients who obtain sustained virological response have considerably reduce risk of HCC. So the moment HCV related HCCs, if you see patients with hepatitis C virus, you try to give them antiviral therapy and try to have a sustained response. So to conclude, cancer prevention and screening can prevent many cancers and detect precancerous lesions at an early stage to decrease the morbidity and mortality. Developing an appropriate cancer screening and if appropriate preventive plan should be a part of routine preventive cancer care medicine. Cancer prevention strategies are available for the women who have BRCA1 and BRCA2 mutations or other high risk features. Thank you.
Thank you so much, sir. Now we have the floor open for questions to Dr. Gandhi. Anybody who has any doubts or any questions can ask right now. Dr. Gandhi is with us.
Hello.
So we have a question on the chat here. Is how common in terms of incidence is development of colorectal cancer in patients with irritable bowel syndrome with normal colonoscopy findings and also have a family history of carcinoma colon?
See, irritable bowel syndrome is a completely different entity. Irritable bowel syndrome is not a risk factor for development of colorectal cancer. That is one thing. It's very clear. Okay. IBS is completely different. It's a benign thing. There is no evidence or there is no 0% incidence of development in any colorectal cancer. Those are not the high risk individuals. People who have a personal history of colon cancer or people who have personal history of previous colonic polyps. Yes, these are the patients who are at risk of developing colon cancer. So for that, which I had mentioned in my slides, screening is recommended as mentioned. For an average risk, means if there is no previous history of colon cancer, in that individual screening should start at the age of around 50 years. And for a high risk, which I have already mentioned, that which are the high risk previous past history, personal history of colonic polyps and all, there the screening should start earlier. But IBS and colon cancer, no relation.
We have another question, sir. What is the mean age at which we should ask a woman or a man to undergo a screening, which includes an all-inclusive approach towards most common life-threatening cancers?
Okay, so basically, see, truly speaking, I mean, all these colorectal cancer guidelines and all these are predominantly guidelines which have come from US and UK. Indian screening guidelines, age guidelines for at least colorectal cancer, pancreatic, or I would say GI malignancies are not there till now. But having said that, for a colorectal cancer, I would recommend that screening typically starts at the age of 50 years. What you can do is at least you can do a colonoscopy once in 10 years. That's a fairly, 10 years is it's a decade. So once in 10 years, a colonoscopy should be good enough, at least for colonoscopy. Upper GI endoscopy for gastric cancer and all, it is actually not required because it's too much. I mean, we do see patients of gastric cancer, but it is not that very common in India as compared to this Japanese or Korean countries. But colorectal cancer we do see quite commonly. So I would recommend at least there you start earlier.
There's another question, sir. Is chemotherapy okay if it is done with half the dose but repeatedly?
No. Chemotherapy half the dose repeatedly is not this thing. You have to take the proper dose as suggested by the medical oncologist. I think so. Dr. Karandikar is there on platform. He would be the right person to answer it. But half baked is not recommended. You have to take the complete dose. What is recommended? Repeatedly half the dose is not the answer.
Thank you, sir. We'll wait for just another minute for any other questions from the participants.
Sure.
I guess that's it, sir. Thank you so much, sir, for joining us and giving us this lecture.
Thank
Next,
you.
we have Dr. Mansi Munshi, who is a radiation oncologist, and she'll be talking about cancer genetics.
Hello everyone and welcome to the cancer management course. My name is Dr. Mansi Munshi and I am a radiation oncologist here at Ruby Hall Clinic. Although I am a radiation oncologist, I have a passion for hereditary cancer and genetic counseling, and over the last few years I have developed a cancer genetic clinic over here. And today I will be talking to you a little bit about cancer genetics and hereditary cancers. So whenever there is any case of malignancy or cancer, there is always this word genetic which comes into the picture. And one thing right at the offset I would like to explain is that every cancer is genetic. So every cancer has a genetic basis, but whether this genetic basis of the cancer beginning is hereditary or is it sporadic, that is the question. So while most of the cancers are sporadic, which means that they occur by chance and they occur because of maybe some identifiable carcinogens like tobacco and oral cancers, or say smoking and lung cancer, most of the cancers happen because of some random genetic event which is sporadic. About 15 to 20% of all cases, there is a hereditary cause, which means that there may be some defect in the inheritable genes of the patient, which has led to this cancer from occurring. Now, most of these genes which lead to hereditary cancer syndromes are autosomal dominant. Now, there is autosomal dominant and autosomal recessive. Autosomal dominant conditions are those in which a single faulty copy of the gene is necessary for the person to have the syndrome, and therefore it gets passed on from one generation to the next with a 50% probability, which means that if you have an affected parent and it has no gender selection, so it can be passed on from a father to a daughter or a mother to a son, and the parent passes on to 50% probability to each child. Now, this does not mean that if the couple has 4 children, 2 of them will have the syndrome and 2 will not. That's not what it means. It means that each offspring has a 50% chance. So you may have a situation where all the children have the syndrome, you may have that and all of them don't, none of them have it, and there is no real way to predict who has it, and not depending on looks, personality or any other phenotypic features. It has to be confirmed via a genetic test. So most of these syndromes that today I will talk to you about do get inherited in an autosomal dominant fashion. A small number of them are autosomal recessive, which means that both copies of the gene need to be defective for the syndrome to happen, and these are much rarer and most commonly seen in consanguineous marriages where the both couple have a particular defective gene, and in those children there would be a 25% for each of the children to be affected. So having said that, the most common syndromes that one would come across in the clinic is the hereditary breast ovarian cancer syndrome and the Lynch syndrome, or the HNPCC, the hereditary colorectal cancers which one sees. So these are the 2 most common syndromes which you would see, and of course there are a bunch of rare syndromes which I will also touch upon today. So let's talk a little bit about hereditary breast ovarian cancer syndrome. Breast cancer as such is the most common cancer amongst women now, even in India, and 1 in 8 women, we know the statistics, and it is extremely common. There are a number of hypotheses for why breast cancer has become so common, maybe lifestyle, hormones, PCOD, infertility, IVF. There are many hypotheses, but today let's talk about the hereditary concept. And the first question which pops into the mind of the patient is, why did it happen? So why did I get cancer? Is it something I ate? Is it stress? And they have number of various ways to blame themselves. But there are risk factors which you can control, and there are risk factors which you cannot control. So let's talk about genetic. A couple of years ago, the BRCA gene became extremely popular because of Angelina Jolie, a Hollywood film actress who she did not have cancer herself, but she had a strong family history of breast and ovarian cancers in the family. She did the genetic testing and turned out that she was positive for the BRCA gene. BRCA gene, there is a BRCA1 and BRCA2. There are two different genes which are responsible for controlling and preventing breast and ovarian cancer. These genes are good. They are present in men and women, and their job is to prevent breast and ovarian cancer. But if there is a defect in one of the two copies of BRCA1 or BRCA2, then these women have about a 70 to 80% lifetime risk of getting breast cancer, the risk of which starts at the age of about 22 and increases as the woman gets older, and about a 40% risk of getting ovarian cancer in her lifetime, the risk age of which starts at about 35 to 40, depending on whether it is BRCA1 or BRCA2. Now, this gene, of course, can be passed on to the male children as well, and men have a much lesser risk of getting breast cancer in the tune of about 7 to 8%, and also very small risk, but a little higher than normal risk of getting prostate cancer. What's more important is that men, although they don't have a very high personal risk of getting cancer, they can pass it on, the gene, to the next generation, to the women with a 50% probability. So evaluating for the defect in BRCA gene is important in both men and women. The BRCA defects do not cause childhood cancers. So we generally do genetic counseling and testing only for adults. So a little bit about a case that I can present of a HBOC. So there was a 34-year-old lady who had a very strong family history of breast and ovarian cancers in the family, and she had a lump in the breast for the last few months, and this was an early stage breast cancer with negative nodes and found out to be malignant, and a triple negative type of breast cancer. So most of the BRCA1 related breast cancers do end up being triple negative. So, when you have a case like this, it always raises a red flag. A young girl at 34, premenopausal, strong family history, and a triple negative breast cancer. So everything is pointing towards hereditary. Some of the other red flags which should come up in your mind when you see a case like this is a bilateral breast cancer. So very often the ones which are related to hereditary syndromes may have bilateral breast cancers which come at the same time, or it may be first in one breast and after a few years in the other breast. So young age, family history of not just breast cancers but ovarian cancers and any other malignancies in the family, a bilateral breast cancer, or any case of ovarian cancer should raise this red flag in the mind. So this lady, when we see a new case in the genetic clinic, we make a pedigree chart to look at the family history in up to 3 generations, and so you can see that this is the patient, and from her she had some sporadic cancers from the father's side, but there were breast and ovarian cancers from the mother's side. Now, this was a young girl. She had an early stage, so she underwent a direct surgery with adjuvant chemotherapy and then came up for genetic counseling during the course of her chemotherapy, and we came to know that she was BRCA positive. Now, what are the implications for a patient when they turn out to be BRCA positive? Firstly, the implication is for the treatment is the type of breast surgery. So I would like to say here that even women who are BRCA positive can very safely have breast conservation surgeries. Of course, they have to be counseled that there is a very slight increase in chances of ipsilateral breast tumor recurrence in BRCA positive patients, but with radiation and with a good follow-up, there is a good amount of evidence to show that they can conserve their breasts. The opposite breast has a 40% chance of having a future cancer, and therefore they must have, they can have the option of either having a prophylactic mastectomy or undergoing 6-monthly imaging for the breast in the form of mammograms, sonomammos, as well as MRIs of the breast and a good clinical examination. Risk reductive salpingo-oophorectomy or RRSO is the only way to mitigate the risk of ovarian cancer after the family is complete and after a certain age of 35. But the timing of doing this surgery is extremely tricky and important, especially in young women who do require, they may have completed their families, but they do require their ovaries for hormones, for a good sexual function, and their bone health, their heart health, and everything else. So having a good genetic counseling and explaining all these aspects is extremely important. No two patients are the same. Every patient has their own baggage, their own emotions, their own situations, and therefore, and this kind of surgery, a risk reductive oophorectomy or a mastectomy, or it can have huge implications on the patient's social, cultural well-being, and therefore they have to be managed with utmost care. The next case, which I'll quickly go over, is the other most common kind of case that you would see in the clinic. This was a 50-year-old male with a right-sided CA colon at the age of 51, and he also had another CA sigmoid colon previously at 51 and then at 54, and he received regular kind of treatment and came up for genetic counseling because he had an extremely strong family history of colon and endometrial cancers, and this pointed to something known as the Lynch syndrome. So in this pedigree chart you can see that he has, this is the proband, and he had 3 sisters with colon or endometrial cancers. He had a cousin who had passed away, his mother had endometrial cancer, and his Masi had CA colon as well. So clinically, when I saw this patient, I had no doubt in my mind that this is a Lynch syndrome, and we confirmed this with the genetic testing. Genetic testing is a blood test. The report takes about a month to come. We don't always get a clear-cut answer. You may get a positive, you may get a negative, and sometimes you may also end up with a confusing result. But in this case, it was clearly a positive in the MLH1 gene, which causes Lynch syndrome. Now, Lynch syndrome, the people with Lynch syndrome, men or women, have about a 70% lifetime risk of getting colorectal cancers, a 40% risk of uterine cancers, a slightly higher than normal risk of upper GI cancers, and hepatobiliary cancers. It is autosomally dominant as well. But there are some cases, very rarely, which we have seen in our clinic, where in consanguineous marriages where the parents are related, where if both parents have the same gene for Lynch syndrome, the child has a 25% chance of having something called as a CMMRD, a constitutional mismatch repair deficiency syndrome, which is quite devastating, in which you can have childhood cancers, GBM like cancers, and leukemias in young children. So while Lynch syndrome itself is really not that devastating, because colorectal cancers can have a good prognosis if caught in an early stage, endometrial cancers also do well if caught in an early stage, it is very important to look at history of consanguinity in these cases. Once you find a case of Lynch syndrome, what I would do to manage the risk in that individual is suggest an annual colonoscopy, once in about 2 to 3 years an upper GI scopy, having a prophylactic hysterectomy and oophorectomy after family is complete after the age of about 40, because this has shown to improve survivals and reduce uterine cancers in women who have Lynch syndrome, and also have occult blood tested. There is some evidence to show the use of aspirin in the reducing the chances of polyps and to reduce risk of hereditary colorectal cancer in Lynch syndrome patients, but I don't routinely prescribe it because there is really no guideline on what the dosage should be for aspirin or how long it has to be given, and also no kind of evidence for the side effect profile in such cases. A quick word about my personal experience with the in my genetic clinic. Of course, this data is now about 1.5 or 2 years old, because I had a big break recently in my genetic clinic for personal reasons. But the large number of patients which underwent testing, about 47% of the patients who I counseled did opt for undergoing testing, and we had a very high positivity rate in our genetic clinic because of the high index of suspicion. So I ended up getting referrals for genetic counseling only for the most suspicious cases, for the ones which were very obvious hereditary syndrome. So I had a nearly 50% positivity rate, which means 50% plus of the patients who I sent for testing did end up coming positive. The most common syndromes were, of course, BRCA and Lynch syndrome, but we also saw rare syndromes like the TP53, which causes Lee-Fromenni syndrome, and the Rett proto-oncogene, which causes a Men syndrome. This picture that you see on the top left corner is of a family where they had classical hyperpigmentation of the oral mucosa. One of them had intestinal hamartomas, and this was indicative of Peutz-Jeghers syndrome. It's an autosomal dominant syndrome. We also had a case of Men syndrome, and we've had several cases of neurofibromatosis. So we do see some of the rare syndromes as well. 78% of patients who tested positive in my genetic clinic had had some intervention done to reduce their risk of future cancers. 9 of them underwent regular screening, and 7 had some surgical intervention done. About 22% chose not to do anything. The reasons for not doing any kind of surveillance was mostly for personal reasons or just apathy towards this. Also, resources and unaffordability is one of the major reasons. Of the patients that underwent surgical prophylaxis, 4 of them had RRSOs, risk reductive salpingo oophorectomy. We had 2 patients that opted for a prophylactic mastectomy, and 1 patient with Men syndrome where a prophylactic thyroidectomy was done, and in that patient they had an occult malignancy found. So almost none of the patients had aspirin, but tamoxifen can be used to reduce the risk of contralateral breast cancer in BRCA positive women. And olaparib is a drug which can be used in BRCA positive women as maintenance therapy, especially in ovarian cancer. So there is some impact on treatment as well. Wrapping up the presentation, I just wanted to share that in my personal experience of doing genetic counseling, the timing, that is when to do the genetic counseling, plays a very important role, because when you see a woman who has, for example, just been diagnosed with breast cancer, she may be grappling with emotions and coming to terms with it and denial that she has got breast cancer. So in that kind of emotional period, it's not the right time to talk about genetic counseling, because most of them are very concerned about their daughters and their children. So there is a cool off period that is required. So when to refer the patient and when to kind of hold on is important. Handling relatives, handling expectations, impact on reproductive choices. So when a person knows that they have a genetic syndrome, how it impacts their decision to have a biological child. Some of them may even be pregnant or may have a wife who is pregnant at the time. The cost is really not much of a deterrent. Contrary to popular belief, genetic testing is not really that expensive, and of course there is a lot of help available to patients that are unaffording. I already mentioned that no 2 patients are the same. So I've had patients who have started crying and have got very scared and anxious about what they hear in the genetic counseling, and then it impacts their treatment choices. And I've also had patients who were very upset that they were not earlier referred for genetic counseling. So you have to gauge the kind of emotional position the patient is in. Some patients may be adopted, they may not know they are adopted, and therefore their family history they may not have a family history. So that's something to keep in mind. Consanguinity is much more common than you would expect, in my experience. And when a genetic test is done, when the blood sample for this is drawn, it's very important that the sample is labeled with utmost care. So I once had 3 brothers who had names which were very, very similar, and it's very important that you label the samples correctly to avoid, because the implications for future, for surveillance, for surgery, it makes a huge impact on their lives. Of course, you have to see hundreds and thousands of patients to find that one occult cancer, but there is always kind of some benefit to the family. The aim of the genetic clinic and of the counseling is to prevent any further cancers from happening in that family, and that is something which is invaluable to the patient and their family. So thank you very much, and of course you can get in touch with anyone from our team or to me directly if you have any doubts regarding any clinical situation or if we can be of any help. Thank you.
Thank you so much, ma'am, for the lecture. We now have the floor open for questions for Dr. Mansi. So we have a question, ma'am. This male patients have LAD block 90% and is hepatectomy suitable. I'm sorry, but the questions seem to be directed towards someone else. Can we have questions directed towards Dr. Mansi right now? I'm sorry for the error. Dr. Mansi will join us in a minute, and then I'll direct the questions towards her. Until then, anybody who has any questions can please post it. Hi, ma'am. So we have a question for you. What is the average cost of tests for detection of genetic mutations? Ma'am, you're muted, I think. We can't hear you.
How about now? Am I audible?
Yes, ma'am. We can hear you.
Yes. So on an average, the genetic cost of a test would be anything between about 15 to 25,000, depending on how many genes are required to be tested. But like I mentioned in the talk, not all patients end up requiring the genetic test. So after doing genetic counseling, some patients may not want to do the test, some patients may not need the test. And we have never been unable to test a patient for lack of resources or lack of funds. So even if a patient is unaffording, there's always a way to find a way to do their genetic testing. So that's what I wanted to convey. But on an average, it's about 25,000 rupees for the test.
Thank you, ma'am.
Thanks.
Are there any other questions for Dr. Mansi from the participants?
Are there any other questions, Rusha?
There's another question here that says this male patient has LAD block 90%.
I did, yeah. I did read that, but I think that's not in my
yes, ma'am. That's
my area of expertise. Yeah, probably somebody else can get that later on.
Yeah. Is there any other question for Dr. Mansi with respect to her presentation or genetics in general? We're going to wait for another minute, ma'am, and then. Oh, I believe there are no other questions.
Yeah, there are no other questions. Thank you very much.
Thank you, ma'am.
Thank you.
This concludes the first session. We'll begin with the second session right now, which is chaired by Dr. Sanjay Deshmukh. And the first presentation is by Dr. Minish Jain, who's the Director of Medical Oncology at Ruby Hall.
I'm Dr. Minish Jain. I'll be discussing basics in oncology today. There are 7 warning signals of cancer, and it is called by a mnemonic called caution, that is change in bowel habits, a sore that doesn't heal, unusual bleeding or discharge, thickening or lump anywhere, indigestion or difficulty in swallowing, obvious change in wart or mole, and nagging cough and hoarseness. Characteristics of cancer cells. Cancer is a clonal disease and all cells arise from a single cell which they lose their normal mechanism of regulation, proliferation, and they now want to be immortal, they want to grow rapidly, they don't follow the cell to cell interaction, they just want to eat up onto somebody else's food, they want to encroach on other territories. So this is a characteristic of cancer. It is not following the normal rhythm of body. And supposing we have a nail cell growing into the face, then it will be a trouble. So similarly, cancer cells, they are just going out of the way. This is model of cancer in colon. Basically, cancer is not a single step process, it is a multi-step process. So if there is a normal mucosa which loses APC, APC is a gene, it will turn into a small adenoma, then there will be a loss of KRAS, chromosome 18 loss, then this adenoma will have dysplasia, and then there will be a P53 loss, which is a policing gene in our body, and that will lead to carcinoma. So this process may happen over 6 to 10 years. So nothing happens overnight. So cancer is not an overnight procedure. Biopsies, we know that there are two kinds of biopsies. FNAC, which is just pulling out some cells out of the tumor, and it is done by a very fine needle, so it's called fine needle aspiration, and you don't get the structure, you just get the cells. If you take a biopsy, then you would be able to define the structure of that cells, how they are placed. So this is also important. Core needle biopsies are taking a bigger chunk. So there are various stages of cancer. Stage 0, where the cancer is in situ, there is no invasion surrounding it. Maybe if you are looking at breast cancer, it may be called ductal carcinoma in situ or lobular carcinoma in situ. Stage 1, this is just a small tumor in a breast. I am just discussing the breast carcinoma staging because every staging is different in different carcinomas, but generally more or less this is similar in TNM pattern. So tumor which is confined to breast, which is less than 2 centimeter, it will be called stage 1. If it is stage 2, then you will have a tumor which is 2 to 5 centimeter and there will be axillary nodes. Stage 3, which is like, you will have locally disease, nodal disease, and you will have regional disease. So the supraclavicular node, if it is involved, or internal mammary nodes are involved, then you get stage 3. And if the tumor is spread to liver, lung, bone, or other soft tissues, then it is called stage 4 or metastatic disease. Cell cycle. This is very important. Cells are actually in 3 phases: dividing phase, resting phase, and differentiating phase. No tumor generally would be responding to chemotherapy in resting phase. So these are dormant tumors and they would generally escape the killing mechanisms of chemotherapy. Most of the drugs don't work in this, but some alkylating drugs do work in this phase. If you look at it in the form of cell cycle, then it is called G1 or RNA protein synthesis phase, S which is DNA phase, G2 which is pre-mitosis, M which is mitosis, and G0 which is resting. Why this is important? If you are looking at the cell cycle, then they are dividing, you need to use this for your benefit of giving chemotherapy. I'll come to it in the next slide. The cell cycle and different drugs working at different areas of the cell cycle. So you need to use drugs which are working in different areas of the cell cycle with different toxicity. So if you are using, supposing you are treating C ovary, then you would use taxane and a platinum. So you would use antimicrotubule and a drug to target into the S to G2 phase. So this is how you will target, and they will have different toxicity. One will be myelosuppressive, other one would be nephrotoxic. So you are combining 2 different toxicities, 2 different mechanisms to achieve the maximum response and not allow the cells to escape the tumor kill of the chemotherapy. So basis of chemotherapy, when you give chemotherapy, most of the tumors, when it get detected on a PET scan, it is more than 10⁻⁹. So to understand this, if a tumor has to become 1 centimeter in breast cancer, it has to undergo 30 doublings. 30 doublings means it is reached 10⁹, which is 1 centimeter. So if you make 1 cell into 2, 2 into 4, 4 into 8, such way, then it will reach 1 centimeter at 30 doublings. Below 10⁹, most of the scans may not detect. If it is scan which is very, very superior, it may detect at 1 to 5 millimeters. So it's like 10 raised to still 8 cells and 29 doublings. So this kind of tumor might have lived in breast in a person's breast for somewhere around 6 to 17 years, depending upon what is the doubling time. If it is a 30-day doubling or 270-day doubling, then that is the time it has already lived in body. But most of the patients would die if their tumor reaches 10 raised to 12 or 40 doublings. So most of our patients, they come in advanced stages, stage 3, stage 4. If it is detected early, like stage 1, stage 0, stage 2, you may still cure a lot of them. And in advanced stages, the cure rates are dropping. So try to detect cancer early, treat them early, so the resistance is low, the cure rate is high, and the chemotherapy dosaging or requirement also may be low in such patients. So if you give chemotherapy to a patient who has got 10 raised to 10 cells, then every chemo cycle is expected to cause a 3-log kill. We'll come to it in the next slide. So if you give chemotherapy, it causes a 3-log kill. So 10 raised to 10 will become 10 raised to 7. By the time your next cycle comes up 3 weeks, it may grow, the tumor may grow. So it becomes 10 raised to 8, and you give another cycle, it becomes 10 raised to 5. So this is a very, very pictorial depiction, but it is not exactly, it is a 3-log kill. So if you go by calculation, it is a little different. To make it easier, I have shown it in a graphical format like this. So you require 5 cycles to bring it down, and 6 cycle is given, so to bring it down less than 10 raised to 3. Most of the tumors never touch 0. They will always be less than 10 raised to 3, where the body is taking care of them. And if you give a very good chemotherapy dosaging, you get a 3-log kill. But if you give a poor chemotherapy or a smaller dose, you may achieve a 2-log kill or 1-log kill. The tumor may become undetectable, but then it may have a chance of coming back. So chemotherapy should be given optimally, in right dosaging, in right sequencing, to achieve the maximum response. The purpose of chemotherapy is to prevent cancer cells from multiplying, metastasizing, or killing the host. So when you are trying to kill these fast growing cells, you are also killing some good cells like the WBCs, the mucosal lining, the hair follicles. So you may get side effects of this. Most of the people are worried about side effects of chemotherapy. We are not really worried of side effects. We are worried of the effect. If you want to achieve good effect, you must give a right dosaging, not to bother about side effects which are only temporary, and they're going to last only for a few days or a couple of weeks, and most of them would be reverted back to normal, and they can be taken care. You have got so much of good drugs, like you have filgrastim, you have antibiotics, you have supports, so you should not be bothered about neutropenia or mucositis. They are good drugs for this. So why multiple cycles? We already seen you require 6 cycles. The strategies are monotherapy. If the tumor is very advanced, you give single drug. If it is curable, you use combination, attacking the tumor by different mechanisms. You give adjuvant chemotherapy when you are done surgery, and you give neoadjuvant chemotherapy when you are doing it before surgery. So supposing you have a bigger tumor, you want to shrink it, you give chemotherapy, it is called neoadjuvant chemotherapy. So in metastatic setting, use single agent because you are not trying to cure them, you're just trying to keep them prolonged. So you're just trying to cut the grass, you're not cutting the roots. But when you are giving combination chemotherapy, that is for aggressively treating early tumor, so that you are cutting the roots, you are not allowing them to come back, and that's the reason you need to use combinations. So the principles of combination is to use drugs which are active as single agents, which have different mechanism of action, which have dose limiting toxicities are different. They should be used in optimal dosaging, and they should be given at constant interval with different patterns of resistance. So this is to reduce down the resistance, to kill the tumor completely. Why do you need to do all these things? I will just come to it. See, if you are using a single agent, your possibility of resistance is high in this slide, and if you are using multiple drugs, then the chances of resistance are low. If your drug has to be given in an optimal sequencing, like if you have gemcitabine and docetaxel, then you have to use it in a particular way. If you have taxanes and platinum, then you have to use it in a particular way. So you may have to use taxanes first, platinum later. You can't change the sequence. Also, if there is a specified time like gemcitabine in half an hour, don't give it in 3 hours. It will be a different drug. So if you are given a sequencing, optimal dosaging, and another thing, if your drug plan is like, if you are giving 100% dose, that's the best thing. If you are giving less than 15% dose reduction, like 85% dose, you will achieve a 50% less effect of the drug. So your sequencing should be right, your dosaging should be right, your all treatment should be given in time. So you should not skip any scheduling. Preferably try to support the patient and get them recovered in time, so that you achieve the best benefit of the chemotherapy. So this is a dose dense therapy. When young patients are there, instead of 3 weekly, we may give them 2 weekly regimens to try and give them growth factors, recover them fast, give the chemotherapy, so you don't allow your opponent to get time to recover. Now this mechanism is called dose dense. So it will achieve a better result, a better survival. So when these cancers chemotherapies are killing bad cells, they are also killing some good cells. So you may get WBCs going low, you may have to use filgrastim, you may have neutropenia, you may have to treat them with antibiotics. If it is a mild neutropenia, you will treat with oral antibiotics. If it is a deep neutropenic curve, then you will use injectable antibiotics, admit them. You may have digestive tract affected, so mucositis, so ulcers may be there, poor intake may lead to loose motions may be there. So these are the things which you will have to manage. With a combination of the treating oncologist and the family physician, patients can be managed very well. Most of the time the patients are with you, so you will have to take care of them, and you can inform us, and we can always tell you what drugs or how, what saline or what. If the patient has got severe complications, they can always come down to the institute and we can help them. So this is how the teamwork can help the patient to keep them comfortable at home. There can be other side effects, like the heart has to be monitored with anthracycline, kidneys have to be monitored with platinum, nervous system has to be monitored with taxanes, vincristine. So you need to understand the side effects and manage those patients accordingly. So these are other side effects of chemotherapy. You may have anemia, you may have to use erythropoietin or blood transfusions, you may have arthralgias and myalgias, and you may have to use some painkillers for them, or some massage, or you may have to teach them yoga therapies and other things. So these are some pictures which are showing the side effects. This is an extravasation in the foot which has been given on the foot. Never give chemotherapy on the foot. If you don't have a line, do not give chemotherapy that day. You may have to delay, that's fine, but don't give chemotherapy. This is another side effect of a drug. You are seeing the nail bed being eroded. This is an extravasation, which is an early extravasation in the forearm, but it may develop into an ulcer. The chemotherapies get delayed, so make sure your lines are perfect. There is no extravasation, there is no counterpuncture. So these are some side effects of gefitinib drug, which is a drug used for lung cancer, and this rash is a good rash. These are mucositis. You may get candida like this, or you may get serpentinous ulcers, which may be herpes. There are certain places where you do chemoradiation, like head and neck cancer, cervical cancer, esophageal pancreatic cancer, then anal cancer, larynx cancer, you do chemoradiation. You do organ preservation in larynx, esophagus, anal canal, breasts, in limb salvage, in osteosarcomas and peanut or E-wings, and you do fertility sparing surgeries in borderline ovarian cancers or early ovarian cancers. Pharmacogenomics, basically all tumors are not same. Like lung cancer, to give you an example, adenocarcinoma will have multiple types: EGFR, ALK, RAT, ROS, MED, BRAF, those kind of thing. And each exon, like if you have an EGFR positive tumor, you will be using a different drug. Then ALK, you are using different drugs. So if you know the target, if you know the lock, you can use a key. And if you don't know the lock, then you use hammer, which is chemotherapy. So if you don't know the lock, you will have to use chemotherapy. If you know the lock, you may use a drug which is available. There are 52 subtypes of lung cancer. So all those don't have drugs, but 80% of these tumors will have a targetable mutation, which can be targeted with the right drug. And that's the reason why all the patients should not be treated with the same. So one size doesn't fit all. So you need to have a right kind of treatment for a right patient. All breast cancers are not same. There are 4 subtypes. Then there are multiple different factors which are playing into it. So every tumor has to be managed according to what type they have, what subtype they have, what kind of characters they have, and then you use your chemotherapy or hormonal therapies and depending upon situations. So cancer is a genetic disease, and this is a FISH test which we use for HER2 testing, and this is HER2. This is how it is targeted. So you see next, this is like if you are using lapatinib or trastuzumab or pertuzumab or erlotinib, gefitinib, cetuximab. These are all different targets attacking the HER2 family. And this is a cancer vaccine which is like we create for certain diseases. We take out their patient's tumor tissue antigen, we take out their monocytes, we convert these monocytes into dendritic cells in lab, teach the dendritic cell the antigen, how to attack the antigen in the lab, and put this dendritic cell back into the patient's body. So these are called dendritic cell therapies or cancer vaccines or Sipuleucel for prostate cancer. It is not used for right now all the conditions, but there are some patients are getting great results out of this personalized vaccine. So this is gene therapy. You take out the patient T cell, you put a gene with a modified viral vector and put these cells back into the patient's body. So these re-engineered cells can reform the person's deficiency. Thank you.
Thank you so much, sir. Unfortunately, Dr. Minish Jain is unable to join us, so we won't be having any questions for him. We'll be moving straight to the next presentation by Dr. S.M. Karandikar, who is going to present on complications of chemotherapy and its management. And Karandikar, sir, is a senior medical oncologist at Ruby Hall Clinic.
Good morning. I am Dr. S.M. Karandikar, Senior Consultant Medical Oncologist at Ruby Hall Clinic, Pune. The task allotted to me today is complications of chemotherapy and its management. Now let's start with the basics of definition of cancer. Cancer, we all know, is a disease where cells grow out of control and invade, erode and destroy the normal tissues. Having said that, chemotherapy has become one of the most important modalities of cancer treatment. It's a fast developing subspecialty of oncology. Several new drugs, targeted monoclonal antibodies, are being developed. They are more sophisticated and less toxic. Most anti-cancer drugs, they target rapidly multiplying cancer cells, and they also target rapidly multiplying normal cells like hair, GI tract, gonads, skins, etc. However, it's a very safe treatment modality. Treatment-related mortality is unknown in experienced hands. Side effects are seen on all organ systems and they are reversible. Chemotherapy toxicity can be widely divided into hematologic, skin and mucosal toxicity, cardiac toxicity, renal and or genitourinary toxicity, neurologic complications or toxicity, and GI toxicity. Oral toxicity can take a form of mucositis, oral mucosal infections, dental pulp infections, or periapical infections. So chemotherapy makes its subject more prone for all these kind of oral and mucosal infections, and late effects could be xerostomia and at times osteonecrosis. Targeted therapy is being developed for cancer. Targeted therapy is a type of medication that blocks the growth of cancer cells by interfering with specific targeted molecules needed for carcinogenesis and tumor growth, rather than by simply interfering with rapidly dividing cells, which is a mechanism of action of cancer chemotherapy. The main categories of targeted therapy are small molecules and monoclonal antibodies. Small molecules typically end with IB. So imatinib, gefitinib, erlotinib, bortezomib, they are all well-known small molecules. As against monoclonal antibodies, they end with AB, like rituximab, trastuzumab, cetuximab, bevacizumab, nimesulide, and so on. So now you might be wondering as to why I have put up this slide. It reads that it may look like I am having really deep thoughts, but 99% of the times I am just thinking about what food I am going to eat later. So the crux of the whole thing is that the cancer treatment and its complication management can be really simple, as against you can imagine that it's very complex. Now let's come to skin toxicity. Skin toxicity can take various forms like acral erythroid dysesthesia, radiation recall, photosensitivity, leg ulcers, onchodystrophy, worsening of psoriasis, and at times sweet syndrome, which is related to GCSF or GMCSF. Now, dysesthesias are typically seen with doxorubicin, cytarabine, bleomycin, etoposide, etc. Radiation recall is a funny type of toxicity wherein patient who is subjected to chemotherapy after radiation can develop rash at the site of radiation. Photosensitization is typically seen with mitomycin, vinblastine, methotrexate, and so many other drugs. Patients typically develop rash after getting exposed to sunlight. Leg ulcers are seen with hydroxyurea and other drugs. Onchodystrophy is seen with bleomycin, doxorubicin, 5-FU, and cyclophosphamide. And worsening of psoriasis is also seen with drugs like interferons and interleukins. Now, these are some of the clinical pictures of skin toxicities depicting typically the nail toxicity like oncholysis, erythrodysesthesias, fixed erythrodysesthesias, drug-induced subcutaneous lupus erythematosus, extravasation injury, the upper left-hand corner. This is something which should be avoided at all costs while administering chemotherapy. This should never happen in experienced hands. This is a huge ulcer defect. In this particular picture, there are many things which are absolutely wrong. Chemotherapy should, as far as possible, never administered through a peripheral vein of the lower extremities. And if you identify that it is not going properly, if it's getting extravasated, it should be stopped immediately, and so that so much big defect following sloughing of the skin can be avoided at all costs. Oncholysis due to bleomycin and hydroxyurea. Generalized exanthematous pustulosis is also seen. Next, supravenous hyperpigmentation is typically seen with 5-fluorouracil. Radiation recall dermatitis is seen with anthracyclines and taxanes. Acneiform eruption associated with gefitinib, and perinychial inflammation after cetuximab therapy is seen in the above clinical photograph. Now let's come to neurotoxicity. Neurotoxicity can take a form of sensory neuropathy or sensory and motor mixed type of neuropathies. It is typically seen with drugs like cisplatin, bortezomib, carboplatin, etoposide, gemcitabine, ifosfamide, oxaliplatin, and procarbazine, thalidomide, and so on. Sensory and motor neuropathy is typically seen with very commonly used drugs of taxane category like docetaxel, paclitaxel, and vinca alkaloids, vincristine, vinblastine, and vinorelbine. Now, as I was alluding to extravasation injuries, drugs which are capable of causing extravasation injuries are anthracyclines, mitomycin, vinca alkaloids, and many irritants like paclitaxel, doxorubicin, cisplatin, and so on. Management of extravasation is very important. You have to stop administration of the chemotherapy agent immediately as soon as you identify that it's getting extravasated. Leave the needle in place and immobilize the extremity. Aspirate any residual drug in the tubing, the needle or suspected extravasation site. Remove the needle. Avoid applying pressure to the extravasation site. Apply warm or cold compresses. Elevate the arm. Notify the responsible treating physician and administer an antidote as early as you can. Now, myelotoxicity or bone marrow toxicity forms the crux of administering chemotherapy, because here we are targeting the absolute neutrophil count, and if you can target the absolute neutrophil count and adjust the drug dosing in such a way that patients develop just borderline neutropenia, then probably you have achieved the drug targets. Here the neutropenia can be classified into several categories like grade 1 to grade 4. Where the absolute neutrophil count is more than 1500, it's grade 1, as against when absolute neutrophil count is less than 500, it is a severe neutropenia or grade 4 neutropenia, and patients are often symptomatic once the absolute neutrophil count starts going below 1000. Now, this has been largely prevented or largely manageable with the advent of colony stimulating factors, or which are commonly called as growth factors. Now, patients who can run the risk of bone marrow suppression are elderly, like more than 65. Females are more vulnerable than males. Then patients with poor performance status and poor nutritional status, those having core morbidities like COPD, cardiovascular disease, liver disease, diabetes mellitus, and those anemic patients with low hemoglobin. The treatment risk factors could be previous history of severe neutropenia with similar chemotherapy. Then subsequent cycles are likely to be yielding neutropenias in subsequent cycles. Similarly, dose-intensive chemotherapies often result in bone marrow suppression and neutropenia. Anthracycline-based chemotherapy is causing neutropenias more often. Then pre-existing neutropenia, extensive prior chemotherapy or radiation is also a reason for causing bone marrow suppression. Cancer-related factors, like if the cancer is involving the bone marrow, then obviously the reserve is low, so the subject is more likely to develop bone marrow suppression or bone marrow insufficiency. Uncontrolled cancer, elevated LDH, patients with leukemias and lymphomas, and elderly patients with lung cancer are at higher risk of developing bone marrow suppression. Now, cardiotoxicity can be largely divided into acute or chronic form. Acute forms are often seen while the chemotherapy is being administered, and it is in the form of electrocardiographic changes, sinus tachycardias, ectopics, ST and T changes electrocardiographically, prolonged QT intervals, or transient heart blocks, and they are often reversible. Pericarditis, myocarditis syndrome is also seen with some of the chemotherapy drugs. Now here we are more worried about the chronic forms of cardiotoxicity, that is in the form of cardiac dysfunction, cardiomyopathy, and congestive heart failure. And this is typically seen with patients with extensive prior treatment, prior chest irradiation, and here the cumulative dose of drugs like anthracycline compounds, doxorubicin, daunorubicin, and epirubicin is important. With doxorubicin, the cumulative cardiotoxic dose is 400 to 500 mg per meter square, as against it is 900 mg per meter square for epirubicin. Liposomal formulations are less cardiotoxic, as the dose required is close to 50 to 60% of what the usual anthracycline dosage is required. So liposomal formulations are better suited for elderly individuals, for individuals with compromised cardiovascular status. Now, GI toxicity is a very common toxicity and very disturbing toxicities, and in the earlier days patients used to suffer a lot because of GI toxicities. Nausea and vomiting and resultant electrolyte imbalance and dehydration used to be very common when our anti-emetic drugs were not so properly formulated and were not very effective. But nowadays, with the advent of newer anti-emetics, especially drugs like ondansetron, granisetron, palanosetron, and some of the other newer drugs, like they can really prevent nausea, vomiting, and GI toxicity to a large. The mechanism of GI toxicity is centrally located, where the vomiting center is located in the cerebral cortex, and it influences the chemoreceptor trigger zone, which is located in the brainstem. It influences the vomiting center, and through the efferent pathways of vagus, sympathetics, and phrenics, the vomiting is effective. Now, emetogenic potential of various drugs is divided into from mild, moderate to severe, and it is classified into level 1 to level 4. Level 1 agents are drugs like bleomycin, busulfan, hydroxyurea, and vinblastine with a very mild emetogenic put, as against we have certain drugs like high dose of cyclophosphamide, doxorubicin, epirubicin. They have moderately emetogenic abilities. Here we have developed a anti-emetic cocktail which comprises of granisetron, then apripatents, and steroids, and H2 blockers like ranitidine or cimetidine. And these drugs, this anti-emetic cocktail is very effective in preventing the vomiting and nausea which is resultant of chemotherapy. Now, the drugs with highest emetogenic ability are probably drugs like actinomycin D, high dose cisplatin, high dose cyclophosphamide, dacarbazine, high dose doxorubicin, irinotecan, and carboplatin in the higher doses. Now, let's come to pulmonary toxicities. The common causes of pulmonary injury in a patient with cancer could be lung infections, pulmonary hemorrhage, lymphangitic tumor, congestive heart failure, and pulmonary embolism. So this needs to be differentiated from the pulmonary toxicities, and this forms an important differential diagnosis in a subject with pulmonary toxicities. Now, the drugs which can cause pulmonary toxicity could be drugs like bleomycin, mitomycin, antimetabolites like cytarabine, fludarabine, alkylating agents like cyclophosphamide, busulfan, microtubule inhibitors like taxanes, vinca alkaloids. Monoclonal antibodies also at times can cause pulmonary toxicity like bevacizumab, cetuximab. Small molecules, imatinib, gefitinib, can also sometimes result in pulmonary toxicity. Now, most important part is to identify the pulmonary toxicity and identify the offending drug and use it within the safe therapeutic potential. Now let's come to the renal toxicities. Renal toxicity is seen with drugs like methotrexate and platinum compounds. Even cisplatin in single dose of more than 50 milligram per meter square can result in nephrotoxicity, but it can be largely prevented by adequate hydration, and the glomerular and tubular damage can be prevented, but at times it can be cumulative if with subsequent cycles of cisplatin. So every time you subject the patient to cisplatin or any platinum compound, the estimation of serum creatinine is mandatory. At times it can result in salt-losing syndromes. Drugs like cyclophosphamide, ifosfamide can cause hemorrhagic cystitis and cause bladder hemorrhages. Vascular complications are also very well known with anti-cancer drugs. They can take a form of pulmonary veno-occlusive disease, hepatic veno-occlusive disease, Budd-Chiari syndrome, Raynaud's phenomena. Sometimes myocardial ischemia and myocardial infarctions are also seen with some of the anti-cancer drugs like bleomycin, carboplatin and cisplatin etoposide. It can also result in microangiopathies. Thromboembolic disease, hypotension, Palmer plantar erythrodysesthesia are also one of the known vascular complications of anti-cancer drugs. Now, having said all that, my intention was to simplify this subject, but if I have confused you, I am really be excused, and I feel sorry for that. And here is a quote from the famous Nobel laureate in physics, Mr. Enrico Fermi. He said, "Before I came here, I was confused about this subject. Now, having listened to your lecture, I am still confused, but on a higher level." Thank you.
Thank you so much, sir, for the lecture. We now have the floor open for questions towards Dr. Karandikar. Kindly please post your questions in the chat box. Thank you. Are there any questions? There is one question, sir. What is the role of PSA in prostate cancer?
PSA is important in the diagnosis, number one. Secondly, if PSA is elevated, it is so definite that if PSA is 2.5 times above the normal upper limit, then most probably you are dealing with prostate cancer. And when the prostate cancer gets adequately treated, PSA level, they fall back to normal and they are in the normal range. And once they start shooting up again, that is clear indicative of imminent relapse. That's how PSA is extremely important and a very specific biomarker which is available to us.
Thank you, sir. Are there any more questions? There's another question, sir. It asks, how many sessions are commonly required for counseling?
Typically, the most important session here is at the time of diagnosis. There is something called as breaking the news, and that must be done with utmost care and caution, because the initial shock is very, very severe, and many times that can have a deterring effect on the patient's psyche and the outcome towards the whole thing. So the first session when you are breaking the news to the patient and patient's near and dear ones is very important, and that should be done with caution.
Are there any other questions? I believe there are no other questions. Thank you so much, sir, for joining us and for enlightening us about this. Our next lecture is by Dr. Chetan Deshmukh, who is a consultant medical oncologist, and he'll speak on newer molecules and immunotherapy.
Good morning, ladies and gentlemen. Thank you, Dr. Sujay, for inviting me once again to this great program, which is running on successfully for the past several years. Let's move on to today's topic, newer molecules and immunotherapy. So how new is new? 1980 cisplatin came in, 1990 taxanes came in, and 2000 onwards we've started getting the so-called newer molecules about monoclonal antibodies, tyrosine kinase inhibitors. In 2017 we started getting immunotherapy, and in 2021 the Indian study of CAR T-cell therapy has been published. So it has been a great achievement over the past 30 odd years. So which new molecules are we looking at now? There are primarily three different classes of new molecules. One is monoclonal antibodies, second is small molecule tyrosine kinase inhibitors, third one being immunotherapy, which is actually a type of monoclonal antibody, but since it's so different and so novel in its mechanism that we are considering it separately. And the fourth one, the latest kid on the block, is chimeric antigen receptor activated T cells, or the CAR T cells. I passed my DM in 2004, and after that there have been only two conventional chemotherapeutic drugs introduced after 2004. One is hexabepilone, which is no longer used, and the other is eribulin. And there has been a host of molecules amongst the top three class, that is monoclonal antibodies, tyrosine kinase inhibitors and immunotherapy. So our focus is going to be only on these three classes of drugs, and that is going to be the future of medical oncology. So going on to the next one about targeted therapy. So what is targeted therapy? See, technically every therapy is a targeted therapy. Even aspirin, the one which we've been using for the past several years, it works against a target called cyclooxygenase enzyme. But what is the difference between aspirin and modern day targeted therapy? In aspirin, the therapy came first. Aspirin came first, the target came later. In modern day targeted therapy, the target is pre-decided and the treatment against it is biologically engineered. So this has been made possible only due to the progress in molecular biology and oncology, which enables us to decide and define specific targets. So if you have a more specific therapy, the toxicity is going to be less because there is going to be less collateral damage. And that is how the first part of targeted therapy came up in the form of monoclonal antibodies. Monoclonal antibodies are four types of monoclonal antibodies. They are murine, they are either made from mouse proteins. Chimeric, that is, they are a combination of part mouse and part human. Humanized, these are made of very small parts of mouse protein attached to human proteins, and fully human proteins, they are also available today. How do these monoclonal antibodies work? There is a different system of working of monoclonal antibodies. Basically, they attach themselves to the tumor cells and then they bring about several changes. They either invite antibody dependent cell cytotoxicity, where the NK cells come and then hit the tumor. They sometimes bring about changes inside the tumor, they sometimes bring about changes outside the tumor. They also sometimes work in the form of change in cytokines. Sometimes you can attach a radio labeled antibody to these monoclonal antibodies and you can get a radioimmunotherapy as well. Which are the monoclonal antibodies which are available in today's practice? The commonest ones I have noted here, there are four of them: trastuzumab, rituximab, cetuximab and panitumumab. Trastuzumab is the most popular one against breast cancer, anti-HER2 antibody. The main toxicity is cardiotoxicity. Don't feel that monoclonal antibodies don't have toxicities, they also have their share of problems. Rituximab is an anti-CD20 antibody which is largely used in lymphomas but also used in rheumatoid arthritis. It can cause B cell depletion and sometimes it can lead to prolonged infections. Cetuximab and panitumumab are anti-EGFR antibodies, that is anti-epidermal growth factor receptor antibodies. They are used in head and neck cancer and colorectal cancer, and they can cause a lot of skin toxicity or sometimes rarely hypomagnesemia. All of these are injectable and all of these are proteins. So infusion related toxicities can happen with all of them. That is common to everybody. But in some cases there are more. In some of them give more infusion related toxicities, like rituximab and cetuximab have more infusion related toxicities compared to trastuzumab. Moving on from monoclonal antibodies to tyrosine kinase inhibitors, basically chemotherapy is designed to ease troubles of cancer patients. So the focus today is moving towards oral therapy so that the patient doesn't have to come to the hospital. The prototype drug of this class is imatinib mesylate. Time magazine had printed a photo of these imatinib mesylate capsules on the front page in 2000 as the new magic bullets for cancer. Tyrosine kinase, the word kine has got something to do with move. So it moves the ATP molecule to activate downstream cancer pathways. And tyrosine kinase inhibitors or TKIs, they occupy this ATP binding site and then they stop this process. You can see that the dumbbell shaped yellow EGFR moiety has a tyrosine domain, and this tyrosine domain uses ATP. With the aid of ATP, it starts downstream signaling pathways in various pathways, KRAS, RAF, MEK pathway, MAPK pathway, mTOR pathway, all these pathways can happen. But if you block this with a drug like gefitinib, then this movement of ATP to ADP and then the energy going to the downstream pathways, this process doesn't happen and you get inhibition of the cancerous process. Multiple TKIs are available today in the market. The prototype, the oldest one and the best one probably is imatinib, very well known to people, which targets the BCR-ABL pathway and is the drug of choice for a chronic myeloid leukemia, though it can cause some skin toxicity and hepatotoxicity. Gefitinib, erlotinib, afatinib, osimertinib and now dacomitinib are the TKIs used against the EGFR pathway used in lung cancer. They also can cause a lot of skin toxicity. Sunitinib, pazopanib are VEGF TKIs which are used in renal cell cancer or sarcomas. They also can cause hepatotoxicity and GI toxicity. Crizotinib, ceritinib, lorlatinib, these are targeting the ALCROSS pathway and they are used in lung cancer. They also can cause a fair amount of GI toxicity. And lapatinib is a relatively less used drug in HER2/neu positive breast cancers, but it can also cause skin and GI toxicity. Now, how bad is this skin and GI toxicity? Let's have a look. So this is the toxicity associated with VEGF TKIs, sunitinib and pazopanib. You can see the palms and soles have become red and there are large blisters on the soles. These can be really painful, and the grading is grade 1 to grade 3 as the situation keeps worsening. With EGFR TKIs like gefitinib, erlotinib, you can have a typical skin rash over face, trunk and upper extremities, again grading from grade 1 to grade 5 being death. And sometimes this skin rash can be really troublesome, which can have the patient may not be able to continue his treatment, and you may have to discontinue a very effective treatment. The usual treatment is with skin emollients. In severe cases, grade 3 or grade 4, you can offer tablet doxycycline 100 mg twice a day for 5 days. In severe cases, of course, you need to discontinue the treatment for a while. But an unusual thing is, worse is the rash, better is the response. This has been proven in a meta-analysis way back, that as your rash goes up in severity, the tumor response also improves. Going to the next molecule or the next type of newer therapy available, that is immunotherapy. So why do we need immunotherapy if we have such fantastic monoclonal antibodies and tyrosine kinase inhibitors? Basically, conventional chemotherapy causes a lot of toxicity to even normal tissues. Other targeted therapies like TKIs and monoclonal antibodies, they may be rendered ineffective if there are changes in the downstream pathways. Now, T lymphocytes are our own immune cells. They are our own immune or resistance mechanism. They can specifically target and destroy cancer cells. What you need to do is just activate these T cells. How do we do that? Now, inhibitory signals are always happening in the body. There are always it's like a brake on your vehicle. You always have a brake on every vehicle because you don't want your vehicle running haywire and dashing into somebody. So is the case with T cells, that you want an inhibitory mechanism so that your T cell response doesn't become very strong or unnecessary and causes collateral damage in the form of autoimmune disorders. Not everybody gets autoimmune disorders. Most of us don't have autoimmune disorder. That's because these checkpoints or these inhibitory signals are there. So these molecules on the lymphocytes, they prevent, or in other words, they hold in check the immune reactions, hence the name checkpoint molecules. Now, programmed cell death protein 1 is one of the members of this immunoglobulin superfamily. It is present on activated T cells, B cells and natural killer cells. These PD-1 molecules, it binds to programmed death ligand 1 and 2. How does that work? After binding with PD-1 becomes clustered with T cell receptors and it recruits several other cytokines and all a very complicated mechanism. The bottom line is it achieves suppression of T cell activation. So your T cell activity is curbed or T cell activity is reduced significantly. Now remember, cancer is a chronic disease. Chronic disease produces chronic antigen exposure and inflammation and persistent T cell activation. Due to persistent antigen stimulation, the effector function of CD8 T cells gradually decreases. This is what we call the phenomenon of immune exhaustion. And then they start losing their potency, they start reducing their potential to attack cancer cells, and then through various mechanisms. And this happens and the cancer is tolerated. The body becomes tolerant to the presence of cancer. This mechanism of tolerance of immune system to cancer has to be disrupted. The immune system has to go ahead and hit the cancer. It cannot just tolerate the cancer. So how do you go about doing it? How does immunotherapy work? First thing is it reverses the inhibition of T cell activation. It increases level of circulating interferon gamma and associated chemokines, and it increases the number of T cells with an activated phenotype, and they increase the number of CD8 cells in the tumor microenvironment. It increases T cell activity, host of mechanisms. But the bottom line is, with these drugs you make the T cells more active and more energetic towards the cancer cell. So the drugs which are available today in the market, we have 4 drugs available, 2 PD-1 inhibitors and 2 PD-L1 inhibitors. PD-1 inhibitors being nivolumab and pembrolizumab. We use them in lung cancer, head and neck cancer, renal cancer, melanoma, or for that matter any tumor which has a high microsatellite instability, MSI-H. So it is tested by a technique called digital droplet PCR, and if it shows that it is a high MSI, then these drugs can be used. For PD-L1 inhibition, you have atezolizumab and durvalumab. They are also used in lung cancer, urinary bladder cancer, and in select cases of triple negative breast cancer. Don't feel that these drugs are so fantastic in their mechanism, so they won't cause any toxicity. They all have their share of problems. I remember them as Raat Din Ek Jaisa Locha Hai. So R stands for rash, D stands for diarrhea, E stands for endocrine disturbances, L stands for liver function derangements, and H stands for hypersensitivity reactions, including a very bad and sometimes a lethal hypersensitivity pneumonia. Fine, thank you.
Thank you so much, sir. Unfortunately, Chetan sir is not able to join us for the meeting, so we'll carry on. This concludes session 2, and we'll begin with session 3 right now, which is chaired by Dr. S.M. Karandikar. And the first session here is by Dr. Anupama Mane, who is a breast surgeon, and she'll be presenting on surgical management of breast cancer, the changing perspectives.
Everyone. Today I'll be discussing the surgical management of breast cancer, the changing perspectives over time. So as you can see, our world is slowly turning pink. What does this chart show? All the countries shaded in pink actually have the highest incidence of breast cancer. In fact, according to Globocan 2020 data, breast cancer has surpassed lung cancer as the most common cancer in the world. This is the Globocan 2020 data. And you can see amongst the females, breast cancer is the most common cancer, accounting for almost 24.5%. And the mortality is also high, accounting for almost 15.5% amongst all the cancers in the females. But what is the most important thing in this? The highest ratios between mortality and incidence are found in India, almost 50%, and most of the African continent also is the same. And the lowest ratios are seen in North America and Australia. So even though the incidence of breast cancer might be low in India, but it is steadily increasing and the mortality rates are very high. That is a cause of concern for us. And these are the statistics from India. As you can see, almost 1 in 20 women in metropolitan cities are suffering from breast cancer. Incidence is almost 1,15,000 per year, and 5-year prevalence is almost 4 lakhs, and mortality is almost 47%, as I just mentioned earlier. But the important thing to remember is that breast cancer is curable if it is detected early. And as you can see, it depends on the stage at which the breast cancer is diagnosed. So stage 0 accounting for 100% survival, and stage 4 accounting for 16% 5-year survival. So as the stage increases, the survival decreases. Coming to the management of breast cancer, it is a multidisciplinary management comprising of surgical, chemotherapy, radiation therapy and hormone therapy, and of course the new kid on the block, the targeted therapy. The diagnosis is done by mammography and sonography, also MRI. FNAC has now become obsolete for the diagnosis of breast cancer. Core biopsy is the gold standard. We have to obtain tissue from the breast lump or the lymph nodes, and this is important in treatment planning, in which way the hormone receptor status can be determined on the tissue, as well as the type of cancer can be determined, HER2/neu status can be determined, and of course we get a lot of prognostic information. So core biopsy is recommended for the diagnosis and not FNAC. FNAC has a very low sensitivity in detecting breast cancers. It can easily miss them. One important concept that has come up in the recent time is breast cancer is many diseases. What does that mean? It is not one disease to be treated the same way in all the patients. It is divided into multiple groups. The most important 4 groups are there: luminal A, luminal B, basal-like and HER2 enriched. As you can see from this pie chart, luminal A and B account for almost 65% of the cases, HER2 positive accounts for 20% of the cases, and basal-like accounts for the 15% of the breast cancer cases. But this data is Western data. In India, the scene is a little different. In India, the basal-like accounts for almost 25% of all the cases. That is quite high. And amongst all these 4 subtypes of breast cancer, luminal A and B have good prognosis generally, and basal-like and HER2 enriched do not have as good. Now coming to the treatment options, surgery. I'll be talking a little about how the surgical scenario has changed in the management of breast cancer, moving from radical mastectomy to modified radical, simple skin sparing, nipple areola sparing mastectomies, reconstruction, breast conservation surgeries, and sentinel node biopsy. And then of course treatment options also cover radiation therapy, which is used for local control, chemotherapy for systemic control, and hormonal treatment again for systemic control. Now dividing it into stages, early breast cancer comprises of stage 1 and 2. Treatment is usually surgical followed by adjuvant therapy, and adjuvant therapy, the chemotherapy or the hormone therapy is dependent upon the IHC markers, the ERPR and HER2/neu that I had mentioned earlier. If the patient is ERPR positive, sometimes even in early breast cancers we start with, we do surgery first, and if the patient is HER2/neu positive and triple negative, TNBC or the basal-like, then we may start with neoadjuvant therapy first. And why this neoadjuvant is started first even in early breast cancers, I'll come to the reason a little later. Important thing to know is whether the surgery is done first or neoadjuvant chemotherapy is done first, overall survival is equivalent in both the approaches. Then locally advanced breast cancer, the treatment I mentioned earlier is multidisciplinary. Biopsy is taken for the diagnosis, metastatic workup in the form of PET CT or CT chest, pelvis, and bone scan is done, and then the treatment plan is formulated. Most of the times it is neoadjuvant chemotherapy followed by surgery. followed by completion chemotherapy, or all the cycles of chemotherapy can be given initially, followed by surgery, and then followed by locoregional radiation, plus minus hormone therapy. If the lady is ERPR positive, hormone therapy is given, otherwise it is not given. Of course, when the patient is on neoadjuvant chemotherapy, response assessment is done after every 2 cycles of chemo. If there is good response, we continue the chemo. And meanwhile, we also do clipping of the tumor and lymph nodes, because sometimes what happens is with good chemotherapy, the entire tumor disappears and then we don't know the tumor bed at the time of surgery. To prevent that from happening, when the patient is responding well, under ultrasound guidance, we put in a small clip in the tumor bed, so that even if a neoadjuvant chemotherapy, the entire tumor disappears, we know exactly where the tumor started from, the tumor bed is. And of course, if there is poor response to the chemotherapy, if the disease is stable, is not reducing, if it is a progressive disease, then we change the chemotherapy or we do the surgery first. So this is what I was talking about, the neoadjuvant systemic therapy or chemotherapy mainly. This converts inoperable breast cancer tumors to operable breast cancers. It can convert mastectomy to lumpectomy. There is improvement in the cosmetic outcomes, obviously. And we can identify the patients who are at a lower risk of recurrence or higher risk of recurrence, depending upon the pathological complete response. So once the neoadjuvant chemo is done, the surgery is done, the histopath report comes. If there is a complete pathological response, that means no viable tumor remaining in the tumor bed. That means the patient's outcome is going to be good. And in case that does not happen, then of course we add on a little more systemic therapy to the same treatment. Metastatic breast cancer, of course, the goal of treatment is only palliation. We don't do curative treatment in metastatic setting, except of course for oligometastasis, which is a totally different topic, but in that we might go in with a curative intent. And hormone therapy, chemotherapy, radiation therapy, all are made use of in the treatment of metastatic breast cancer. And nowadays the survival of metastatic breast cancer also has improved a great deal from the olden times. Coming to the surgical management of breast cancer, a little bit more about the journey from ablative surgery, very radical surgery, to conservative surgeries. There has been a shift in the surgical management of breast cancer, as I mentioned, from radical mastectomy to the conservative surgeries. How did that happen? These randomized controlled trials were done which compared mastectomy to breast conservation surgery. As you can see, these trials had a good number of patients. The overall mastectomy and the overall survival of the breast conservation surgery remained equal. That is important to know. Even though the local recurrence was a little higher, a shade higher in the BCS group, but the overall survival remained the same. These are all those RCTs comparing mastectomy to BCS. And after all this evidence came into light in the 1970s and 80s, it became known, this is the graph showing the same, what I just mentioned earlier. Then it became the gold standard that breast conservation surgery is equally good as a mastectomy as long as it is combined with radiation therapy, and it is good for stage 1 and 2 disease. However, eligibility for breast conservation surgery is only T1, T2 tumors, smaller tumors. Patient should be willing to take radiation, cosmetically acceptable results obviously, and it has to be done with oncologically safe margins. This is a photo of radical mastectomy. You can see even the muscle, pectoralis major, has been removed. Very debilitating surgery. This next photo shows modified radical mastectomy. The muscle has not been removed, but the breast has been removed completely along with the lymph nodes. The next photo shows breast conservation surgery. You can see, in fact, you can hardly make out whether any surgery has been done. But if you turn the patient sideways in the next picture, you can see the surgical scar. That is the breast conservation surgery along with axillary resection that was done. So you can see with such good cosmetic results, BCS has actually overtaken mastectomy. This is a mammogram of a patient who's suitable for breast conservation surgery, and this is a mammogram of patient who's suitable for mastectomy. In this second mammogram, we cannot do a BCS because the tumor is more widespread. Now coming to the fact that can axilla be conserved? We talked about breast being conserved, but can axilla be conserved? And why do we want to conserve the axilla? It's because of the complications of axillary dissection. They can be major complications, they can be minor complications. Minor complications like lymphedema, pain, numbness, weakness of the arm, shoulder movement restriction, these are all very common. This you can see in this photo, she's a young lady, 29 years old, with the left arm lymphedema post axillary dissection, and she has to live with this lymphedema throughout her life. This is a case of gross, chronic, severe lymphedema. You can see the picture. So how can we avoid these complications? By doing a surgical procedure known as sentinel node biopsy, in which we give a dye next to the tumor, and the dye travels through the lymphatics, goes to the nodes which are known as the sentinel lymph nodes in the armpit, in the axilla. We take out those nodes, send them for frozen section, and if they are positive, do an axillary dissection, remove all nodes. But if the sentinel lymph nodes are negative, we don't do all the axillary dissection. This is just the way it is done, sentinel lymph node biopsy. This is another, next is another picture of the sentinel lymph node biopsy. You can see the blue dye coming into the lymphatics. Next picture shows the blue sentinel node. Next picture shows the gamma probe that we use for identifying the radioactive tracer. We usually inject technetium-99, which has radioactivity. So this is injected peritumorally, it goes and we detect the radioactivity in the sentinel nodes. These are all the studies on sentinel lymph node biopsy. It has been proven in several studies and it has very good accuracy, above 90-95%. Coming to another part of the breast cancer surgery, if mastectomy is essential, then reconstruction can be done. The lady need not live with one breast only. And breast reconstruction can be done as immediate reconstruction. That means at the time of initial mastectomy only. Post-mastectomy reconstruction can be done with silicone implants or flaps. There are two major methods. Implants are usually textured implants filled with cohesive silicone gels. It's a very easy and short surgical process, and there are some complications of course associated with it, but they are generally minor. This picture shows an implant, textured implant, and next picture shows how the implant is inserted into the mastectomy cavity. Next way of breast reconstruction is autologous tissue. Autologous tissue means tissue from other parts of the body of the patient are shaped into a breast, and anastomosis, microvascular anastomosis can be done. This picture shows an autologous latissimus dorsi flap with nipple areola reconstruction done on the right side after the mastectomy at the same time. This next picture shows a young 24-year-old girl who had breast cancer. Mastectomy was done, and you can see the flap from lower abdomen. It is known as the DF flap. That flap, free flap, has been taken and put in the place of the breast, and it is almost like a normal breast. Nipple areola reconstruction will be done at a later time. Next picture shows an autologous latissimus dorsi flap that has been shaped like a breast. Nipple areola reconstruction I mentioned. Next picture shows this. The next picture shows the nipple reconstruction. And this picture shows nipple reconstruction after BCS for right breast Paget's disease. You can see that. That is the nipple being reconstructed under local anesthesia. This is delayed reconstruction, latissimus dorsi with implant. You can see the mastectomy has been done several years back and she wishes to have a new breast. So initially the skin is expanded with an expander, saline expander, slowly over several months, and later on that expander is changed for a permanent silicone implant. The opposite side breast is reduced and the nipple areola reconstruction is done. So even a delayed reconstruction gives very good results. This is the tattoo machine this picture is showing. Important thing to know is biology of breast cancer is not altered by breast reconstruction. So if a patient needs mastectomy and she is keen to have reconstruction, it should definitely be offered to her. Coming to one more surgical procedure, oncoplastic surgery. Oncoplastic surgery combines the best of oncological surgery and plastic surgery so that the tumor is removed entirely and safely with negative margins, and the breast is shaped properly with the plastic surgery procedure. These are several flaps that we use: Grassotti flap, donut technique, reduction mammoplasty. I'll just show you some of them. This picture shows the donut technique. As you can see, the tumor is in the inner quadrant marked by the blue ink. This is the incision is taken entirely around the areola, and axillary incision shows the axillary dissection. And you can see this is the patient who has the incision only around the areola. There is no incision on the breast skin as such, and hence after this heals well, she will not even be able to know whether any breast cancer surgery has been done. Coming to the next oncoplastic procedure, therapeutic reduction mammoplasty. This is a 54-year-old lady with left breast tumor in the lower inner quadrant. You can see she has very loose, ptotic, heavy breasts. She wanted a breast reduction along with the breast cancer surgery. And this is bilateral reduction mammoplasty done. Reduction is done and the tumor is taken out completely. So she's getting a good cosmetic outcome as well as a good oncological outcome. That's what oncoplastic surgery does. In summary, there have been major changes in surgical approach of breast cancer. Surgeries have become more conservative, minimally invasive. Oncoplastic surgery has come up in a big way in today's day. Sentinel node biopsy has actually become the gold standard in early breast cancers. Of course, there are certain evolving issues in breast cancer management, like the type and extent of local treatment does not affect survival. That is important to know. And systemic treatment, the chemotherapy, hormone therapy, etc., plays a very important part in treatment of breast cancer. One more important concept that has recently come up is that cancer is a genetic disease. Approximately 5 to 10% of all cancers could be hereditary and inherited. As you can see in this picture, the line at the last is general population. Then there are some familial cancers which are running in families, but the families don't have the mutation if you check them. And then there are hereditary breast cancers which are inherited from the parents or the relatives. So this is also an important fact to know. If the cancer is genetic, then the treatment might change a little. And of course, there has been the rise of targeted therapy. You can see a lot of drugs have come in the market, monoclonal antibodies and many others, and they are on the covers of all the major important magazines. So a lot of progress has been made in the treatment of breast cancer, apart from surgeries, even in medical oncology, even in radiation oncology. And the survival of breast cancer patients over time has actually improved from 17 years to 30 years. That's a very significant improvement. And we hope to give that improvement to all our patients. Thank you so much. If there are any questions, we can take them later. Thank you.
Thank you so much, ma'am. I would like to take questions for Dr. Mane. If there are any questions, please post it in the chat box. Thank you. We have a question, ma'am, for you. Does tobacco, especially tobacco powder, cause CA breast? Something that is colloquially called as mishari.
No, tobacco directly cannot cause CA breast. Actually, there is another question, I think. Can you just let me know that?
I'm sorry, ma'am. Can you repeat the question?
Yeah, I said tobacco cannot directly cause breast cancer.
All right. Ma'am, there's another one. Can silicone implants induce breast cancer? Do silicone implants have any place in reconstruction of breasts after the surgery itself?
So silicone implants are used very commonly actually even for cosmetic breast augmentation, and they are associated with another type of cancer which is not breast cancer, but it is ALCL, anaplastic large cell lymphoma. And this association has come to light only recently, few years back, and it is an extremely rare kind of cancer, but yes, it can happen due to silicone implants, but not breast cancer.
Thank you, ma'am. Are there any more questions for Dr. Mane? I believe that was the last one, ma'am. Thank you so much for your talk and for answering the questions. Our next speaker is Dr. Sanjay Deshmukh, who is the Director of Surgical Oncology at Ruby Hall, and he'll be talking on basics of surgery and cancer. Thank you.
Good morning, friends. So, welcome to the 14th course of Cancer Management and Clinical Guidelines. I welcome all of you to this wonderful annual event, which we are doing it very religiously. My topic, which has been given to me, is basics of cancer surgery care, particularly how and what is important in a surgery for cancer. This is a very vast topic. I like to cover it as easily as possible. What do we really mean by cancer treatment? Cancer treatment can be roughly divided between 5 or 6 basic headings. One is obviously surgery, which is also known as cancer surgery or oncosurgery. Then radiation therapy. Again, very old kind of a treatment modality, which probably started in 1910 to 15 and later on became one of the pillar of treatment. And that is also called as radiotherapy. And medical oncology, which is known commonly by chemotherapy. Then there are other branches like immunotherapy, preventive oncology. There are a lot of unproven methods of treating cancer, and those are not proven. Not proven means they are not being proven scientifically to the benefit of this patients. What I am going to talk is about the surgical oncology, means cancer surgery. Now, surgical oncology is developed completely as a specialty in last 100 years. Long back in around 1900s, Mr. Halsted, Dr. Halsted, who actually is father of a residency system, formed a residency system with a good amount of inspiration from the German system, and his first batch of 12 residents further took that residency further. That developed a surgery, not the surgical oncology, although a lot of surgery in initial days was mainly of the surgery of the cancer. And this specialty also has one of the very important kind of a job, that the said cancerous part has to be removed completely with anatomical margins and with a draining lymph nodes. Now, this drainage of lymph nodes was considered to be a loco-regional treatment. When you have a proper loco-regional treatment, patient will probably have a better outcome. And that was proven in multiple clinical trials, multiple different diseases. So, in a solid cancer, now as I am saying a solid cancer, there is a solid cancer and blood cancer. In a solid cancer, we need to have a proper surgical treatment, and that's how surgical oncology developed. Somewhere after 1960s onwards, it developed into a dedicated specialty. As we talk about this, most of the patients actually nowadays are evaluated in a joint care clinic, and then they are further taken to the respective treatment. That is generally called as this joint meeting is called as tumor board, and this board plans a treatment with the specialists who are radiation oncologists, medical oncologists and surgical oncologists, and try to give the best of everything to the patient. So briefly, I'll try to cover few cancers here. I am not saying that I'll probably cover all cancers, but I'll try to cover most of the important cancers. So one of the very common cancer, breast cancer, incidence is quite high, and as we all know that breast cancer now is the #1 cancer in women in India also. Cervical cancer used to be previously 10 years back #1 cancer, but now breast cancer has taken the place of cervical cancer. So how we need to know, how do we plan the treatment? How do we do the timing of surgery? What are the incisions? Now this takes me to the incisions of breast lumpectomy, maybe even a benign lumpectomy, where we need to have a proper breast incisions. So here I'll probably dwell more in a breast cancer about the breast incisions and its surgical effects. Now a lump, when it comes to first to a surgical oncologist, then it is evaluated by typical 3 methods: clinical evaluation, then breast imaging and breast biopsy. Anyone who has got a suspicious nodule has to be evaluated in these 3 treatment parts, and then they are to be taken. And when we are doing incisions, we have to see that what are the recommended incisions and what are not recommended. I am giving you a here figure. What you can see here is the upper quadrant incisions are generally according to the skin lines, which are Langer's lines, and most preferred incision will be along the periareolar, which is along the areola, and the lower part incisions, the lower half of the breast incisions can be radial incisions. Very commonly you see very bad incisions, and they have a lot of impact on the treatment of patients. Here you can see these bad incisions, very bad incisions, where you can see in the first part there is one incision which is in the upper quadrant, one incision along the periareolar area, then one is a radial incision. You can say again bad incision. So when you see something like in the last figure 4, you have an incision which is really has taken multiple ways, and this kind of bad incisions make the patient vulnerable for not being opted for breast conservation surgery in spite of very small tumor volume. Here comes actually the importance of what actually becomes a breast conservation surgery. Most of the patients with an early tumor should be given advantage of breast conservation surgery. That is a small surgery compared to the major surgery of removing all the breast, which carries a lot of emotional impact and does not really give any additional benefit to the patient. So we have to plan this breast conservation surgery taking into account a small tumors, patients who are willing to take radiotherapy, cosmetically acceptable results when we can give, and when there are oncologically safe way of doing surgery. What are the contraindications? Multicentric disease, pregnancy is a relative contraindication, not the absolute. Diffuse microcalcifications and signs of malignancy, prior therapeutic radiation, more than 5 cm tumor. Again, this is a relative contraindication. History of collagen vascular disease, these kind of people will not be able to withstand radiotherapy, and persistent positive margins on a frozen section. Now, I will try to see, after going into this, to other topic, which is the colon and rectum. This is again very important. I am trying to cover not a topic, I am trying to cover the broad guidelines. So you will probably feel that I am not really going to giving it to a complete this. These are basics of treatment. So when you are doing a colon and rectal cancer, again you have to decide how you are going to plan your treatment, when you are going to time your surgery, what will be the extent of surgery, is the minimal invasive surgery possible, and how you are going to do a post-surgical rehabilitation of these patients. So there are different, colon cancer will be planned differently, rectal cancer will be planned differently, and obviously surgery can be either open or minimal invasive according to the suitability of the disease. It has been proven with most of the not very bulky lesions that both the treatment options are equally effective and good. Now, most of the times post-surgical chemotherapy is planned according to the final pathology of disease, and we have to also understand that this is one disease where multiple secondaries, or rather isolated secondaries in the liver, up to 2 secondaries in liver, can be taken for surgery, and planned removal or radiofrequency ablation is done for these liver secondaries. So this is one of the very important factor of colon and also for the rectum, that liver secondaries are not really a absolute contraindication for doing a surgery. Understand, colon and rectum, whenever there is obstructive symptoms, you may or surgeon may have to plan surgery upfront to reduce the obstruction. Again, for rectal cancer, multidisciplinary tumor board decides. Now this is on imaging, on basic imaging like PET scan and MRI pelvis will decide what is the extent of disease. How much disease is in a rectal cancer is breaching the circumferential margin. There are 2 margins, one is the longitudinal margin of the disease, another is circumferentially. Tumor is spreading outside its wall, and that can be seen on a pelvic MRI. And that pelvic MRI will tell us that is this patient a candidate for preoperative radiotherapy? So that treatment is planned in a multiple disciplinary treatment. And if stoma is planned, then obviously a stoma nurse has to be involved, and she has to take care of further post-operative care. Now surgery can be done either laparoscopy or open according to disease and condition of the patient. Briefly, I'll give the oral cancer. This is one of the very preventable cancer. India is one of the capital of oral cancer because of the tobacco, and obviously no kind of restriction on tobacco intake. Of obviously, even similarly, alcohol, which is getting a popularity or becoming a acceptable kind of thing in most of the households, is also showing its effects in the oral cancer. So we need to curb this. Again, treatment has to be planned beforehand. What can be done? How patient can really have a good aesthetic face is very important to know how that whole thing can be done. Surgery is very important. Skin crease incisions, use of free flaps also aid in these patients. In a lung cancer, we need to do planning of treatment in a lung nodule. Whenever there is a lung nodule, we need to know how we are going to go ahead with this. And that is obviously it is one of the most common cancer. In India, the highest cancer in the males is lung cancer and accounts more deaths than any other types of cancer, a lethal cancer. And it contributes significantly toward the cancer morbidity and mortality in India. Importance is a solitary pulmonary nodule. In evaluation of HRCT, high resolution CT scan, which is very easily available, is known to diagnose tumors early and have a better survival. So we should be doing proper planning for lung cancer whenever we can get a solitary pulmonary nodule by HRCT and CT guided biopsy, so that they can be picked up early. We have a small video here where we are going to, this is probably a 4.5 minute video where this is a patient which is a right side up. This is a video thoracoscopic lung resection of a lung cancer. This is a right middle lobe tumor. What you're seeing onto your right side is the upper end of the tumor, right? That is the apex of the tumor, and there you can see there's one lymph node of the right middle lobe is being taken out. Now this is why we are showing this, is that this is very easily possible to do surgery by a minimal invasive disease. That is a right middle lobe vein which is undergoing a stapler cut, so that that is achieved very well. Now these kind of lot of things which are available actually make us very easily possible to do this surgery by minimal invasive. This surgery I did around maybe around a year back, last year, almost a year back, and this patient went home on third day. Third day patient went home. That is a middle lobe bronchus which you are seeing being isolated, and again the stapler will go along that and will staple that right middle lobe bronchus, and that right middle lobe bronchus will be cut. That is the right middle lobe bronchus being cut. That is the right middle lobe bronchus being taken care of. The aim of this video is to show that even big surgeries like lobectomies can be very easily done by minimal invasive method. These are the vessels, the blood vessels of right middle lobe. These are the two blood vessels at one go which we are trying to kind of encircle and take into our stapler. So this will be achieved, and then that whole lung, right middle lobe, has been completely will be separate, and there will be only parenchymal incisions. That is done. Now here you are seeing stapler being applied. So that is what is a right middle lobectomy. Is completed right middle lobectomy, removed on a 3 centimeter incision, and patient is completely free. Again, similarly, cancer of esophagus, you need to plan disease. Cervical and endometrial cancer, which is a gynec cancers, again requires a proper planning. We have to know that cervical cancer should not be treated by minimal invasive treatment. Larynx cancer, large number of treatments are given by radiotherapy. Ovarian cancer is one disease where treatment planning is very, very important. So I hope that I must have tried to make some kind of effect into planning the treatment of basics of cancer treatment and surgery. Thank you.
Thank you so much, sir. Do we have any questions for Dr. Deshmukh right now? You can post them in the chat box. Are there any questions for Dr. Sanjay? I believe there are no questions.
Yeah.
Thank you so much, sir, for the talk.
Okay, bye. Bye.
Our next presenter is Dr. Sujay Hegde, who is a consultant surgical oncologist, and he'll be speaking on organ preservation surgery.
Hi, everyone. This topic for today is organ preservation surgery. I'm Dr. Sujay Hegde. I'm a surgical oncologist at Ruby Hall Clinic. So, what is organ preservation? And traditionally, if you look at the systems that we have followed, surgery has always been the mainstay of treatment. So, any patient that comes to you has always been addressed with a radical surgical resection, and then following that, we have been giving them adjuvant therapies and radiation, chemotherapy, and sometimes even targeted therapies. So, how has things changed, and how do we improve? And what are the factors that help us determine whether we are doing the right thing or not? So the points that we look at is local recurrence and survival, which is non-compromisable. And the things that we strive to achieve is comfort, continuity, compliance, and obviously the cost, essentially quality of life for the patients that we treat. The first question that comes up is that has surgery changed? In other words, has the type of surgery changed? And has the adjunct changed? So there has been a paradigm shift as far as our approach is concerned, and we have continued to be radical, but an element of conservation and cosmesis has come in, but not at the cost of survival. So the multidisciplinary approach to management of all cancers has been the most significant development in the management of these cancers. And this is a combination of all the faculties involved in the treatment of cancers: radiation oncologists, medical oncologists, interventional radiologists, gastroenterologists. And all of them together has changed the outcomes and made the quality of life as the center stage of treatment. What have we been doing? As I mentioned, operable cancer, surgery, plus or minus adjuvant therapy. The new paradigm says that surgery remains the main focus as far as treatment is concerned, but organ preservation comes in first as far as treatment options are concerned. There's an addition of neoadjuvant and adjuvant therapy. We'll come to that later. Survival has to be adequate. Survival has to be the same as any other modality, hopefully better. Reducing local recurrence rates has been the main focus, and increasing the rates of conservative surgery. How does neoadjuvant therapy theoretically help us? The first thing that we theoretically think of is by giving chemotherapy or dealing with the systemic disease. We do know that most cancers, even at a very early stage, develops what we call as micrometastasis. These are small cells that are in the circulation. This chemotherapy given prior to surgery addresses that problem, hence reduces the risk of recurrence and seeding. Second, the patient himself or herself is in a better condition to receive therapy. post surgery, many of them are morbid and their ability to tolerate treatment is not so good. Hence, in that sense, neoadjuvant therapy has a benefit. Third, it helps in selecting patients. So you have patients with borderline tumors, which might be borderline aggressive, borderline advanced, and by giving chemotherapy upfront, you are selecting those patients who respond and hence will benefit from definitive treatment. The non-responders generally don't do well and hence can avoid unnecessary surgery or unnecessary definitive treatment. And finally, you are dealing in an area which is a virgin territory, and we know from biological modules that the absorption and tolerance of treatment is better in the neoadjuvant setting as compared to the adjuvant or post-operative setting. Neoadjuvant implies prior to surgery or prior to any definitive treatment. The limitation obviously is that you have decided that this is a locally advanced or a borderline advanced tumor, and hence the necessity for added treatment, and so you base this on radiological investigations or sometimes endoscopic or even clinical investigations. And there is a risk of over-treating patients or overstaging patients. There is another limitation of progression on treatment and treatment-related toxicity, and finally compliance issues. So let's give examples to make you understand how organ preservation has helped and how it has kicked in as far as regular treatment is concerned. The most common example being rectal cancer. So we take a case scenario of a locally advanced rectal cancer. This is an MR with an endoscopic ultrasound. Shows in a 37-year-old male a very low rectal cancer at just 5 centimeters from the anal verge. He has local nodes which are seen both on the MRI and the endoscopic ultrasound. The conventional option would have been an abdominoperineal resection. What is an abdominoperineal resection? The word is self-describing. You have a patient who has a rectal cancer in the lower rectum. You have excised the entire tumor and you end up giving the patient a permanent colostomy because you are unable to join the or give the continuity of the intestine post-surgery. So what are the current options? What would you do today? In any patient of this type with a node positive rectal cancer, we always end up giving neoadjuvant therapy. This neoadjuvant therapy commonly is what we call as chemoradiation, radiation being the main treatment and chemotherapy being an add-on treatment. Sometimes we also add chemotherapy, but neoadjuvant implying that we first start off with some other treatment. Once this treatment is given, as you can see here, the MRI and the endoscopic ultrasound shows very good regression of the tumor. It has shrunk significantly, the nodes have shrunk, and here we can go ahead with what we call as an ultra low anterior resection, implying we save the normal passage, the continuity of the intestine is maintained, sphincter control is maintained, and this particular patient is still alive at 82 months disease free. So the newer paradigm says that as compared to a system where maybe 25 years back more than 40% of patients with these kind of situations ended up with a permanent stoma, less than 10% of patients require a permanent stoma today. The other thing that has also helped is obviously technology. We have staplers, we have laparoscopic minimal invasive devices, we have robotic devices which have improved visualization, improved technical handling of tissues, and hence gives us a better outcome as far as sphincter preservation is concerned. So a combination of strategy and surgical techniques have helped in outcomes. So the goal is to remove all gross and microscopic disease. That never changes with negative margins as far as both proximal distance and circumferential margins are concerned. But we try to preserve continuity and we try to preserve sphincter control. So we have different options. If you have a very early cancer, this is one strategy where you're talking in terms of a borderline tumor. Suppose you have a very early cancer, very low rectal cancer, T1 tumor. We have now endoscopic methods. We can actually do transanal excisions. These are called as TAMIS, as in transanal minimal invasive surgery, or TEMS, transanal endoscopic surgery. So these are techniques wherein again there is no compromise on oncological safety, but a patient with an early cancer who would have ended up with a permanent stoma ends up with a very minimal surgery with equal outcomes. And as I explained, for advanced cancers we have major surgeries. So the conceptual change, how would actually giving radiation help? How does it make a difference? As far as the overall concept, you have something called as a sterilized margin concept. So the whole thinking was you need a 1 centimeter, 2 centimeter, 0.5 centimeter. These were all various numbers which came up. But with radiation, with neoadjuvant therapy, these margins can be sterilized, implying a much smaller margin up to a millimeter is sufficient to call it as a safe oncological margin. Obviously, with a smaller margin, you can achieve greater conservational techniques. So the second point that always comes up, many times people ask me, why don't you just operate, then we'll give treatment later. That has also been addressed. I won't go into the details of that, whether treatment like in chemotherapy or radiation should be given prior to surgery or after. Neoadjuvant or prior to surgery is any day better than adjuvant therapy. So neoadjuvant is the standard. Another example, breast cancer. So breast cancer, again, we talk in terms of what is appropriate in these situations. We know early cancers, you can always do conservative surgery. These are small tumors. But let's take this lady, 45-year-old lady, no comorbidities. She comes up with a 5 by 4 centimeter tumor with purely orange or skin involvement. Axilla shows matted nodes. This is a locally advanced breast cancer. Mammography also shows a dense mass, isolated mass. A biopsy which was done confirmed malignancy, and a PET scan confirmed local disease with local matted nodes, no distant metastasis. As I mentioned, it was an infiltrated ductal carcinoma, ERPR positive, HER2 negative. We put in a marker clip to the tumor site, and I will explain that as we go ahead. What next? Ideally, this is an operable tumor. You can comfortably do a mastectomy. Should it be surgery first? Should it be systemic therapy followed by surgery? And what is the rationale of organ conservation? So this patient received 4 cycles of chemotherapy, was reassessed after 4 cycles, and the lump had completely regressed clinically and the nodes had regressed completely. So the rationale being that we, again, the same point that even at 0.5 to 1 centimeter you have cells in the circulation. You have a patient who is has an option of either a mastectomy or a breast conservation surgery, and if that patient wants to or desires to save her breast, there is no rational reason why you cannot do that, because as far as oncological safety is concerned, whether it is going to be a mastectomy or a breast conservation, the outcomes remain similar. So this patient underwent a segmental mastectomy with a 2 centimeter margin around the clip, and the clip was predominantly used because of this situation wherein after chemotherapy the tumor disappears, and using that clip we can actually go ahead and identify the same area where the tumor was initially there and do what we call as a wide local excision along with an axillary clearance. The final histopath confirmed a ductal carcinoma, the nodes were negative, the margins were negative. So the principle is the basic concept being a complete local excision or a mastectomy. Both of them fulfill the demands of an oncological surgery wherein the entire tumor is taken out with a margin and the nodes are either sampled, which is what we call as sentinel, or excised as per the demands of oncological surgery. The aim of treatment is to maximize disease control and to also give the best quality of life without compromising on the oncological outcomes. So in a breast conservation surgery, complete local excision has been done and the nodes have been adequately addressed. So this is just a small diagram to show what a lumpectomy or a wide excision would mean, and the evidence is based on trials which are more than 20 years old, which have confirmed that a breast conservational approach is equivalent to a mastectomy as far as outcomes are concerned. And this is the trial which will not go into the details, but this has confirmed the outcomes over a long period of time. So BCT is an acceptable treatment in lieu of mastectomy for patients with both early and locally advanced cancers in highly selected patients. A next approach, again for organ conservation, a laryngeal organ preservation strategy. Again, consider a concept of what constitutes a laryngeal conservation strategy. What are the normal functions of the larynx? Essentially, it's an organ which prevents your food particles to go into your respiratory tract. So it helps in phonation, is part of respiration, is part of airway protection, And so it's a very important organ, and it's one of the commonest areas for cancer, specifically in countries like ours, where tobacco chewing and smoking is very common. So conservative treatment came in because the only known treatment for laryngeal cancers was surgery or excision. And in patients who were going through excision, that would have meant a permanent stoma, which was a respiratory outlet in the neck, and loss of voice. So these are things which are not compatible with normal quality of life. And so the question came up, can we offer something better? We came up with many strategies. First came the surgical strategies, which were the open strategies. Then came the endoscopic strategies, which were both based on endoscopic laser surgery and robotic surgeries. And finally, the alternative strategies, wherein we used induction chemotherapy followed by radiation or concurrent chemoradiation as treatment options. So all these options have to be equivalent to the primary option, which was a laryngectomy or removal of the entire larynx. So the first thing that came up was open partial laryngeal surgery. This was the same principles as for total laryngectomy, but with negative margins. But with these kind of open partial laryngectomies, we could save the normal respiratory tract and give adequate voice control. But these are very technically demanding surgeries, and hence have gradually come out of circulation because of the advent of alternate easier options like endoscopic and treatment options like radiation and chemotherapy. Transoral endoscopic laser resections and robotic surgeries can be done for early laryngeal cancers. These are easily doable, have very less morbidity, very short operating times, almost minimal blood loss, and can be done with very low morbidity without any feeding tube or long-term morbid effects. It has similar oncological and functional outcomes as radiation in selected patients, and even if the endoscopic laser or robotic surgery fails, you can still go ahead with radiation as a salvage treatment. Non-surgical strategies have been based on trials. These are again very old trials with 10-year plus survival outcomes. The first one was the veteran trial, which said that induction chemotherapy followed by surgery for locally advanced laryngeal cancers, wherein at one time laryngectomy was the only choice, gave excellent survival and local control. There was improvement in communication, swallowing, and even the speech intelligibility, suggesting that the outcomes were equivalent to radical surgery. So you have a voice conservation protocol here working very well with just induction chemotherapy, induction implying chemotherapy to start with and radiation to consolidate. And you also had an option wherein you actually could select patients. So here was an kind of a dynamic process where you give chemotherapy, had a great response, completed with radiation, and if you didn't have a response, you would go ahead with radical surgery. The other option was the concurrent chemoradiation, which was also validated by trials, the RTOG study, and they also gave excellent oncological outcomes and great quality of life. So laryngeal preservation today is the standard of care. As a choice for most patients, we would go for conservational strategies rather than for radical neck dissections and radical removal of the larynx. And in case of recurrence or in case of failures, you would still have the option of radical surgery, but you would get a longer period of laryngectomy free life. In other words, you have a longer period with speech rather than having a permanent tracheostomy up front. So these are just various methods, and there are various organs which is very difficult to cover in a short period of time, but the thought process is clear that if you talk in terms of cancer treatment, it is more conservative than what was there 100 years back. From the Halstead's mastectomy to even something like a lumpectomy today is a long way to go. And thank you, and if there are any questions to go ahead, please go ahead.
Thank you, sir, for the lecture. We now have, do we have any questions for Dr. Hegde? So we have a question. What is the prevalence of recurrence in conservative breast after conservative breast surgery? For the first question, the recurrence is less than 2%. We have another question. What is the role of olaparib in BRCA positive patients, BRCA positive patients? So the answer to that is olaparib has a role both as adjuvant and in the metastatic setting as well. Thank you, sir. Are there any more questions? In addition to what Deshmukh sir had added, there's a little more that sir has sent, which says there is a significant survival advantage when olaparib is used. Thank you, sir. Are there any other questions? I believe there are no other questions. Thank you, sir, for your presentation, and thank you, Sanjay sir, for answering the questions. Our next presentation is by Dr. Gajanan Kanitkar, who is a consultant surgical oncologist at Ruby Hall, and he'll be presenting on laparoscopy and oncology.
Good afternoon. Today I have been given the task of speaking about the role of laparoscopy in cancer. So let us today discuss various aspects of laparoscopic surgery in the field of oncology. So my topic will be laparoscopy in surgical oncology, the current scenario, where I will present the latest evidence which is available, which supports or disproves the role of laparoscopic surgery in cancer. So what is laparoscopy? Basically the term comes from Greek words laparo meaning flank and scopine means to examine the flank. Laparoscopy is a minimally invasive surgical procedure because it requires much smaller incisions than traditional surgery does, causing less damage to nerves, muscles and skin. So if you look at the history of laparoscopy, the first ever laparoscopy was done by a German surgeon called George Kelling, who used the cystoscope, which is a scope which is used to see the urinary bladder. He used it through the abdominal wall to evaluate the effect of pneumoperitoneum in dogs. In 1921, Heinz Kark developed a superior laparoscope with improved lenses and is known as the father of modern laparoscopy. In 1936, Bosch, a Swiss gynecologist, first used the laparoscope to do a laparoscopic sterilization by electrocauterizing the fallopian tubes. After that, the role of laparoscopy grew a lot in the gynecologic community, but the surgeons were pretty late to pick up laparoscopy. You will be surprised to know that almost 50 years later, Eric Meux was the first man to do a laparoscopic cholecystectomy in 1986. In 1991, Jacobs was the first surgeon to do a laparoscopic anterior resection for cancer of the rectum. In 2002, we had the first scientific evidence which supported laparoscopy for colorectal cancer. So laparoscopy means minimally invasive surgery, where instead of large incisions, 5 or 10 mm incisions are taken. Long instruments are used which are specially designed for laparoscopy. 5 or 10 mm ports are used. A camera port is used. There are 3 or 4 working ports. Nowadays we have HD or high definition cameras, and now even we have gone further and we now have 3D or the 3-dimensional cameras, which makes the precision of surgery even better. What are the advantages of laparoscopy? Why are we talking about laparoscopy? Obviously there is less pain because there are smaller incisions, less post-operative hospital stay, earlier recovery from bowel function, earlier mobilization, less post-operative complications, and less immune response to surgical intervention, and therefore less inflammation. In this era where everyone has to go home or get to work very fast, laparoscopy has become especially more popular because the time required to get back to your normal work is less as compared to open surgery, and therefore laparoscopy is getting more and more popularity. Now what we will start with is called as a diagnostic laparoscopy. So always there are certain situations where we need to do a diagnostic laparoscopy before we go ahead and open and take a big cut on the patient. So what is the diagnostic principle laparoscopy? The general principles are that it is used to determine feasibility of a proposed curative cancer operation. For example, in gastric cancer, there is a very high chance of having peritoneal metastasis in about 20 to 30% chance of having peritoneal metastasis. And sometimes what happens is that we take a big cut, open the patient, and then we realize that, oh, this patient has peritoneal mets, and therefore we cannot go ahead with a curative resection and we have to reverse. But then a big cut has been taken on the patient. Now this can be avoided with a diagnostic laparoscopy. The goal is for a primary digestive malignancy is to identify or disprove the presence of local, regional or metastatic disease. It also aids in identifying extra-organ disease that would preclude an attempt for intended curative resection. Assessment of resectability with curative intent of the following primary digestive cancers can be done with a diagnostic laparoscopy. As I mentioned earlier, esophageal cancer at the gastrofacial junction has a very high chance of peritoneal metastasis, gastric cancer, pancreatic cancer, biliary tract cancers like cholangiocarcinomas or gallbladder cancers, and staging prior to administration of neoadjuvant chemotherapy or radiation therapy in certain cancers can be done. Assessment of inconclusive histology following failed attempts at biopsy. Definitely, now in this situation, there are patients sometimes where multiple biopsies are attempted, CT guided biopsies, USG guided biopsies, but we don't get adequate tissue because the tissue might be in a difficult area to access, or it might be adequate amount of tissue may not be coming. In this situation, a diagnostic laparoscopy helps us because we can go in, put a scope, put in a port and take an adequate sample of the tissue for biopsy. Let us start with individual cancers now and the role of laparoscopy in these cancers. Let us start with gastric cancer. In gastric cancer, a staging laparoscopy is one of the almost mandatory procedures which is done before opening every patient. The advantage of directly visualizing the liver surface, peritoneum and local lymph nodes and permitting biopsy of any suspicious lesions which is offered by diagnostic laparoscopy is invaluable. Radiologically occult metastases which have not been seen on any imaging can be identified, avoiding unnecessary exploratory laparotomies. At laparoscopy, peritoneal metastases are documented in 20 to 30% of the patients with gastric cancer, and here unnecessary exploratory laparotomies are avoided. Any lesion which is more than T1 on staging warrants a staging laparoscopy in gastric cancer. Also considered in patients requiring neoadjuvant therapy for gastric cancer. So what is the clinical evidence for that? In 2016, a Cochrane analysis of 13 randomized trials which compared laparoscopic and open gastrectomy resulted in similar short and long-term outcomes, including mortality rate, recurrence rates, positive margin rate, complications rate, length of hospital stay and requirement of post-operative blood transfusion. In the Korean trial, which was also called as the CLASS trial, conducted between 2011 to 2015, over 1,000 patients were randomized and are randomly assigned to laparoscopy or open group, and both underwent a D2 lymphadenectomy, a lymph node dissection. The laparoscopy group showed a lower 30-day mortality rate, lower patient reported pain scores, less post-operative analgesic use, earlier passage of flatus and a shorter hospital stay. The mean number of lymph nodes retrieved was absolutely the same, 90-day mortality rates were absolutely the same, and at 3 years relapse-free survival was also comparable with the open group. Therefore, laparoscopy was comparable with open surgery in gastric cancer. So, which are the patients to be selected? Generally, T1 to T3 lesions are the patients who should be selected for laparoscopy. It should not involve other organs. There should be no significant lymphadenopathy. It should be done at a high volume center by a trained surgeon. Now, this is applicable for all laparoscopic cancer resections. It should always be done by a trained surgeon who has adequately trained in this procedure, because these are complex procedures not to be attempted by novices. Additional support of critical care intensivists, therapeutic gastroenterologists, interventional radiologists may be required at these centers, and it should be available before you go ahead for advanced laparoscopic resections. Also, we need good physiotherapy and good nutritional support after surgeries. Coming to colonic cancer, meta-analysis of randomized trials demonstrates faster recovery with no detrimental impact on recurrence or survival for laparoscopic compared to open colectomy for treatment of colon cancer. In the largest trial called as the COST trial, where almost 872 patients were randomly assigned to open and laparoscopy group, operative time was significantly more. In laparoscopy arm, definitely the operative time was significantly more, but on the other hand, they had shorter duration of hospital stay and less use of parenteral analgesics. There was no significant difference in intraoperative or postoperative complication rates, perioperative mortality rates, readmission or reoperation rates, and rates of surgical wound recurrence. At median follow-up of 7 years, there was no significant difference in the 5-year survival, disease-free survival rate in the laparoscopy versus the open arm. Coming to rectal cancer, as I mentioned earlier, colorectal cancers were the first cancers where we got level 1 evidence to show that laparoscopy was equivalent to open surgery, if not better. So in rectal cancer also there was a big trial, there have been big trials which compared laparoscopy versus open surgery. One of the most important points when you do rectal cancer surgery is total mesorectal excision. All the lymph nodes of the rectal cancer are present in the mesorectum, and if you remove the mesorectum properly, that is the key to success in rectal cancer treatment. So and if you can do total mesorectal excision properly, as good as open surgery by a laparoscopic technique, then you are good to go. So total mesorectal excision remains the most important surgical point in rectal cancer. Rectal cancer management has changed a lot with the advent of neoadjuvant chemoradiation. Any cancer with perirectal nodes and perirectal disease will straight away go for neoadjuvant chemoradiation and not be considered for surgery. However, T3 tumors are not a contraindication for laparoscopic resection. The Color, Classic and Korean trials have reported a similar 3-year local recurrence rate, 5-year disease-free survival rate between open and laparoscopic groups. Added shorter hospital stay, earlier recovery from bowel function and less pain have been clearly shown in the laparoscopic arm. However, the long-term results beyond 10 years of disease-free survival remain to be seen in laparoscopic versus open surgery. In esophageal cancers, we can do a laparoscopic esophagectomy in 3 different ways. A video-assisted thoracoscopic esophagectomy, where the thoracic dissection of the esophagus is done with the help of a laparoscope. Transhiatal laparoscopic esophagectomy, where the laparoscope goes into the thorax via the hiatus between the gastroesophageal junction. And thoracoscopic Ivor-Lewis esophagectomy. A thoracotomy, we all know that once we open the chest of the patient, the vital capacity of the patient goes down by 40%. Vital capacity means the ability to take big breaths. Thoracotomy will reduce the vital capacity by 40% and is very painful. Thoracoscopy avoids pain and chest complications, because if the patient has pain in the chest, he won't breathe and he will have chest complications like pneumonia, which can be avoided with a thoracoscopy. However, in operable lower third esophagus adenocarcinomas, nowadays we all give neoadjuvant chemotherapy before we take them up for surgery. The best evidence comes from the TIME trial, which has found that patients undergoing a total minimally invasive esophagectomy have a better perioperative hospital course. Lower rate of pulmonary infections is seen compared to open esophagectomy. Lower perioperative rate of pulmonary infections, and a follow-up has shown a similar 3-year disease-free survival and overall survival. Coming to now let's go to the group of gynec cancers, where gynec cancers have shown a little bit of a mixed bag. If we look at endometrial cancers, cancer of the uterine endometrium, it is a mixed bag. The surgical outcomes comparing laparoscopy versus open surgery are similar. 5-year survival and recurrent rates are close to 89%. However, more conversion rates to open surgery have been reported, almost 25%. And especially with obese patients having a BMI above 40. A systematic review of almost 3,500 women with endometrial cancer included data from 8 randomized trials. There was no evidence in the difference in the risk of death or recurrence between women who underwent laparoscopy compared with laparotomy. In two separate sub-meta-analysis, there was less blood loss with laparoscopy and few severe postoperative adverse events compared with laparotomy. This is a slight advantage which we have in doing a laparoscopic endometrial doing a laparoscopic radical hysterectomy for endometrial cancer. Coming to ovarian cancer, most of our patients present to us with large ovarian masses. Now, intact removal of this large ovarian masses often is not possible when you do a laparoscopy, because the laparoscopy incisions are very small. And if you try to aspirate the mass, make it small in size, and then try to take it out through a smaller incision, rupture of the mass can occur, and it can actually worsen the prognosis by spreading the disease in the peritoneal cavity. Therefore, in ovarian cancer, the role of laparoscopic surgery remains limited. It has been limited to stage 1 epithelial ovarian cancers, and here also capsule rupture occurred more frequently in patients undergoing laparoscopic surgery compared with laparotomy, and it has been associated with increase in all-cause mortality in both the groups. Thorough inspection of the entire pelvis and abdomen, especially inspection of all bowel surfaces and mesentery, is challenging when you do it laparoscopically or as compared to when you do it in open surgery. Tumor seeding of the laparoscopic access sites, that is the port sites, has been considered as a possibility, and this usually happens in the setting of peritoneal carcinomatosis, where the patient already has peritoneal disease or has positive peritoneal cytology, which often resolves with adjuvant therapy. Therefore, the role of laparoscopy in ovarian cancer remains a little bit doubtful, and is limited to absolutely early stage 1 ovarian cancers, which are very small in size. Coming to the last cancer which I am talking about, cervical cancer, that is the cancer of the uterine cervix. This is one cancer where clearly laparoscopy has not been shown to be beneficial to the patient. A randomized trial included 631 patients with stage 1A, 1A2 and 1B1 cervical cancers who were assigned to radical hysterectomy using minimally invasive techniques or laparotomy. Most patients had stage 1B1 disease. The minimally invasive group had a lower rate of disease-free survival at 4.5 years and lower disease-free survival overall. Overall survival and higher rate of death because of cervical cancer was seen in the minimally invasive group. Therefore, this is one particular cancer where I would not suggest that patients should go for laparoscopy. Similarly, a meta-analysis of 15 observational studies, including almost 9,500 patients undergoing radical hysterectomy for stage 1A to 2A cervical cancer, compared minimally invasive and open surgery, and was associated with higher risk of recurrence or death in minimally invasive surgery arm. Therefore, in ovarian cancer and cervical cancer, definitely very limited role for laparoscopy. In endometrial cancer, it's a mixed bag. You can use it for selected patients. So in total, I have tried to summarize the common cancers, common GI cancers and gynecologic cancers where we can use laparoscopy, and what is the role of laparoscopy in it in all these diseases. To summarize, laparoscopy in cancer is to be used with caution, will benefit a select group of patients who have early disease. Organ confined disease, early stages will benefit the most, will prevent unnecessary explorations or unnecessary surgeries on patients. Surgeon credential is very important to proceed for laparoscopic surgery. Judicious patient selection is the key to laparoscopic surgery. I hope I have been able to help you with some information on laparoscopy, the role of laparoscopic surgery in cancer. Thank you very much. Thank you all for your attention.
Thank you so much, sir. Are there any questions for Dr. Gajanan here?
जर तुम्ही खाली खाली जर तुम्ही माझ्याकडूनच घेतला.
I request you to please post your questions for Dr. Kanetkar, if there are any. I believe sir's talk has made it pretty clear and we don't have any questions. Thank you so much, sir, for your presentation. We'll now be moving on to session 4, which is chaired by Dr. Minish Jain. And our first presentation is by Dr. Neeraj Dhingra, who is a consultant radiation oncologist, and he'll be talking on the basics of radiation oncology.
Hello everybody, I am Dr. Neeraj Dhingra. I am a consultant in the Department of Radiation Oncology at Ruby Hall Clinic, Pune. The topic of my presentation is Introduction to Radiation Oncology. So, the objectives for today's presentation are to learn how radiation therapy is incorporated into multidisciplinary cancer care and to understand the basic principles of radiation oncology. Radiation oncology is a branch which is not a very popular branch amongst many physicians because many are not aware of it. So today I will try to throw some light on what are the basics and how we treat the patients. First of all, what is a tumor? So a tumor is a swelling of a part of the body which is generally without an inflammation and is caused by an abnormal growth of tissue. It can be either benign or malignant, which is commonly termed as a cancer. Now, oncology is the study and treatment of these cancers mostly. As we can see in this pic, there is a meningioma as well as a grade 4 glioblastoma. Both are considered tumors, whereas the first one is a benign tumor, the second one is a malignant tumor. For the treatment of cancer patients, the treatment modalities are basically 3 currently. The first one, which is most commonly known to everyone, is a surgical oncologist. He is like the army who does the surgical removal of the cancers by going in locally and removing as much of the cancer as possible. Second important component is the medical oncologist, who is like the Navy. He gives chemotherapy and immunotherapy through blood or by oral route, and it works systematically. Third and our branch is the radiation oncologist, and we can be ascribed to like as the Air Force. We are totally non-invasive. We use high energy photons to cause a local effect in the desired cancer tissue. Now, a surgical oncologist mostly functions in a definitive setting, whereas a medical and a radiation oncologist work both in a definitive and palliative care for cancer patients. All are equal partners in cancer care and all work together to manage the cancer patients. Now, surgery and radiation are mainly local and loco-regional therapies. Chemotherapy is a systemic therapy. Chemotherapy is a primary treatment for all hematological malignancies, whereas surgery or radiation is primary treatment for solid malignancies unless they are metastatic, in which medical oncologist takes over. A combination of these 3 therapies are used for almost all cancers, and a cancer patient and around 1/2 to 2/3 of patients with cancer will receive radiation at some point in their treatment course. Now, when people hear the word radiation, they often think like the atomic bomb blast which happened in Nagasaki, or a caution, which is because radiation is obviously a dangerous thing to handle. But the reality of medical use of radiation therapy is very different. Now, if we go for the indications of treatment with radiation therapy, it's an important component of curative treatment, either alone or in combination with surgery, chemotherapy and immunotherapy. Also, radiation is a very effective palliative treatment of symptoms from advanced cancers that are no longer curable. Whether used for curative or palliative indications, radiation can provide a quality of life benefit that may not be possible with the other modalities. Radiation therapy can be used as a complement to surgery. For example, after surgery, when it is used, it is called as adjuvant treatment, and it can eradicate microscopic tumor cells in a post-op tumor bed or nodal region. The examples for such treatment include the treatment of breast cancers, soft tissue sarcomas, malignant gliomas, even in uterine cancers. Also, radiation can be used before surgery to downstage a tumor and make it more amenable to surgical resection, which is known as a neoadjuvant treatment. Examples of such cases nowadays include treatment of rectal cancers, esophageal cancers, and so on. Radiotherapy can also be used definitively instead of surgery with comparable probability of cure. The potential reasons for not involvement of surgery in such cases are that not all tumors are surgically resectable, not all patients are medically operable, some cancer surgeries are very morbid, and in some cases organ conservation or organ preservation is desirable. Examples for such treatments include cancers of CA prostate, where after a stage radiation is given instead of surgery. Even in cervix and larynx or pharynx pharyngeal cases, surgeries are quite morbid and more often than not they require adjuvant radiation also. So it has been found out that going for definitive radiation therapy along with concurrent chemotherapy can give the same benefits as opposed to doing a surgery and following it up with a radiation or chemotherapy. Also, nowadays with the advent of oligometastatic cancer spectrum, a local consolidative therapy can be used with the help of radiotherapy. Moving on to palliative care, many times the cancers are metastatic in nature and we need to go for some specific symptomatic control for the patient. With these can be done with the help of radiotherapy because it's non-invasive in its approach. Some examples of such indications are for painful bony metastasis, we can give radiotherapy. 5 to 10 days of radiation will cure the pain and kill the metastatic disease in that particular bony region. Similarly, if there are brain metastasis or there is a spinal cord compression, then palliative radiotherapy can be given. If there is a bleeding in case of a cancer bladder or cancer cervix or even hemoptysis in the cases of cancer lung, a palliative RT of a short duration 5 to 10 days can be given to the patient. In certain cases of obstruction like a superior vena cava obstruction or an airway obstruction leading to dyspnea or esophageal obstruction leading to dysphagia which is not relieved by chemotherapy, in such cases we can give palliative radiation and it can give certain amount of symptom control to the patient. Now, what is the radiobiological basis for radiation therapy? Primarily, radiation therapy works by damaging the DNA of cells and destroys their ability to reproduce. Now, both normal and cancer cells can be affected by radiation, but cancer cells generally have by definition an impaired ability to repair this damage, which leads to their quicker cell death. Now, all tissues have a tolerance level which we have to respect, and hence radiation therapy cannot be given to unlimited doses. We have to respect the dose threshold levels of the normal tissue, and hence the dose profiles have been regulated. Now, how does radiation work? As we can see, this is the double helix model of DNA. There is a direct action and an indirect action of the radiation. These X-rays, the direct action is direct damage of the DNA because of the high energy that they impart to the electrons of the DNA molecules. Secondly, there is an indirect action which is like X-rays first interact with water, which leads to the formation of free radicals like hydrogen peroxide. These free radicals then bind to and damage the DNA, and which leads to the cell death by mitotic catastrophe. In this radiobiology, we have a consideration of the 4 R's of radiobiology, and these are believed to affect the tissue's response to fractionated radiation. These 4 R's are the repair of sublethal damage to cells, which happens between fractions of radiation. Second is repopulation or regrowth of cells between these fractions. As radiation occurs, because it is given fractionated over a period of time, say 5 to 6 weeks, repopulation of cancer cells can happen in between the fractions of radiation. Redistribution of cells into radiosensitive phases of cell cycle. This helps in cancer treatment because the cells usually go through a cell cycle, and as cells are most sensitive in the G2M phase, they are killed off when radiation is given, and the other nearby cells then move forward in their cell cycle to proceed to G2M phase, in which they are again killed. So this redistribution actually helps in killing of tumor cells. Reoxygenation of hypoxic cells is the 4th R, and it makes them more sensitive to radiation. What we are usually treating patients are of the radiation is of 2 types. One is external beam radiation therapy, which takes place with the help of the older generation cobalt machines or the newer generation linear accelerators. And the second is an internal type of radiation, which is by implanting the sources of radiation directly into the tumor or in close proximity to the tumor, which is known as internal radiation or brachytherapy. Here is an example of a linear accelerator which is used to treat with external beam radiation therapy. Now, the team of a radiation oncology comprises of the radiation oncologist, the doctor. There is a medical physicist who makes the treatment plans according to the complicated softwares and algorithms of the machine. There is a radiation therapist who is who are trained professionals who are directly on the machine, and they are responsible for daily treatment of the patients, and the radiation oncology nurse. Now, a linear accelerator or a LINAC delivers high energy X-rays or photons or electrons to the patient. It is a totally non-invasive procedure, and the treatment delivery is very rapid. It is often in 5 to 10 minutes daily. Now, how we treat the patient? After the decision is made that the patient is to be treated, a simulation is done in which the patient is positioned and the immobilization device is placed so that the patient does not move during the treatment, and it is reproducible. There are different types of immobilization devices like an alpha cradle or a VACLOC or an Orifit mask that is used in our department. After that, a CT scan is taken of the desired region of interest and the patient is marked. Afterwards, these scans come on our planning monitors and we draw the targets on the planning CT with image fusion with a PET or MRIs as required, and planning volumes are given. These planning volumes are known as a gross tumor volume, a clinical target volume, and a planning target volume. And based on these, then the plan is passed over the physicist who generates a treatment plan on the computer, and then this is evaluated by the radiation oncologist by various techniques like isodose curve or a dose volume histogram to assess whether the dose that is required to the tumor is going, and simultaneously we are able to save the other organs at risk in the vicinity. Now, there are different types of external beam radiation therapy as it is evolving. Earlier, the patients were treated with two-dimensional approach in which patients were directly treated with the help of anatomic landmarks. But with the advent of CT scans and X-rays and CT scans, now we are being able to treat the patients with various high techniques which are like 3D CRT, IMRT, IGRT, SRS SBRT, and even now particle beam therapy is also being used for the treatment. Now, sometimes a simple treatment plan is sufficient. For example, in an adjuvant RT for right-sided breast cancer, a two-field plan from a medial and lateral side is sufficient to treat the area of interest. Or in a palliative treatment to most bone metastasis, we can treat with a simple two-field plan. However, in most of the radical or an adjuvant or neoadjuvant case, an IMRT or a 3D CRT plan is required. This is made possible with the help of multi-leaf collimators, which are small leaves which can distribute the radiation as our desire and can dynamically modulate the dose intensity around a curved target volume. It enables a dose escalation or reduction in toxicity, and it is valuable in curative and re-irradiation settings. As we can see in these images, a 3D CRT plan of the CA prostate in this patient, we are able to treat the prostate while simultaneously being able to save the anteriorly bladder, the posteriorly rectum, and the sideways on the both sides the femur heads are there. So all these target is given a high dose, whereas the organs at risk are saved simultaneously. Now, other examples of IMRT treatment planning, we can see that in cases of CNS gliomas, head and neck cancers, lung cancers, or prostate cancers, the dose volume is beautifully controlled. The dose profile is beautifully controlled so that only the tumor, which is our area of interest, is treated with high doses, while simultaneously the other organs at risk are saved. Now, image guided treatment delivery or IGRT accounts for daily shifts in soft tissue anatomy or patient setup, and it enables reduced margin around tumor because we are doing a daily CBCT for assessing whether the patient positioning is perfect, and hence the risk of toxicity is reduced. Now, radiation doses are generally calibrated in the units of Gray, where 1 Gray is equal to 100 centigrade. Usually we are treating patients with conventional fractionation to the amount of 1.8 to 2.2 Gray per day, and 1 centigrade is the dose which is roughly equals to 1 CT scan. So you can appreciate the high amount of doses of radiation that are being given to the patients for curing cancer. Now, the goal of treatment or the dose prescription depends whether the intent is curative or palliative, what is the amount of disease, whether it is gross or only microscopic in level, the radiation sensitivity of tumor, and the radiation sensitivity of surrounding normal tissue. Now, radiation therapy is delivered, it is totally painless, non-invasive, and is usually given fractionated. That means it is scheduled for 5 days a week for 1 week to 10 week duration as the situation demands. The effect of radiation therapy is usually cumulative, with most significant side effects occurring near the end of the treatment course. These side effects also usually resolve over the course of a few weeks after the treatment is over. and there is a slight risk that radiation may cause a secondary cancer many years after treatment, but the risk is outweighed by the potential for curative treatment with radiation therapy. Now, a strict safety and quality assurance program is in place in all the centers and our center also, and the medical physicist daily and weekly calibrations happen on the renal accelerator to make sure that the patient is being delivered while simultaneously it is totally safe to the surrounding regions and also the treating technologists and the doctors that are sitting in the vicinity of the machine. The total dose is delivered in a series of daily fractions on 5 days a week, and the fractionation decreases the risk of toxicity by allowing the DNA repair in the normal tissue. The potency or biological effective dose of a radiation course depends not only upon the total dose, but how that dose is fractionated and how that tissue is irradiated. Now, a new technology has come up in recent times, and this is known as stereotaxy. Now, I will go in a little detail about stereotactic radiosurgery. This is basically the use of high dose per fraction of radiation in a very focused and precise way, which leads to a high probability of local control. Now, obviously, all patients are not the candidates for such a treatment. It can be done safely for well-defined small, medium to size targets using most advanced treatment technologies to deliver this very potent dose safely. So, this stereotaxy can be either stereotactic radiosurgery, which is known as SRS, or stereotactic radiotherapy, SRT, which is done for targets in brain, or it can be stereotactic body radiotherapy, SBRT, which is referred to stereotactic surgeries in the rest of the body except the brain. So, when the treatment is done in single fraction in brain, it is known as SRS. When it is done in 2 to 5 fractions in brain, it is known as SRT. The RT is highly conformal, and these are very high doses that are given to well-defined targets to achieve the total tumor elimination. Some common indications for such treatment are for benign tumors like acoustic schwannomas, meningiomas, or arteriovenous malformations, whereas for malignant tumors like brain metastasis and recurrent gliomas, stereotaxy is used. If it is done in the other parts of the body except the brain, it is known as SBRT. And again, the principle is the same, that high doses are given conformally in 1 to 5 fractions to the well-defined targets. It uses sophisticated imaging, treatment planning, and immobilization techniques. Some indications for these treatments are when we are going for radical treatment like in a CL lung, T1, T2, N0 CL lung, or in a CA prostate, low to high risk, we can use SBRT for treatment. Even for metastatic lesions, which includes well-defined nodes, bone, liver or lung lesions that are symptomatic or in an oligometastatic spectrum, nowadays SBRT is used for these tumor cells elimination. Now, there are special stereotactic radiosurgery treatment platforms which are available in market and are used by some centers across the country. The most commonly known is the Gamma knife, which is basically a 192 cobalt 60 source machine, and it is used to treat brain tumors with high precision. Similarly, Cyber knife is another machine which is used for stereotaxy. It has a robotic arm which can treat tumors throughout the body with a 6 degree of motion. It has high precision and long treatment times. It is known as X knife or Cyber knife. Similarly, particle beam therapy is also known as proton beam therapy, and other things are also available but not in India, like carbon ion therapy. So these are also used to treat patients with radiation. Now, a proton beam therapy, I will not go into much details, but it has certain advantages over photon IMRT, that in its dose distribution it gives less low to intermediate dose to surrounding tissues. As we can see in these images, in a photon the treatment region gets high dose, but there is a low dose spillage across the body, whereas with the proton beam the high dose region receives the required dose, whereas the low to intermediate dose spillage is absolutely negligible in the other parts of the body. Hence, it reduces the risk of long-term side effects in pediatric malignancies, and currently its benefits are under investigation in many of the tumors. However, it is very cost intensive, and a single treatment protocol for a patient can be in the cost of around 25 to 30 lakhs, and it's currently available in only one center in India, that is in Apollo, Chennai. Now, the second type of therapy, that is brachytherapy, which is delivered at mostly all the centers, is basically the short distance therapy, which is by the help of a radioactive implant, and it is more than 100 years old since radioactivity was discovered. Now the radioactive source is placed on or inside the tumor, and hence it can be defined as a temporary or a permanent implant. There are many radioactive sources available which can be used as per the indications, and the major advantage is that it allows dose escalation by sparing normal tissue. Now what we commonly use is an intracavitary brachytherapy application, which is used for cancers of cervix or cancers of endometrium. And similarly, there can be interstitial implants in the cases of gynecological malignancies also, or a prostate seed implant which is done for low risk CA prostates, and the dose distribution is very beautiful and the dose follow-up is very rapid, so that the high dose region is limited to the area under the implant and the dose follow-up is very quick. Interstitial brachytherapy can also be done for some well-defined targets, like for example in these pictures we can see a hard palate lesion or a breast lesion or a sarcoma which is treated with an interstitial implant. Now being a radiation oncologist, the treatment modality itself is rewarding because you get to cure cancer every day. Also, it is important to understand that there is no radiation exposure for us treating radiation oncologists, because we adhere to the strict guidelines as mandated by BARC, and the radiation exposure is negligible to the person sitting outside the treatment room. Now we have a variety of patients which leads to short and long-term meaningful relationships, and the treatment is a major part of our daily routine. Cancer is intellectually stimulating because treatment approaches now are evolving with time. There is much more still to learn about cancer, and the technology is evolving day by day, and a lot of procedure opportunities also come up to us. Also, the benefit of being in radiation oncology is that it is an outpatient hours job and there are fewer emergencies in life, so there is a plenty of time to do research, teach or enjoy life. Surgery is the historical standard, and surgery has also evolved and improved over time with the impact that now bigger surgeries or radical surgeries are giving place to smaller surgeries. The smallest surgery which can lead to a cancer elimination is being preferred, and also big open surgeries are being replaced by laparoscopic and robotic surgeries. But by nature it is limited by its invasiveness, and in all areas of medicine there is a trend towards developing less invasive techniques and being more judicious with their application. So systemic therapy and radiation have great potential, and both modalities have become very target oriented and individual planning is required. They are mostly non-invasive, complementary and synergistic in their nature. Now radiation and systemic therapy will continue to improve, and we are hopeful that in a few years of time delivery of radiation will become even more precise with lesser side effects, and we will have better drugs to sensitize cancer cells with radiation synergistically. So in summary, radiation therapy is a well-established modality for the treatment of numerous malignancies, and we are specialists trained to treat cancer with a variety of forms of radiation. Treatment delivery is safe, quick, non-invasive and painless. So feel free to refer patients. Thank you.
Thank you so much, sir. Are there any questions for Dr. Neeraj? Please send in your questions for Dr. Neeraj now. Thank you. I believe there are no questions. So thank you so much, sir, for the presentation. Our next presentation is by Dr. Shweta Mutta, who is a consultant radiation oncologist, and she'll be presenting on radiation complications and strategies to prevent them.
Good afternoon, everyone. I'm Dr. Shweta Mutta, and I'm consultant radiation oncologist at Ruby Hall Clinic. So today I will be discussing about radiation complications and strategies to prevent them. So let's begin. It has been estimated that more than 70% of all cancer patients receive RT throughout the course of the disease. Besides tumor sterility and tumoricidal effects, radiotherapy has potential to affect normal tissues, causing tissue damage in RT fields or systemic side effects like fatigue. Newer techniques like intensity modulated radiation therapy, image guided radiotherapy, deep inspiratory breath hold, and focal treatments such as stereotactic radiosurgeries have changed the adverse effects immensely. So, radiation therapy side effects can be divided as acute and late. Acute occur during treatment or within 3 months after treatment, and late occur 3 months after completion of treatment. So, we will be discussing about the factors influencing complications of radiotherapy. So, it largely depends on the site being irradiated and tissue or organs in that area. Like say breast cancer patients where the chest wall is irradiated, and head and neck cancer patients where face and neck is irradiated, volume of the irradiated site, total dose per fraction, frequency of dose fraction, performance status of the patient, and any associated comorbidities, use of concurrent chemotherapy. So now I will be discussing about the acute side effects and late side effects. Acute side effects. Acute side effects, they are type of deterministic effects, that is, have distinctive thresholds and there is direct relation with delivered dose and severity. And it mostly occurs in rapidly dividing cells, example, GI mucosa, hematopoietic system. It results from damage to large number of cells. And severe acute side effects can lead to consequential late effects. Late side effects, they are mainly observed in tissues with slowly proliferating cells like lungs, kidney, heart, central nervous system. It is slowly progressive and often irreversible. It is improved but never completely repaired. It results from a combination of vascular damage and loss of parenchymal cells. Much more sensitive to changes in fractionation than acute effects. Functional subunits, when arranged as link of chains, integrity of each is important for organ function, and elimination of any one's functional subunit results in complication. Example, spinal cord. And in these cases, we see Dmax, that is point dose, which should not be greater than 45 gray for spinal cord. And in organs arranged in parallel like liver, lung, severity is related to the irradiated tissue volume above threshold. For example, for lung, we see volume receiving 20 gray, which should be less than 20%. So, these are the commonly used scales to report side effects. They are RTOG, National Cancer Institute, Common Toxicity Criteria, EORTC, Lent and SOMA. So, side effects can be graded as 0, 1, 2, 3, 4. That is mild, moderate, severe and life-threatening. Now we will be discussing about the radiation-induced nausea and vomiting. How it is caused by radiotherapy. It is mainly caused by damage to enterochromaffin cells of GI mucosa, leading to release of serotonin, which activates serotonin receptors, visceral efferent fibers, and chemoreceptor trigger zone in brainstem. So when we are radiating brain, there is increase in intracranial pressure leading to due to radiation-induced edema and inflammation. Latent period for radiation-induced nausea and vomiting is 30 minutes to 4 hours for single fraction study and 3 to 4 days after fractionated RT. And it is more common after total body irradiation, hemi body irradiation, craniospinal irradiation, whole brain RT, pelvic irradiation and upper abdomen irradiation, where a major part of the intestine is involved, and for field sizes more than 400 centimeter square. What is the prevention and management strategy? So prophylactic use of 5-HT3 receptor antagonists like granisetron and ondansetron, steroids like dexamethasone and dopamine receptor antagonist like metoclopramide helps in preventing radiation-induced nausea and vomiting. Hematological side effects, it can be graded as 1, 2, 3, 4. So basically what is more important is neutrophils, and when it is less than 1000 per ml, we use filgrastim or pegfilgrastim. When thrombocytopenia is less than 10, when platelet count is less than 10,000 per ml, platelet transfusion is done. And when there is severe anemia, peg cell transfusion is done. So coming to radiation dermatitis, it is especially seen in radiotherapy for breast cancer, head and neck cancer, lung cancer and sarcoma due to superficial position of these cancer. and there is always inter-individual variation. Mechanism, it is direct cellular injury and inflammatory cell influx, cellular damage to the epidermal basal cells, endothelial cells, Langerhans cells, and vascular component. Timing, we can see erythematous reaction at second and third week, dry desquamation after third week, that is at approximately 30 gray of dose, moist desquamation at 4th to 5th week, which is at approximately 45 to 60 gray. And post-inflammatory hyperpigmentation may persist for 5 to 7 weeks after RT. Risk factors, beam energy. When low beam energy is used, skin gets more radiation. Junction between electron and photon fields, use of bolus, concurrent systemic therapy, concurrent cetuximab use, smoking, advanced age, obesity, breast implants, serum aspiration after breast surgery, and skin folds. Prevention. Washing the irradiated area daily with water and mild soap or normal saline, wearing loose clothing, avoid skin irritants, extreme cold and heat, and avoid sun exposure. One can use prophylactic 1% hydrocortisone, and then advanced technique like IMRT, IGRT, low level laser therapy, oral ascorbic acid, oral zinc, friction protection with soft dressing in areas like axilla. And once it develops, what we are supposed to do, we can use topical steroids, normal saline compresses, hydrocolloid dressings, and silicone foam skin dressings. So here we can see this is grade 0, grade 1, grade 2, and grade 3 and grade 4 skin reaction. Grade 4 skin reaction consists of ulceration. Grade 3, there is moist desquamation. Oral mucositis. It is mostly seen in head and neck cancer patients and can cause significant pain, difficulty in swallowing, pain during swallowing, and can lead to dehydration, malnutrition, and treatment breaks. Why is it caused? Because there is damage to DNA of rapidly dividing cells of oral epithelium. Radiation generates oxidative stress and reactive oxygen species, leading to tissue damage by activating a number of transcription factors. And there is increase in pro-inflammatory cytokines, which leads to connective tissue and endothelium injury. Timing. Mucosal erythema with mild discomfort can be seen at 1 to 2 weeks after starting RT. That is approximately that corresponds to 10 to 20 gray. Patchy pseudomembranous formation after 2 weeks at the dose of 20 gray. Ulcerative mucositis at doses more than 30 gray, which peaks at 4th to 5th week. Generally, it takes 3 to 6 weeks post RT to resolve. What are the risk factors? Metallic dental restoration, pre-existing periodontal disease, low body mass index, genetic susceptibility, altered fractionation, and it is more commonly seen in oral cavity cancers, which involves lateral border and ventral surface of the tongue, floor of the mouth, and soft palate. Because these are the areas where there is high cell turnover. Prevention. Cleaning teeth with toothpaste and soft brush after each meal, dental flossing once daily, dental screening before starting RT. If there is any bad tooth, that has to be extracted 10 to 21 days before starting radiotherapy. Rinsing the mouth 4 times a day, moisten the lips, they shouldn't be dry, adequate fluid intake, avoid alcohol, tobacco, caffeine, high sugar, highly acidic foods, crunchy food. Oral glutamine, zinc supplements, and natural honey are helpful, and use of IMRT technique. And how should one manage these patients if oral mucositis sets in? These patients should be weekly assessed to see the progression of oral mucositis. Systemic analgesia via benzidamine mouthwash, doxepin oral rinse at 25 mg diluted in 5 ml of water for 1 minute 3 to 6 times a day, hydrocortisone 2.5 mg buccal tablet for oral use, gabapentin for neuropathic pain, low level laser therapy, treatment of any underlying infection, nutrition support through Ryle's tube, magic mouthwash, and then there is oral gel known as Gelclair, acetylcysteine, oral rinses, which has mucolytic effect. So these are the pictures showing grade 1, grade 2, grade 3 and grade 4 oral mucositis. See, in grade 3 there is extensive erythema and formation of ulcers, and in grade 4 this mucositis is more severe and there is confluent patches. Xerostomia. It is most commonly seen in radiotherapy in head and neck cancer patients as salivary glands are highly radiosensitive. And once xerostomia sets in, it will affect chewing, eating, swallowing, taste, speaking, and will cause tooth decay. What is the mechanism of xerostomia? Normal salivary flow is 0.25 ml per minute, and parotid glands are responsible for serous watery secretions, and submandibular gland both serous and mucous saliva secretion. Serous acinous cells are more radiosensitive than mucous acinous cells. Therefore, parotid is more radiosensitive than submandibular gland. And what is the timing? When RT doses reaches 10 to 20 gray with 2 gray per day, 50 to 60% decrease in salivary flow is seen. After 7 weeks, salivary flow decreases to 20% and continues to drop for more than 6 months after RT completion. Recovery is possible until 12 to 18 months after RT, depending on the dose received by salivary glands and volume of it included in the RT field. What are the risk factors? Altered fractionation, that is hyperfractionation when we give 2 fractions in a day, advanced age, concurrent chemo RT. How should we prevent it? By using good techniques like IMRT, IGRT, where it is possible to achieve mean dose of less than 20 gray for at least one parotid, or a mean dose of less than 25 gray for both the parotids. Lower mean dose to the oral cavity and contralateral submandibular gland, which is 39 gray. Acupuncture, low-level laser therapy, pilocarpine, it improves the unstimulated salivary flow. The dose given is 5 mg TDS during radiation and continue till 3 months post RT. Amifostin also has role. Treatment. Oral rinses with normal saline, chewing to stimulate secretion of residual glandular tissue, drink adequate fluid, cold air humidifier to alleviate nocturnal symptoms, artificial saliva supplementation, pilocarpine, civimilin, bromhexine, bethanol. Osteoradionecrosis. It is exposition of devitalized bone in previously irradiated area without histological evidence of tumor recurrence, occurs months to years after radiotherapy. Radiotherapy causes vascular obliteration, which leads to hypovascular areas and tissue hypoxia, leading to osteoradionecrosis. What are the risk factors? Abuse of alcohol and tobacco, primary site, like whether we are irradiating the mandible area or maxillary area, T stage, advanced T stage, proximity of tumor to the bone, poor dentition, type of treatment, that is whether we are giving brachytherapy or external beam RT, and radiotherapy dose. When it is more than 66 gray, chances are more. Acute and chronic injury, that is surgery, dental extraction, infections to mandible or maxilla. So it may be asymptomatic or symptomatic. When it is symptomatic, look for any infection. If it is non-infected, then hyperbaric oxygen therapy, pentoxifylline, tocopherol, clodronate are helpful. And when it is infected, antibiotics and chlorhexidine mouthwash are used. Once the infection settles, again we have to go for hyperbaric oxygen therapy. And if there is still infection, then we have to go for surgery, which can be debridement and local cover, or excision and reconstruction with vascularized tissue. This is how osteoradionecrosis looks. Coming to the other adverse events. So cardiovascular diseases like pericarditis and ischemic heart disease, the latent period for which is at least 10 to 20 years, and it mostly occurs when for breast cancers, lung cancer patients and Hodgkin's lymphoma patients, because heart receives dose in such patients. Risk factors: young age, longer follow-up and increased radiation dose. And treatment: awareness, although no definitive guidelines for cardiovascular screening, but with the advent of deep inspiratory breath hold techniques, heart dose can be reduced to as low as possible, which further prevents cardiovascular diseases. Pneumonitis. It is seen in breast, lung and mediastinal radiotherapy. And increased RT dose, volume of the lung irradiated, concurrent chemotherapy, comorbid lung diseases, poor baseline pulmonary function, test and lower performance status. What is the treatment? Steroids and pentoxifylline. GI toxicity. So there can be mucositis, esophagitis, head and neck, thoracic radiotherapy, and when there is increased RT dose and concurrent chemotherapy, it is most commonly seen. And how should one treat it? Via viscous lidocaine, proton pump inhibitors, sperm motility agents, bland diet, avoidance of alcohol, caffeine, and acidic foods. Enteritis, it is seen when abdomen and pelvic radiotherapy is given. So when there is previous abdominal surgery, there are adhesions which can lead to increased chances of enteritis. Prior pelvic inflammatory diseases and comorbidities like hypertension and diabetes mellitus. These are the risk factors. So how to prevent it? Limit the bowel volume in radiation portal by using belly board, full bladder, IMRT technique, oral sulfasalazine, 500 mg twice daily, low residue diet, low lactose diet, stool softener, loperamide, octreotide, 100 micrograms subcutaneous, 3 times a day, and antispasmodics. Proctitis. It is seen in anal cancers, rectal cancers, cervical cancers, bladder cancers, and uterine cancers and prostate cancers. So chances of proctitis are increased in inflammatory bowel disease patients. How can one prevent it or treat it? By giving rectal hyaluronic acid, rectal misoprostol, oral sulfasalazine, sucralfate enema, steroid enema, butyrate enema, and hyperbaric oxygen. Let's talk about the genitourinary toxicity. Cystitis. It is most commonly seen in the cancers of the prostate, colorectal cancers, bladder and pelvic cancers. Concurrent chemo-RT increases the incidence of cystitis. So how should one prevent it? IV hydration, uroprotective agents, intravesical glycosaminoglycan instillation like hyaluronic acid, chondroitin sulfate, and phenizoparidine, tamsulosin, which is an alpha blocker, oxybutynin, tolterodine, and hyperbaric oxygen, and symptomatic care for cystitis. So these are the agents available when cystitis sets in. Erectile dysfunction, it is most commonly seen in prostate cancers and colorectal cancers. It is increased when there is ADT use. So how should one prevent it? By counseling the patient and by giving phosphodiesterase type 5 inhibitors. Vaginal dryness and stenosis, it is seen for cervical cancers, endometrial and vaginal cancer patients when pelvic irradiation is done. It is more common in elderly patients, and prevention is by lubrication and vaginal dilatations. Infertility and teratogenicity, it is most commonly seen in cervical cancers, pelvic cancers, and testicular cancers, and it is more common in elderly patients and when ovaries receive greater dose. So how to prevent it or to treat it? By egg and sperm preservation prior to starting radiotherapy and ovarian transposition. CNS toxicity. So what are the risk factors for CNS toxicity? It is the volume of normal brain tissue irradiated and use of concurrent medications and advanced age. Mechanism, it is via oxidation of lipid bilayer, changes in microvascular permeability, mitochondrial alteration leading to oxidative stress. Acute effects are fatigue, headache, somnolence. Late effects are radiation necrosis, which is how can we detect radiation necrosis? In MRS, that is MR spectroscopy, there is a lipid peak. If symptomatic, give Dexona 8 mg TDS and then tapering dose. If there is no response to steroid, then start bevacizumab at 7.5 mg per kg 3 weekly for 2 cycles. And otherwise, surgical resection is the best treatment available. Other late effects are neurocognitive dysfunction, endocrinopathies, cerebrovascular effects, and ototoxicity. Prevention, PPAR, that is peroxisome agonists, example, pioglitazone, hippocampal sparing whole brain RT gives better results when compared with whole brain RT for brain metastasis. Psychostimulants like methylphenidate and NMDA receptors antagonist like mementin, reversible choline esterase inhibitor like donepezil. Radiotherapy induced fatigue. So what are the non-pharmacological interventions and pharmacological interventions? Non-pharmacological interventions are exercise, optimized sleep quality, cognitive behavioral therapy, yoga, pranayam, and avoid poor body posture, select the task based on priority, eliminate unnecessary tasks, hypnosis, group therapy, stress management, and adequate intake of nutrition and fluid. Pharmacological interventions available are treat the underlying cause, which is aggravating fatigue, like treat anemia, any pain, or any underlying infection. Methylphenidate, modafinil, steroids, high doses of American ginseng, IV, vitamin C. And guarana, it is a plant native to Amazon forest, and it is under research for the prevention of radiotherapy induced fatigue. So radiation fibrosis syndrome. So when radiation dermatitis can lead to lymphedema and radiation myositis, which can ultimately lead to radiation organ fibrosis causing adhesions. Radiation fibrosis is influenced by many factors such as radiation dose and volume, fractionation schedule, previous or concurrent treatment, genetic susceptibility, diabetes mellitus, RERT, that is for recurrent diseases, and connective tissue disorders. So what is the mechanism? So fibroblast is converted to myofibroblast by transforming growth factor beta, which and myofibroblast leads to excess secretion of matrix forming substances like collagen, proteoglycans, and fibronectin, which leads to avascularity, thickening, and stiffening. Clinical manifestation varies with site. For example, head and neck cases leads to trismus, reduced mouth opening less than 35 mm inter-incisor distance, contracture of sternocleidomastoid muscles, scalene muscles, which may lead to torticollis, shortening and loss of elasticity of tendons and ligaments, resulting in restricted joint mobility, pain, and edema. Prevention. Use of conformal techniques like IMRT, IGRT, exercise, physiotherapy, therapeutic management, targeting transforming growth factor beta, combination of pentoxifylline and tocotrienol, combined oral gamma and delta testosterone replacement therapy for trismus, simvastatin, AC inhibitors like enalapril is used for lung fibrosis, imatinib for skin fibrosis, corticosteroids, anti-proliferative agents like pirfenidone, VEGF inhibitors like bevacizumab. NSAIDs along with muscle relaxants like benzodiazepines, baclofen for pain, spasm, pregabalin for neuropathic pain, hyperbaric oxygen therapy, and injection botulinum toxin for trismus and cervical dystonia. So this is the patient showing radiation fibrosis of the neck muscles. So I end my topic here. Thank you.
Thank you so much for the lecture, ma'am. Can we have questions for Dr. Shweta, please? Thank you. Are there any questions? Seeing that there are no other questions, I'd like to thank you, ma'am, for sharing the presentation with us. Our next lecture is by Dr. Bhushan Zade, who's the Director of Radiation Oncology, and he'll be speaking on ablative radiation therapy protocols.
Hi guys, good afternoon. Let us discuss about ablative radiation therapy protocols. What do you get by this name, and what is it exactly means? So by now you already had 2 lectures on radiation therapy topic, is like basics of radiation therapy and complications of radiation therapy by different doctors. So we'll discuss about the next level of radiation, which is a very focused and very high dose of radiation, which we finish in few days of time. It's called radiation therapy ablative protocols. So what is this? So these are different ways of giving radiation. Very standard, very conventional way of giving radiation is 1 session per day, 5 sessions per week, and holidays on Saturdays, Sundays. So this is like we repeat every week for 5 to 6 weeks or sometimes 7 weeks. And there are different ways, like we reduce number of days of radiation by increasing dose of radiation per day. So depending upon disease, depending upon patient general condition, we use different kinds of a fractionation. So today we are going to discuss about extreme hypofractionation or ablation radiation protocols. So definition. So stereotactic ablative radiotherapy, SABR, also known as stereotactic body radiation therapy, SBRT. It is a highly focused radiation treatment that gives an intense dose of radiation, very concentrated on a tumor while limiting doses to surrounding organs. And SBRT essentially involves use of very sophisticated image guidance that pinpoints the exact three-dimensional location of the tumor so that radiation to the other areas can be well avoided. And it has become treatment of choice for many people with very limited volume of disease, for which the surgery is very difficult or sometimes may not be possible. Few example: early stage lung cancer, liver cancer, pancreatic cancer, prostate cancer, and sometimes oligometastatic disease. Now, why SBRT or SABR? It is very highly effective and accurate treatment, and in that particular location you can achieve 90% local tumor control. Latest image guidance tools achieve sub-millimeter accuracy. So when you have a tumor which is very close to some critical areas, SBRT can do the job. It is a non-invasive and very comfortable for patient. You don't require anesthesia, you don't require surgical post-op recovery time, no complications of inpatient thing. So it's a very non-invasive, comfortable and outpatient treatment. Now, where we use SBRT and how we use it. So clinical parameters, essentially you should have a small volume disease which is a very measurable. Sometimes you have a diffuse disease, small volume but diffuse, that may not be a very appropriate situation for SBRT, but when you have a small volume and measurable and localized disease, yes, you can use SBRT. A disease where surgery is difficult or possible with great morbidity, then you have an option of SBRT there. And of course, patient should have a reasonable prognosis and reasonable general condition, because these are intense treatments which should not be used in a patient who already have an end-stage disease. Now, just a picture of a linear accelerator which has got a SBRT capability. If you appreciate this picture, this is a very latest TrueBeam STS linear accelerator with this head having a housed multi-leaf collimator of high definition size, and you can appreciate this orthogonal or say imaging device which captures a KVCT quality image. What is KVCT? It's a kilo voltage computed tomography. It is as good as a diagnostic CT quality imaging. So when you do a very high precision radiation, you need to have a very high quality imagings to match your reference image. So then you have a confidence that you are hitting a target correctly. I'll give an example. Now you can appreciate this is a bone lesion. This is a bone metastatic. So for this particular patient, there is no disease anywhere in the body and only this bone site has got a disease. Now this is an ideal situation for stereotactic radiation. So we do a very focused, very conformal dose distribution here, and we fire in only 3 days of treatment. So 6 to 8 grays over 3 fractions, or sometimes we do a single fraction also, but for this particular patient we did 3 fraction, daily or alternate day OPD treatment, every day 10 minutes high dose rate treatment, and that's it. So it's so simple to treat with this kind of a technology. Again, one more side, lung. Early stage lung cancers like T1 or T2 small lung cancers in which surgery is a big thing, but SBRT we can do very easily. Or sometimes we have a lung metastasis, but 1 or 2 lung metastasis, no disease as well, so oligometastatic lung disease, and we have to do respiratory motion management in this situation because lungs continuously move with respiration. So when you target a small area of lung, and if that area is moving with respiration, it is very difficult to target. So we have to do motion management so that we don't hit unnecessary lungs around the tumor. So this is one picture showing this lung tumor getting fired with SBRT high dose of radiation. You can see the sleeve of high dose of radiation, and this is surrounding low dose of radiation going in some part of lung but not much. Again, one example, liver. You have oligometastatic liver disease. You can appreciate this is a colorectal cancer patient with liver metastasis. You can see the liver is resected. So earlier the liver surgery was done in the form of resection for the metastatic disease, but now you have a small recurrent nodule disease here. Now this nodule again can be operated, but resurgery becomes challenging, difficult for patient. So option of SBRT. So we put a marker. You can appreciate the platinum coil or platinum marker here. This markers gives us an idea of motion, tumor motion and tumor position. And then with reference to that marker, we plan a SBRT high dose radiation here, spread over 5 to 6 days. And then here you go. After treatment, you can appreciate the clean response. The tumor was here before treatment. Now post treatment scan does not show any tumor. This is one of the examples. We have many examples of this kind of a treatment. So basically we can give a very high dose of radiation in a challenging situation. Now bone metastasis, again a very common situation in cancer patients. So we have a vertebral metastasis. You know that there is a spinal cord housed in the vertebral canal. Now if you give very high dose of radiation to the vertebral body, your vertebral canal which has got a spinal cord may get a very high dose of radiation, which in turn can damage the cord. So here we use stereotactic techniques, give very high dose of radiation. You can appreciate how nicely the spinal cord is spared. This is sagittal image. You can appreciate how nicely cord is spared. And then you see the response. The same patient, this is pre-radiation, this is post-radiation. It's clean. So very good response in a select group of patients. So I would summarize, ablative radiation therapy protocols have become definitely popular because of availability of high-end radiation treatments, longevity of cancer patients. They are living longer with effective treatment, so they tend to develop few metastatic disease here and there, which we can fire and still control the disease. It's highly effective and very short treatment. Extreme precision and high experience is needed because this is not a simple treatment to deliver. Thank you very much.
Thank you, sir, for your presentation. We're open to questions towards Dr. Zade right now. You can please mention them in the chat box. Thank you. It looks like there are no questions. So this concludes session 4, and we'll be moving on to the final session of today's conference. This is going to be chaired by Dr. Bhushan Zade, and the first presentation is by Dr. Tahir, and it will be on the basics of molecular techniques. Dr. Tahir is a consultant histopathologist at Ruby Hall Clinic. Over to you, sir.
Good afternoon, everyone. I am Dr. Tahir Chorchodawala. I am going to present the basics of the molecular techniques. As we know, the diagnosis, treatment of the cancer has gone paradigm shift, and it is not longer treated as per the morphological parameters. Like more and more diagnostic and treatment algorithms are supported by the immunohistochemical and other molecular alteration at the DNA, mRNA, microRNA and proteinolix levels are available to help the treatment. So molecular techniques are used for the detection of the cancer, to specify specific diagnosis, monitoring and detection of the recurrence of the cancers. The cancer is considered as a genetic disease, and it has a genetic alteration as well as the epigenetic alterations. The genetic alteration include point mutation, single nucleotide pleomorphisms, copy number variants like loss of heterozygosity, deletion and gain of the chromosome numbers. In epigenetic alteration, there are microRNA alterations, DNA methylations and histone modifications. So for the molecular assessment, the blood, fine needle aspiration, fresh tissue like frozen sections, and most commonly used method is a paraffin tissue, which are embedded in the paraffin by formalin fixation. And for the assessment, DNA, RNA, protein, microRNA and mRNA are used. The many molecular techniques are available, but for the cancer diagnostic, The common methods are the immunohistochemistry, fluorescent in situ hybridization, or commonly called as a FISH, gene expression analysis, sequencing. The common methods of the sequencing are the Sanger sequencing and next generation sequencing, and epigenetic study include methylation specific PCR. And these are not a complete list, but these are the common tests which are used for the molecular diagnosis. There are few IHCs are available to detect specific mutations like IDH1 mutant antibody for the glioma detection and BRAF IHC to detect BRAF mutations, ROS1 IHC and ALK1 IHC, and many more are coming for the specific mutation diagnosis. Let's say example, for 55-year-old men with frontal lobe mass, and diagnostic dilemma was whether it is a glioma or whether it was a reactive gliosis. So surgery was performed and tissue was embedded in the paraffin blocks and the slides were cut and IDH1 IHC was performed. So this is a mutant IHC and it is a positive. We can see the nuclear brown positivity of the IDH1 antibody. So what is the interpretation and management impact? It is a IDH1 mutant. So the diagnosis is glioma because reactive gliosis never show the IDH1 positivity. So it will be treated as a glioma protocol. Second example is it help in the treatment in the case of the melanoma. So specific BRAF IHC is available. In case of melanoma, if it is a positive, then specific drug like dabrafenib is available for the management. Another technique is a fluorescent in situ hybridization, in which molecular cytogenetic technique is used, in which fluorescent probe are used for the bind the specific sequence in the nucleic acid, and it has to detect the amplification, deletions and fusions of the chromosomes. Like we can see here, the first is a chromosome, and chromosome has a long strand of DNA, and DNA has a specific sequences. In fish, we generally have a specific probe which bind to the specific region of the chromosome, and it is labeled with the fluorescent dye. And if we use a fluorescent microscope, it will light up. The 33-year female patient with the breast cancer, on biopsy it was a ER and PR hormone receptor was negative, and her HER2 IHC was equivocal. So for the confirmation, fish was advised. We can see this is a patient fish on the left side and the control fish on the right side. On right side we can see there are 2 red dots and most of the cells have 2 green dots. So green dots is a centromere probe and green dot is a test probe which is a HER2 gene. Normally we have 2 copies of the HER2 gene, but if it is amplified we can see the more than 2 copies per cell. On the left side we can see there are much more red dots compared to the green dots, and sometimes it form a cloud. So it is a fish positive HER2 amplification. So what will be the impact? It is considered as a HER2 gene amplified tumor, and it is considered as a poor prognostic factor, but specific drug like Herceptin is available for the management. Let's say take a second example. 42-year male with the lung mass, and on biopsy it was a adenocarcinoma, and ALK1 fish was advised, and we can see here there are 3 signals are available. One is a yellow signal, second is a red signal, and third is a green signal. Yellow signal is basically a fuse signal of red and green. So if gene is translocated, the signal gets apart and it will give 3 signals. So red and green signal signify it is a translocation. So what is the interpretation? The ALK translocation is present, but specific drug like a crizotinib is available for the treatment. There are some gene expression profile studies are also available which measure the tumor mRNA, and it compare with the internal control of some of the genes mRNA, and it gives a score. The commonest method commonest test is used in the breast cancer. It is a Oncotype DX and MammaPrint. Here we can see that there is a gene expression profile. We can see the green and red bars. It is a complex thing, but if green is more, it is considered as a underexpress, and if red is more, then it is considered as a overexpress. So many complex algorithm is there, and it gives a specific score. Take an example of Oncotype DX. The Oncotype DX, the prerequisite requirement is the tumor should be ER/PR positive and node should be negative, and it will do analysis and give a recurrence score. If score is less than 10, then we can safely avoid chemotherapy, but if score is more than 25, then chemotherapy should be given. One hypothetical patient with 40-year female, 3.5 cm invasive tumor, ER/PR is positive, HER2 is negative and lymph node is negative, and patient want to avoid chemotherapy, so we can advise her to the Oncotype DX. And suppose this is the result, the recurrence score is 32, her distance recurrence risk is at 9 years is 20%, and absolute chemotherapy benefit is more than 15%. So what will be the impact? Because her recurrence score is 32, the chemotherapy will be required for the management. There is another method, it is called DNA sequencing. So this is a very commonly used method now for to identify mutations, amplifications as well as the deletions of the genes. So the DNA sequence is a process of determining the nucleic acid sequence. It can be any method. The common method is Sanger sequencing and so-called next generation sequencing. Here we can see the pictorial representation of chain termination method, in which we can see the chain are terminated at the specific base, and depending upon the various method, this is gel electrophoresis, and we can identify specific sequence. Here a pictorial representation of the Sanger sequencing. In Sanger sequencing, what we will do, we do a single gene analysis, and in which it is bind to the primer, and we use a fluorochromes which are bind to the nucleotides. So it goes to the like that. There is a primer elongation and there will be a chain termination, and the chain is terminated at different level, and we analyze this termination at the various method. The common is a capillary electrophoresis, and it gives a specific sequence, and it is analyzed by the computer, and it gives the mutation is present or absent. Let's take an example of 48-year male patient with the metastatic colon carcinoma. So for the metastatic colon carcinoma, cetuximab is advised provided that KRAS and NRAS mutation is negative. So these are the Sanger sequencing result, in which 2, 3 and 4 exons are analyzed, and this patient, it was not detected. But if it is detected, suppose in second patient there was a exon 2 mutation and it is a pathogenic mutation, so what will be the impact? So if KRAS is non-mutated, it is considered as a wild type thing, and cetuximab can be given. But if KRAS is mutated and if it is pathogenic, then cetuximab will not work and it is a contraindicated. There is another commonly used method for the sequencing, and which is going now in the mainstream, is a next generation sequencing. What is the disadvantage of Sanger sequencing? It is a single gene sequencing method, so we cannot perform a more than one gene sequencing. But in next generation sequencing, we use a multiple genes for the sequencing, and many genes are parallelly sequenced. Here we use a sample of the patient and we fragment it and we bind it with the adapter. It is called library preparation. Then second phase is it is a clonal amplification. We do a PCR and we amplify this library. And third thing is sequencing. and sequencing can be done by the various method by the different platforms. Different platform use a different method. So one is a pyrosequencing, in which the light is used. It is called pyrosequencing. The enzyme used for this method is luciferase. Second method is DNA ligase, and third method is a sequencing by synthesis. So the many genes are simultaneously analyzed, and it can be, you must be aware, there are many gene panels are available, like 35 gene, 70 gene, 170 gene, 300 gene. So these are done by the next generation sequencing. So commonly what we are using right now it is for the lung cancer. So in lung cancer many targetable mutations are there, and we cannot analyze this by one gene panel in the Sanger sequencing. We can do it, but it will take a time. So NGS is a much better option to identify any mutation which can be targetable. So if patient is 60-year male patient with non-smoker, and it has a lung mass and biopsy is adenocarcinoma. So for the treatment person, NGS was advised, and this is a result. So this is a NGS report in which we can see there are many mutations were found, but the most important mutation is EGFR mutation, and it was a exon 19 deletion. And in you can see in the report it was 1.1% tumor allele present in this sample. The main thing is it is a good sensitivity to the EGFR TKS. It is a tyrosine kinase inhibitor. So what was the significance? So patient has the EGFR mutation, and specific drug against the EGFR is available. It is called tyrosine kinase inhibitors. You must be aware there is a term called liquid biopsy. So what is a liquid biopsy? So liquid biopsy, basically instead of tissue, this tests are done on the blood sample, and it is called as a liquid biopsy. So in blood we detect the circulating tumor cells or fragments of the tumor DNA. It is called cell-free DNA, which are studied into the blood from the primary tumor and from the metastatic site. So blood is collected, and from there plasma is separated for the circulating tumor DNA, and the cells are separated for the circulating tumor cells, and from there the DNA is isolated, it is amplified, and various tests can be run for the specific mutation detection. So what is the take home message? So the molecular testing is becoming routine in the management of cancer for a diagnostic, for therapeutic purpose, and many different techniques are available. All have a different sensitivity, specificity, and turnaround time, but depending upon the clinical requirement it can be used. And it is a very upcoming field, but it will ultimately give a individualized treatment for the specific patient. Thank you.
Thank you, sir. We will now ask for questions for Dr. Tahir. Are there any questions? Please do leave them in the chat box. Thank you. There seems to be no questions. Thank you, sir, for your presentation. We'll be moving on to the next one, which is by Dr. Vijay Ramanan, who is the Director, Bone Marrow Transplant and Consultant Clinical Hematologist. And his presentation is on the basics of blood cancer management.
Good afternoon, everybody. and welcome to the cancer course. Today I am going to speak about basics of blood cancer management. My name is Dr. Vijay Ramanan. I am the chairman and director of the bone marrow transplant unit at Ruby Hall Clinic and a clinical hematologist. So what is blood cancer? It is also called leukemia. Leukemia comes from a Greek word. Leukos means white, which is WBC, white blood cells, and emia means swelling. So it's divided basically into acute and chronic. So leukemia is not only one. It could be acute leukemia or a chronic leukemia. Again, acute leukemia is divided into myeloid and lymphoid. Similarly, chronic leukemia is also divided the same way. It's called chronic myeloid leukemia or chronic lymphoid leukemia. There are other entities which are also part of the blood cancer. This is lymphoma, myeloma, myelodysplastic syndrome, and myeloproliferative disorders. So remember, all these are part of the hematological disorders. So very important thing for a management is that a correct diagnosis is the first step towards correct management. So that's a very, very important paradigm for all of us. So always ask for immunophenotyping, which is on the bone marrow sample, cytogenetics, FISH and PCR of the patient itself. When you're taking the bone marrow, you take all these things. And if you are not getting any sample out of the bone marrow, then you can ask for immunohistochemistry, which is on the bone marrow biopsy. So what is the incidence, epidemiology of leukemia? Before the advent of the chemotherapy era, it was a rapidly fatal disease. People used to die in days to months, days to weeks to months, and it contributes to 3% of all cancer, around 30 to 35% for children. It's the number one cause of death below the age of 35 years. Around 5,000 ALLs are diagnosed in USA per year, median age being 10 years, and 9,000 AMLs are diagnosed in US. Adults much more than children, median age of 65. So you multiply this number by 5. So to say in India probably we have 25,000 ALLs per year and around 45 to 50,000 AMLs per year that occur in this country, in our country. Now this is a slide, next slide, this is a slide which talks about the epidemiology. You can see the ALL has a curve which is early part of the whole thing, and second part is it's balanced between two age groups. And the best prognosis for ALL is when the age is below 10 years. So someone who is elderly comes with ALL, the prognosis is not good. Similarly, AML is good prognosis till 40, 50, 60 years of age. Beyond 60 years of age, it is called elderly AML, and the outcomes are. Now coming to the first group, that's myeloid leukemia. As I told you at the beginning, myeloid is again divided into acute and chronic. So acute myeloid leukemia has 3 risk groups. One is called a good, intermediate or poor. So remember 3, good, intermediate and poor. Good will only respond to chemotherapy. Intermediate will need a chemotherapy followed by autologous transplant, and poor will need chemotherapy followed by a more stronger transplant called allogenic transplant, where the stem cells are from the HLA matched sibling or HLA mismatched sibling. There is an entity called AML-M3 which needs a totally different treatment, which is arsenic trioxide or a vitamin A analog called all-trans retinoic acid. So this AML-M3, if it is diagnosed, it's a medical emergency, because after the diagnosis in 10 to 15 days, patient may have a bleed or a clot at the same time, and so treatment has to be started very fast. Blood support has to be excellent. So that's why a place like Ruby Hall will be able to manage such a patient. In acute myeloid leukemia, other ones, there are other chemotherapies called 7+3, with 7 days of cytosine followed by 3 days of along with the daunorubicin for 3 days is given. This is for 1 month. First month it's called induction, and second month onward is called consolidation, which is done by a chemotherapeutic agent called cytosine. It's called high dose cytosine, which is given for 3 to 4 months. So AML total treatment is approximately 4 to 5 months. Now coming to chronic myeloid leukemia. So this is one of the best things in last 20 years that has happened to leukemias. This whole malignancy can be treated with just tablets. So you have sequence of frontline and salvage strategies which are there available for our patients. So we in India follow the second part of the slide, where we give frontline treatment with imatinib, which is available for as low as 1,000 rupees a month today, which was initially around 1,80,000 per month. It's come to 1,000 rupees thanks to the intervention of the Indian government. And if you don't respond, you have other drugs called dasatinib, which is again generic formulation. In US it's available for around 3 lakh rupees. In India it's available for 4-5,000 rupees. Bosutinib is also available. And if you fail, ponatinib is not available in India. A clinical trial is coming to Ruby Hall under me with ponatinib. So if you have a patient with myeloid leukemia, CML, you can probably refer the patient to us. So remember, all these drugs are available. That's why 95% of CMLs will live a long life. Coming to lymphoid leukemias, we have basically again divided into acute and chronic. Acute is in children, as I showed you in the previous slide, and again is divided into good, intermediate and poor. Good needs a chemotherapy for 3 years. Good is decided by the age of the child. 1 to 9 years, 1 to 10 years is good age, WBC count being low, no CNS involvement, 8th day after treatment, what is the number of blast percentage, all those things are included in the risk stratification. Intermediate patients would need chemotherapy, and if they relapse, then we do transplant. In poor risk patients with ALL, we give chemotherapy followed by transplant. That is done in the first remission itself so that they can be cured. Cranial radiotherapy has a big role to play in ALL because it prevents CNS relapse. Once the CNS relapse occurs, the chance of survival is less than 10%. So it's better to prevent rather than treat later. Lymphoid leukemias, the chronic ones, are basically we have a different criteria altogether. CLL is another disease where you may not treat a patient and still make him live. So remember that we look at various parameters. What is the doubling time? What is the lymphocyte doubling time? There is a test called ZAP70. There is a test called FISH. If after doing all this, the patient is in the good group, the division rate is very slow, the lymphocyte doubling time is more than 12 months, we do wait and watch. If the lymphocyte doubling time is less than 12 months, ZAP70 is high, then we treat with chemotherapy with a drug called bendamustine and rituximab, or there is a tablet called ibrutinib that can be used. So summarizing the whole treatment, the step 1 is induction of remission, and which has chemotherapies of multiple modalities. Then is a consolidation or a maintenance therapy as in ALL, and in rare cases 10-15% of the patients we need bone marrow transplant. So what is bone marrow transplant for? Bone marrow transplant is basically for intermediate or poor risk AML or a poor risk ALL or a relapsed leukemia. We routinely do transplants for myelomas. We routinely do transplants for relapsed lymphomas also. So remember, all these are indications of bone marrow transplants. It could be autologous, where the patient himself is a donor, or allogenic, where there is a donor who is different from the patient. The very important thing is we need common ground, which are the things which are needed for treating our patients. One is a central line, which could be a port, which could be a peripherally inserted central catheter, or central line which is needed. The port is put by a surgeon, PICC by our interventional radiologist, central line by our ICU team. Blood product support is very, very important for us. We give SDP or a random donor platelet or a single donor platelet depending on whether the patient is bleeding or the platelet count is less than 10,000. Packed cell volume is given if the hemoglobin is less than 7 gram %. FFP is given if the PTINR is more than 1.4. So important thing is hand hygiene, reverse barrier nursing, and food care. So very important that after COVID, everybody has learned how to put a mask, but hand hygiene. But we have been doing this for last 15 years. And reverse barrier is we try to prevent patient getting infected from the healthcare worker. And food care is done by basically pressure cooking the food that's available to him multiple times so that no bacteria goes to the patient. So how have we fared over the last 50 years? Look at the slide. The top part of the slide is ALL, acute lymphatic leukemia, where you can see the survival in 1971 to 75 was hardly 25%. Today we are looking at 75% survival, more than 75% survival. Look at the lower part of the slide, where you have AML, acute non-lymphocytic leukemia, that's what they used to call at that time. So this survival was hardly 5-10% in 1971, today is around 70%. So there's been a huge jump in the survival. That's to do with the bone marrow transplant, availability of the bone marrow transplant, of various types of bone marrow transplant. That's how the patients are surviving. To summarize, you need a hematologist to treat hematological malignancies like leukemia, lymphoma, myeloma. A trained nursing team is quintessential for successful management of leukemia and bone marrow transplant. A good blood bank and lab support is essential for the same, and good ICU support is needed for really sick ones. Thank you very much. You can contact us at this email. This is our mobile number, and that's our website. Thank you very much.
Thank you for the presentation, sir. Unfortunately, Vijay sir is not able to join us for a question and answer session. So we'll be moving on for the next presentation. The next presentation is by Dr. Amol Galge, who is a consultant and in charge of the PET-CT department and nuclear medicine at Ruby Hall Clinic. And his topic is PET-CT in cancer imaging. Over to you, sir.
Good evening. I will be talking on PET-CT in cancer imaging. PET imaging, it is basically positron emission tomography. It is a nuclear medicine imaging technique where radioisotopes which emit positrons are used. These radioisotopes are tagged to molecules of particular physiological role, such as glucose, for example, and we get radiopharmaceutical. And these radiopharmaceuticals we inject to the patient or administer in different ways to the patient, and then scanning can be done. So, for example, radiopharmaceutical here 18F fluorine is labeled to glucose, and then we get 18F FDG, fluorodeoxyglucose, and that we can inject to the patient IV. Other radiopharmaceuticals such as 18F fluoride, which is used for bone scan, or gallium dotanok and PSMA scans for specialized PET scans. So, what is the difference between PET scan and nuclear scans and routine conventional radiology scans, CT scan? So, CT scan or X-rays, these are basically here the X-rays are generated through in the X-ray unit, X-ray tube, and then they will be passed through human body, and the attenuation map generated will give us image. So, these are called transmission scan. The X-rays are transmitted through human body. So, these are transmission scans. While nuclear medicine scans like PET scan, here the radioactivity is in human body. So, gamma rays are emitted from the human body, and here and then those will be detected by gamma camera detectors, and we get images after that. So, it is emission scan emitted from human body. So, that is emission scan. So, positron emission tomography, it is a emission scan, and how it gives different images like CT scan and radiological images will give us anatomy, like here you are seeing a map, India map, and while PET images will give you functional images, like here you are seeing the clouds over the sky. So, here that is a functional information we get from this PET images. So, now what is PET-CT? Basically, it is a PET and CT fusion data. So, here you get anatomic information from CT images and functional information from PET images, and with this functional information, if you overlap with the CT images with software fusion, we get a PET-CT data. So, PET-CT fusion data we get. So, here is the scanner, next image. So, here is the PET-CT scanner. You can see in the scanner, PET-CT scanner, there will be two gantries. One is a PET scanner and one is the CT scanner. So, in CT gantry, first scan will be done, and then patient moves to in the same position patient moves to the PET gantry, and the PET data will be recorded. So, we will get both the data in the same position. So, this is how PET-CT will be acquired. Though the concept of PET, it came in 1970s, ultimately it came in reality in 2001, where the first commercial PET-CT scanner announced in early 2001, and then in India it came in 2004 at TMH Tata, and here we got it at 2008. In last 15 to 16 years, you can see the growth of PET-CT in India, like there are already now 300 to 400 PET scanners in India now, and it is becoming mainstay of cancer imaging. Now, workhorse of the PET scanner department is fluorine labeled FDG, so fluorodeoxyglucose. This is a radiopharmaceutical that will we use for most of the patients, our patients, for the regular PET-CT scan. When we say whole body PET-CT scan, then it is mostly FDG PET-CT scan. So, what is the FDG? It is a glucose tagged with 18F fluorine. It is a metabolic contrast agent. It is very safe. It is just a sugar. There is no contraindications like renal failure or liver failure. There is no we can use even in the renal failure patients also. It is just sugar. It is injected IV. Only it is a radioactive, we can't do the scans in pregnancy. So how does FDG works in a human body? Like glucose, it will be taken up by the cells in the through glucose transporters, and once in the cell, glucose gets converted to glucose 6-phosphate by hexokinase, and then it enters into glycolysis. While FDG, it is again taken by the glucose transporters, and in the same way it is converted by hexokinase into fluorodeoxyglucose 6-phosphate, and after that, as its hydroxyl group is replaced by fluorine, it cannot enter into glycolysis. So this fluorodeoxyglucose 6-phosphate remains trapped in the cell. So in particularly neoplastic cell, now in this next slide you can see there is increased glucose transporter expression. That's why the more intake of fluorodeoxyglucose will be there in the cell, and there will be also increased hexokinase activity. So there will be more quantity of fluorodeoxyglucose 6-phosphate in the concentration will be in the neoplastic cell. So that's why that's how we can differentiate from like normal cells from the malignant cells. Basically it is higher metabolic activity shown by the neoplastic cell. This is a normal PET scan. Next in this slide, here you can see the high degree of glucose activity in the brain parenchyma. So that suggests that glucose activity, high glucose utilization will be there by the brain cells. That's why the glucose activity is high in the brain cells. Other areas like liver and myocardium, they will have variable degree of glucose activity. And there can be some activity in the vocal cords or extraocular muscles depending on their muscle activity. FDG will be excreted by the cells, FDG will be excreted by kidneys, and we can see the FDG tracer excretion in the urinary bladder as well. So coming to clinical utility of PET-CT, its main use is oncology. There can be other indications in cardiology, neurology, or in infection imaging as well, but main indications is in oncology. It can be used at different stages in cancer management, as in diagnosis or at level of staging, then assessment of treatment response, then early detection of recurrence, and for radiation therapy planning, as well as for detection of unknown primary. One by one we'll see this in this slide. Solitary pulmonary nodule. This patient, for example, this patient 72-year female presented with cough, X-ray chest showed opacity in left mid zone. It was persistent in follow-up. FDG PET was advised to see what is the metabolic activity of this nodule. And you can see in this whole body PET image, there is a nodule hypermetabolic activity seen in left mid zone. And if you see the fusion CT images, it is overlapping with the CT nodule, and so this nodule in the CT scan is hypermetabolic and it is more likely malignant. So in this case, biopsy is suggested to get the histopathological final diagnosis. This patient's another patient, solitary pulmonary nodule, again similar complaints like history of cough, X-ray chest showed right lower zone opacity, but here on PET scan it is not concentrating FDG, and in such situation it is more likely benign and follow-up is suggested. Next slide. FDG PET in there can be false negative in this, like in well differentiated adenocarcinoma or bronchoalveolar carcinoma, where the FDG activity may be on lower side in these tumors, but the routine the most common malignancies like squamous cell or adenocarcinomas, they will have a high activity. False positives can be in tuberculosis, sarcoidosis, or other infections. But here the main important point is PET has a high negative predictive value to rule out malignancy. So lesion on CT scan, if it is more than 1 centimeter and if it is negative on PET scan, so it suggests that it is more likely benign. Staging of PET scan, staging with PET CT scanner, it is a principal, here is the principal role of PET CT. Here all the PET CT generally are whole body scans, and we get comprehensive staging here. It is single most effective way of staging tumor, where T staging can be like tumor staging can be done with the contrast CT, and nodal and distant metastatic staging PET is good. PET has a higher sensitivity and specificity for this nodal staging than any other modality. The conventional staging with different modalities is like this story of elephant seen by 5 blind, different 5 blind persons. They will have different impression about it. Different modalities like regional CT, then X-ray chest, USG abdomen, bone scan, HRCT. Instead of that, one PET CT will give you complete comprehensive way of staging. So advantage for PET for staging in this slide you can see. It is a whole body imaging, as I told you earlier. Then equivocal findings on CT are better characterized with the PET. For EM staging it is superior, and sensitivity for myelometastasis is next only to MRI. For nodal staging again accuracy is more. It is not just based on the size of the size criteria, but even the sub-centimeter sized, if they are showing a high activity, yes, they can be metastatic. For example, CA breast patient presented with CA left breast lump, and here on this scan you can see there is a lesion in left breast, and regional nodes like left axillary nodes are lighting up. So this is a loco-regional disease on PET scan. There were no distant metastasis. While this another patient where the primary lesion is in the right breast, which is involving overlying skin, so it is a T4 lesion, and there are axillary nodal lesions and multiple mediastinal as well as skeletal lesions, mediastinal nodes as well as skeletal lesions. So this is a stage 4 CA breast. In this next slide, lymphoma staging, like different stages, different patients scans you can see here. The first image is stage 2 lymphoma, where the disease, we can see the hypermetabolic nodes are predominantly in the supradiaphragmatic region, while in the second image you can see it is a stage 3 yes, where the nodes on both sides of diaphragm are involved and spleen is involved, while the last image is showing multiple skeletal involvement as well, suggesting stage 4 lymphoma. Now another important indications for PET-CT is assessment of treatment response. For example, this is a patient of germ cell tumor of left testis where orchidectomy was done, and the retroperitoneal lymphadenopathy was there. So you can see the previous scan, compared to the previous scan, the metabolic activity has significantly reduced. It has almost disappeared, though the CT scan is showing residual nodal lesions still in the retroperitoneum, but they are not showing activity. So that suggests it is a good response, but though the nodal lesions are still persistent on CT scan, metabolic response is good. This is another patient of CA lung where mediastinal and supraclavicular nodes were there and pleural deposits are there on the baseline scan, the first image here. And on chemotherapy, sequential PET-CT scans were done to look for the response to therapy. If after 2 or 3 cycles of chemotherapy, if response is good, then the further chemotherapy will be continued in next cycles, and we can see the response here. This is another patient of CA tongue where the scan was advised after chemoradiation. On PET CT scan, on MRI there were the equivocal changes in left side of tongue. On PET scan we can see high metabolic activity suggestive of recurrent disease. So this is again CA lung with brain metastasis patient where PET CT was followed with different lines of chemotherapies and different drugs, where the first 4 scans they are not showing much response, but after particular crizotinib drug it is showing very good response. So here which drug is better we can assess with the PET scan. So I'll go to the next part of it. So we can use PET CT to detect early recurrence particularly like in this patient, CA ovary patient. In this the CA 125 level started rising and PET CT is advised to detect any recurrent disease. Here on PET scan you can see there are few deposits in pelvis which are difficult to pick up on CT scan because of relatively less lesion to background ratio, but on PET scan they are lighting up and they can be easily picked up on the PET CT. PET CT can also be used for radiation therapy planning, where in this case for the CA lung patient where the CT scan has a large area of abnormality. You can see here the blue ROI region showing large area of in the left lower lobe, while PET is showing the perihilar is the basically active tumor, and while the peripheral portion in the left lower lobe is just collapse and it is not a disease. So we can target only the active lesion here on the PET CT images, and here the metabolic information of PET from PET allows differentiation between tumor versus atelectasis. Again, one of the common indications for PET scan is to find the unknown primary. For example, this patient here presented with a bilateral lymphadenopathy where the FNAC from the cervical nodes was positive for malignant cells, and PET scan was advised to detect the primary. Here we can see the primary clearly in the nasopharynx region. So for primary detection, PET CT has a sensitivity of around 50, it can go up to 57% as per this paper, where the anatomic versus compared to anatomical imaging, where the detection rate for primary will be around 20 to 27%. So which malignancies PET CT will be most useful for? Lymphoma, it is used very commonly for lymphoma staging as well as for to assess the treatment response. Then lung cancers, colorectal malignancies, melanomas, esophageal malignancy, breast carcinomas, head and neck malignancies, thyroid carcinomas, well differentiated thyroid carcinomas once they become negative on the iodine scan, PET scan can be used. Then gynecological malignancies like ovarian, endometrial and cervical cancers. We'll talk about the false positives, the limitations of PET CT. FDG is basically, it targets the metabolism for its detection. So it is not cancer specific. It will accumulate in any areas of high rates of metabolism and glycolysis. Therefore, increased FDG uptake can be expected at sites of infection, inflammation such as tuberculosis, or sites of active tissue repair after surgery. So these sites we can get false positives. For example, this patient, 50-year female, presented with multiple hypermetabolic, showing multiple hypermetabolic lesions in hepatic and lung lesions. But the biopsy, we thought it could be a metastatic disease, but the biopsy turned out to be granulomatous etiology. So positive findings on PET, we have to correlate with the clinical and histopathological findings. False negatives also can be there. Like if tumor is too small, PET CT sensitivity is It used to be 5 to 7 mm. With the new scanners, we are now that resolution, it came down. We can do detect 3 to 4 mm lesions as well. The low metabolic activity tumors also can be false negative on PET-CT, such as mucinous carcinoma, low-grade sarcomas, or CA prostate, or neuroendocrine tumors, hepatocellular carcinoma, or renal cell carcinoma. These can be false negatives on PET scan. For example, this patient here showing enhancing lesion in right kidney, which is not concentrating FDG. So it is a RCC but not concentrating FDG. I will talk about in short about 2 new radiopharmaceuticals like we can use instead of FDG, where FDG has low sensitivity. Like in neuroendocrine tumors, we are using now gallium labeled Dotanoc Dotanoc, and in prostate carcinoma we are using gallium labeled PSMA. So in neuroendocrine tumors, this Dotanoc, it targets somatostatin receptors, and it is useful in neuroendocrine tumors such as carcinoids, paragangliomas, pheochromocytomas, or small cell lung cancers. It has very high sensitivity and it goes up to 93%, and specificity as well, high specificity. So this is a case of 71-year male presented with chronic diarrhea. Gallium Dotanoc was advised to rule out any neuroendocrine tumor such as VIPoma. We are seeing lesion in first part of duodenum, which is very small lesion, difficult to pick up on the earlier CT scans. Patient had earlier CT scans as well, but it was difficult to pick up on CT scans. Retrospectively, yes, we can see their lesion, but so on Dotanoc scan, it is high intensely Dotanoc avid lesion, and we can easily pick up on gallium Dotanoc scan. Next is gallium 68 PSMA scan for prostate carcinoma. It is basically, it targets prostate specific membrane antigen on prostate cancer cells, where it is expression will be high on the prostate cancer cells. So we get high lesion to background ratio with this, and that's why the high specificity for prostatic carcinoma. These are 3 different patients with where gallium PSMA scan. First image shows the only focal uptake in the prostate, where it is localized to prostate, while the second image shows prostatic lesion as well as the prostatic PSMA avid nodes in the pelvis. So it is a loco-regional disease, while third image you can see the extensive skeletal metastasis. So to summarize, how PET-CT is useful in oncology. Its main role is in staging. The staging can be done with PET-CT with higher accuracy than conventional imaging. PET-CT changes management in approximately 36% of patients as per literature. To assess treatment response early, again PET-CT can be very helpful. To detect recurrent disease early, when the tumor markers are rising, the PET-CT scan can be used. Then PET-CT also can be used to characterize lesions which are difficult to biopsy on CT scan or a conventional radiological imaging. PET-CT also can be used to detect unknown primary. New radiopharmaceuticals such as gallium 68 Dotanoc are helpful in neuroendocrine tumor detection and staging. Again, gallium 68 PSMA for prostatic carcinoma we can use. Thank you.
Thanks a lot, sir. We have one question for you. How to differentiate between primary and secondary lesion involving the spine?
Yeah, can you hear me?
Yes, sir, you're audible.
Yeah, right. So it is we get hypermetabolic lesions in like if some spine lesion is there, and PET-CT is many times ordered to look for whether it is metastatic lesion and to look for primary pathology elsewhere in the body. So it may not be always possible to say it is a primary and it is or it is a secondary. but looking at overall picture, looking at overall body scan and looking at the clinical picture, we can decide probably this is this is a primary pathology, and the pattern of the spread, like prostate carcinoma, it starts from prostate and usually have a vertebral met. So we can have that clinical data, and accordingly we can find out, we say it is a metastatic lesion or primary pathology.
Thank you, sir. Are there any other questions for Dr. Amol? Oh, there are no more questions. Thank you so much, sir.
Yeah.
And this brings us to the final presentation of this afternoon. This is by Dr. Varsha, who is a consultant in pain management, and she'll be presenting on cancer pain management and palliative care.
Good afternoon, everyone. I would like to thank the organizing committee of Ruby Hall Clinic for inviting me to deliver the talk on cancer pain management and palliative care. Let us see how the difference it makes when we come to pain and palliative care in the cancer pain. Roadmap. The inclusion in my topic will be magnitude of problem, overview of cancer pain, opioids, which is considered as gold standard in the treatment, pain interventions, total pain management concept, then palliative care, which is the need of an hour, interdisciplinary team approach, barriers in the implementation, national policy making for palliative care, take home message and summary. So pain and palliative care, which is an emerging specialty worldwide, especially third world countries. As per WHO estimate, more than 15 million people in 2020 are in need of pain and palliative care. The pain prevalence ranges from 64% to 82% in all cancer patients in all stages of cancer disease, right from the diagnosis, terminal phase, on anti-cancer treatment and curative treatment. Every year, an estimated 40 million people are in need of palliative care. 78%, which is very significant figure, are living in low and middle income countries like ours. But only about 14% of people are currently receiving it. So the global need of palliative care will continue to grow as a result of aging population, increasing life expectancy and rising burden of diseases. But the cancer pain remains underreported, underrecognized and untreated. Now we'll go to next slide. Common symptoms in cancer pain, as we all know, all like anorexia, constipation, nausea are the symptoms patient presents with in cancer disease. But pain has been reported the commonest symptom which brings the patient to the doctor. Let's see the etiology of pain in cancer. It could be disease related like infiltration of disease tissues, nerve compression, spread in the bone, muscles, lymphedema and raised intracranial pressure like neural tumors. Some comorbidities in the patients which can be coexisting already like low backache, arthralgia, angina or history of trauma. Treatment related like surgery, radiation or chemotherapy. Debility related problems like pressure sore, constipation or bladder spasm can also give rise to cancer pain. So which type of patients can be treated for pain management? All patients being treated are from the stages of all cancer diseases, like from the time of diagnosis, post-surgery pain, pain in the cancer recurrence, metastatic diseases, palliative chemo, radiotherapy or terminally ill patients. So the important point to be considered here is pain management can be done in every stage of cancer, right from diagnosis throughout the treatment till palliative care. This is the WHO ladder recommended for cancer pain management, a stepwise approach. This is revised ladder which has included step 4 in the recent revision that includes interventional pain management. The most important aspect to be considered here is medicine to be given by the mouth, by the clock, by the ladder approach, and it has to be individualized as per the need of the patient, disease stage and progression of the disease. Along with adjuvants, it forms the basis of treatment. So opioids, As we all know, this is the basic classification of opioids: pure agonist, partial agonist, mixed agonist, antagonist and antagonist. You can find this classification and drugs everywhere. The point to be considered here is these are the mixed antagonists like pentazocine, butorphanol and nalbuphine, which has got ceiling effect for analgesia. So if they are used with pure agonists like tramadol or morphine, they can precipitate acute pain and opioid withdrawal symptoms. So one should keep in mind, especially while prescribing two drugs of the same group. Then there are few indications like we have seen in WHO ladder: mild pain, moderate pain, severe pain. For mild pain, we can start with basic drugs like paracetamol, non-steroidal anti-inflammatory drugs. When it is moderate pain, weak opioids like tramadol, tapentadol or even low-dose morphine can be prescribed. For severe pain, we have to start pure agonist like morphine, and when it is severe pain, we have to start with IV dosages. They can be titrated over the period of 10 to 15 minutes, and looking after the side effect and pain relief, we can escalate the dose. And once we reach the total dose, we can divide it into 24 hours dosages and then shift the patient on sustained release product like controlled release morphine. So it improves patient compliance and quality of life. There is something called as breakthrough pain seen in 20 to 80% of patient, which is the pain in addition to otherwise medically stable pain, controlled pain with regular doses. For this pain, we have to prescribe the same medicine, which is almost 1/10 of the dose as and when needed. The pain is sudden onset, acute and happens with the movement. So the extra dose of same medication works, but if we are needing 2 to 4 extra doses in 24 hours, we have to increase the routine scheduled dose as per the requirement. After this, quick onset and offset preparations like oral transmucosal fentanyl in the form of lollipop or nasal spray or inhalers are also available. Transdermal fentanyl patches, which we all are aware of, are used in cancer pain management, but the point to remember here is they are very slow onset, like 12 to 18 hours. So they are not useful for breakthrough or acute onset pain. Coming to opioids, we all are aware of side effect, but that should not restrain us from giving opioids. As we say in pain practice, the hand which prescribes morphine should also prescribe the drug for constipation or laxative. We all know constipation is the most common side effect which can be easily dealt with stimulant or osmotic laxatives. Then coming to dysphoria, confusion or giddiness, we can lower the opioid dose. Adequate hydration for renal clearance of the drug is to be suggested. Changing the opioid could be option, or adding small dose of neuroleptic drugs. Pruritus, urticaria can be dealt with antihistaminics. Tolerance to analgesia can be overcome with change of dose or opioid rotation, and physical dependence, addiction, though they are not very commonly seen in our patients, should be kept in mind. Opioid tolerance, hyperalgesia, dependence, these are the terms which should be known by every physician while dealing with opioid prescriptions. Like we have said in WHO ladder for pain management, there is introduction of 4th step of ladder. Invasive techniques like interventions in terms of nerve blocks or neurolysis with phenol, alcohol or radio frequency are the advanced techniques. These help in breakthrough acute severe pain, or when patient presents in very acute pain, we can go by the reverse approach of management. Rather than treating by 1, step 2 or step 3, we can directly undergo interventions with neurolytic techniques and then stabilize the patient depending on mild, moderate or severe pain on the drug management. This is the list of commonly performed interventions in cancer pain. For head and neck, we can go for sphenopalatine or stellate ganglion block, thoracic block for CA lung patient, splanchnic nerve or celiac plexus block, lumbar sympathectomy, superior hypogastric or inferior hypogastric for all abdominal or pelvic pains, ganglion impar block for urogynecology or perineal pain. Targeted nerve blocks can be given for restricted area of pain management. Continuous epidural catheter for chest or abdominal or lower limb pains are very useful in cancer. Again, this is something new. Central desensitization with the help of IV infusion of lignocaine or ketamine can help in patients with intractable pain. Obviously, it is to be carried out in ICU and monitored care. Vertebroplasty for localized single vertebral involvement in metastatic diseases, and advanced treatment like intrathecal pumps or spinal cord stimulators can be advised. Then coming to next slide, these are the adjuvant analgesics in cancer. They are very important to reduce the side effects of the main drugs like opioids, and also take care of other symptoms which patient experience in cancer. So the target is socially and economically productive life, patient compliance to treatment, and aim for a pain score less than 3 or 4 out of 10. These drugs can be anticonvulsant, antidepressants, corticosteroids, bisphosphonate, ketamine as we have seen the infusion, and some of the anesthetic anti-anxiolytic. So in this slide we can see the concept of total pain management. Along with drug treatment, there are so many non-physical factors contributing to pain which we have to deal with, like psychological factors, anxiety, depression, social factors which involves family estrangement, dependency, social burden as well as economic burden, spiritual or existential factors. There could be loss of meaning in life or fear of death or feeling of usefulness when patient is suffering through terrible cancer pain. They can be definitely dealt with alternative strategies. So each of these issues must be addressed to manage the pain. As we can see the pain palette in this diagram, pain is a multifactorial origin. So should be the treatment in terms of multidisciplinary or total pain management. Coming to the next slide, we will see about the palliative care definition in this slide. So palliative care is an approach that improves the quality of life of patients and their families which are facing problems associated with life-threatening illness like cancer in this case, through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain as well as other problems which could be physical, psychosocial and spiritual. Though it looks very extensive, in subsequent slides we can see what is the meaning of this definition. Here we are seeing the palliative care principle. The palliative care provides relief from pain and other distressing symptoms. It affirms the life and regards dying as a normal process rather than regretting about it. Palliative care neither intends to hasten or postpone the death. It integrates the psychological and spiritual aspects of patient care. It offers a support system to help patients live as actively as possible until death, as well as support system to help the family to cope up during the patient illness and after care during their own bereavement. It helps them in ethical decision making, and it is the multidisciplinary team approach. The ultimate goal or main goal of palliative care is to improve quality of life. So coming to essential components of palliative medicine in this slide, as we can see in the central triangle, hope and honesty. Palliative care doesn't mean giving the patient false hope, or the expectation should not be unrealistic. So the honest opinion about the disease status and prognosis forms the foundation in palliative medicine. Of course, it involves symptom control for the patient, psychological support to patient as well as family caregivers, and with the help of multidisciplinary team approach. So how it is carried out, we can see in the next slide. These are the components dealt in palliative care. Like physical, we have to deal with the symptoms like pain, fatigue, dyspnea, anorexia, nausea, delirium. The emotional components which patient faces like anxiety, depression, coping, denial or adjustment disorders. Social issues with the help of family caregivers can be dealt with, relationship or living situations. Spiritual aspect, hope, meaning to life, dignity of the patient. Patient's faith and religious concept should be addressed. And information, the right information about prognosis or illness, understanding about treatment, risk, benefit, advanced care plan as well as home care. You can see the interdisciplinary team. Here in the hospital, home as well as palliative center, we have to have multidisciplinary approach with the help of interdisciplinary team. It consists of physician who could be primary care physician or onco surgery specialist, nurses working in the department of curative as well as palliative center, social workers, physiotherapists, volunteers, clinical psychologists, pharmacists, counselors, caregivers, and not to forget pain specialists who will take care and alleviate the symptoms related to pain which is from the cancer origin or treatment related. This can be carried out at every place right from home, palliative center and hospital. So here in this next slide we can see the old model of palliative care and below is the updated or recent model of palliative care. In the old school of thought, initially there was only disease modifying or curative treatment, and you can see palliative care in the green, or it used to be called as hospice care, which comes at the end of life when the patient or doctor feels it is the end stage of the disease and now nothing can be done, there is no cure from the disease. They used to be referred for palliative care or hospice care till the death. But revised integrated palliative care program helps patient right from the diagnosis of disease. Like in below diagram we can see in the initial stages disease modifying treatment forms the bigger part of the patient management and palliative care takes over right from the beginning. Then as the illness progresses, disease modifying or curative treatment becomes lesser in intensity and palliative care takes over. At end of life, that forms the mainstay of treatment, and for family and caregivers it can be extended as bereavement care even after death of the patient. So coming to this very important point which we all should be aware as barriers to palliative medicine, lack of awareness or education of patient and family is the main hurdle in palliative medicine. When patients come to us, they say that we are suffering from a year or two, we have undergone so many treatment, but till now no one has explained us about pain management or something like this, symptom control, or these options are available. So my request, sincere request to everyone, that please be aware of this specialty and include or incorporate our patient care right from the beginning. Again, lack of trained professional like physicians or nursing care, neglect of palliative care and hospice in policy making at hospital level as well as government level, lack of funding, unavailability of essential medicines, especially opioids, and many social or cultural issues like social stigma. So as we can see in this diagram, presently as we can see there are two different water flows, we can see different colors of water. We have not yet incorporated pain and palliative care along with the main curative treatment for cancer pain. The future should be like this. You can see green island as cohorts of the patient, and wherever and whenever needed, as we can see these small water currents are flowing through the islands. Like that we can provide curative care, pain management or palliative care wherever and whenever needed. This should be the primary goal of this practice. Looking for the improvement in palliative care at national policy level, we can improve professional practices, standard of practice to involve certain palliative interventions, specialty areas for nursing training, service availability, core requirement for facility and program accreditation, reframe the good palliative care as a prevention or promotion to the services, education. We have to include the curriculum in undergrad and postgrad in all disciplines of medical fraternity, and there should be continuing education like CMEs. Public awareness remains the mainstay of every medical specialty to improve the death culture and empower in decision making. So in summary, there is high prevalence of pain associated with cancer in the present scenario. The pain could be mixed type and it varies, especially when it comes to cancer, depending on stages, it varies in temporal association. WHO ladder still holds the good standard of practice. Opioids are the mainstay of treatment. Of course, we have to take care of side effects, titration, opioid rotation and monitor them. Invasive techniques and interventions are to be considered at the earlier stages. Adjuvants and non-pharmacotherapy or alternative therapies have got definitely good stay in the treatment of cancer pain. Palliative care is to be incorporated right from the beginning. Pain relief is the basic human right and it should be respected for every patient. So pain management remains the ethical responsibility of every health provider. So the take home message from this topic should be, we can treat often, cure sometimes, but comfort should be the always ultimate goal of every health provided for every patient. Thank you.
Thank you so much, ma'am. Do we have any questions for Dr. Varsha? I believe there are no questions. So this brings us to the end of the event. Thank you so much to all the participants who've taken your time off on a Saturday morning and afternoon to understand the basics of cancer and cancer management. I would like to thank our CEO, Mr. Bomi Bort, and our COO, Dr. Manisha Karmarkar, for giving us a platform, our organizers, and all the chairpersons and all of the faculty who have taken their time to help organize this event, and also the chairperson of the cancer building, Dr. Ashok Bhange, for giving us the platform to hold such an event. Thank you so much, and we hope you have a great weekend.